on air. So I'm going to mute. I am going to mute all of you. People who want to speak can unmute yourself and speak.
Sure.
Good afternoon, everyone. It is a proud privilege for me to host this meeting. We have a brilliant team of leaders of Chennai City branch of the ASI who have been collaborating, working hard for the last 2-3 weeks to give us such a brilliant academic program. And I also warmly welcome the guests from the National IASO, Professor Arnab Gupta sir from Kolkata, the President of the IASO, the Indian Association of Surgical Oncology. And we have Professor Sharad Desai, the National Secretary of the Indian Association of Surgical Oncology. Friends, for your information, IASO is a sister concern or a sister body of the National ASI. They are doing a lot of wonderful work in part of the academics. The NatCon is very popular with IASO. So with that few words, now I hand over the proceedings to the convener, Dr. Kannan sir.
Thank you, Chairman of Chennai City ASI. First of all, I thank the IASO, the President, Secretary, and as well the EC members for accepting our invitation for the joint program of IASO and as well as Chennai City ASI chapter. This is a gastric cancer update program, so for which I formally welcome and ask our Secretary of Chennai City branch, Dr. Uttara Kumar, to give the Secretary address. Dr. Uttara Kumar, please.
Good afternoon to everyone. On behalf of ASI Chennai City branch and ISO, invite all the senior faculties, ASI and ISO members and students to this academic program, CA Stomach Update 2020. This is an integrated collaboration program with ISO that makes academic forum in high standard. It's really indeed. This is proud and privilege to me for a warm welcome to Professor Arnab Gupta sir, President ISO from Bombay. And yesterday I'm very happy to invite Professor Dabis Chawla, Aga Khan University, Karachi, Pakistan. Welcome sir, I take this opportunity to invite Dr. Ebenezer Benson, Chairman Tamil Nadu ASI, and Dr. Chandrasekhar GC, National ASI, to this program. Today is a galaxy of faculties, Dr. Pramanayagam, Apollo Hospital, Dr. Zahir Nabi, Hyderabad, Dr. P.K. Reddy sir, Apollo Hospital, Dr. Sudipta Savankumar. So welcome you sir, welcome all sir. And we have eminent surgeons as a panelist, Professor Ramesh Adhanari, Professor Dr. Ramakrishnan, Dr. Vikas Mahajan, Dr. Inian Samarasam, Dr. Rajiv, Dr. Manikandan, Dr. Sharad Desai. So welcome you all sir. And finally, before hand over this program to the condensers, I invite all the delegates, all the members to these programs. Thank you for giving this opportunity. Now I am proud to address regarding the academic activity. So far within the shortest period, we have been conducted 5 programs. And also among these programs, we associated with IATCC, that is Indian Association of Traumatology and Critical Care, and ACRCA regarding the topic of abdominal trauma and pilonidal sinus. So and every week we have been conducted PG clinics, so regularly. So all the benefited postgraduate extremely up to date have the knowledge, and all the delegates and the students can be subscribed in YouTube, Facebook, and ASI Chennai webinar in order to know academic activities of ASI Chennai City. And in the month of April, the ASI Chennai City branch contributions in the COVID crisis, we hand over the PP kit, gloves, and sanitizer worth of 1 lakh rupees to various medical colleges, Madras Medical College, the Stanley Medical College, and KMC, the Kilpauk Medical College, worth of 1 lakh. This is under the leadership of past chairman, Dr. Professor Vehanandan. We received an appreciation letter from Honorable Health Minister, Dr. Vijay Bhaskar. So for our gesture and generosity. Thank you, sir. Thank you.
Thank you, Dr. Uttara Kumar. Now I ask our chairman, who is brain behind this program, Dr. Kanagavel, to give the chairman's address.
Thank you, Dr. Kannan. Good afternoon, everyone. Chennai ASI is taking baby steps towards stronger academics. Thank you, all the EC members and my dear good friends, and all the senior faculty for immediately accepting our, I would say, many tough requests to you. In fact, I should put on record the efforts taken by the IASO for doing it as a collaborative program. Normally, all these things take some time, but then we had a very late request, and IAS was kind enough to give the acceptance and endorsement as a collaborative program. And in fact, we have one important guest from the Pakistan Surgical Society. We have Professor Tabish Chawla. Professor Tabish Chawla is the Chief of General Surgery from Aga Khan University, Pakistan. So he was kind enough when we requested to contribute for this important program. So Chennai SI is now regional, national, and we are trying to go with international faculty also. I thank our VC member, Dr. Chandrasekhar, our secretary, dynamic secretary, Dr. Uttatma sir, Dr. R. Kannan, treasurer, my director of surgical studies, Professor Vivekananda Subramanianathan, for carving out academics. And then all of us have been helpful for creating a more sound academic program. And I also thank all the faculty who are going to contribute for the development of surgical sciences today evening in the field of gastric cancer. I take privilege in warmly welcoming the president of the IAS World, Professor Arnab Gupta sir, and our chairman of the Tamil Nadu ASI, Dr. J.W. Ibnesh Bensam, who was the immediate past secretary of the National ASI, for the honor of inaugurating the program. May I request Professor Arnab Gupta sir to give his welcome remarks and officially declare open jointly with Dr. Ibnesh Bensam. Can I request Professor Arnab Gupta sir? Over to you, sir.
Yeah, good afternoon, everybody. First of all, I must thank ASI Chennai for giving this opportunity to be a part of this wonderful program. Just a small correction, I'm not from Mumbai, I'm from Kolkata, which was the British capital once upon a time.
Okay.
So a small correction, and it's always an honor to partner with an academic society, and you've got a very good, vibrant chapter, and you've got all the good faculties there. So it's basically an honor to have this gastric cancer update jointly. It's one of the commonest cancers. It's the second common GI cancer. So it's important that we discuss about, and I understand it's more common in South India, more than what we see in Eastern India or North India. Is that right?
Perfect.
Gastric cancer in South India is much more common.
Perfect. After
about the corona, what we had been discussing, what we had been discussing, yes, during the corona, it has been a disaster. You had been spending a lot of money for many things which were not required before. And we also contributed, 2 lakhs of rupees to Prime Minister. In addition, we have formed certain guidelines for cancer management, and that's on our website. If you look at the ISO website, it's there. It's slightly old maybe when we created, but now it's still valid to a certain extent because we know what to do, what not to do during the COVID. About the ISO, I don't know how many of you know, it's a chapter which was formed in 1977 by a team of hardcore surgical oncologists. Dr. Jaswala, the director of TMH at that time, was one of them, obviously. He was the first founder president. And from there, from a handful of people, we got almost 2,000 surgical oncologists on board. I think we could do with more. For that, I think it's a request from all of us that those who are doing surgical oncology, not only general surgery, but also gynae, urology, orthopedics, ENT, those who are doing part of your work as cancer surgery, you're all welcome to be a member of ISO. The cost is 8,500, yes, but then I think the privileges that you get, especially the postgraduates, the fellowships that are offered, people can go to US, to Europe, and different parts of India as well as a part of the fellowship. That's all covered by ISO. We got our own journal. There's a lot of academic activity going on. So, we are also doing a lot of webinars every month. And we also have partnered with SSO, Surgical Society of Oncology in the US. You have heard about ESSO, it's an European Society of Surgical Oncology. So we are partnered with them as well. So there's a lot of academic activities going on between these three societies. And we share our guidelines, we discuss about difficult cases. So all of you must be dealing with cancer in your practice. So I think it's important that you be a part of this society as well. So I think without much of ado, there's a lot on your list. I'll declare, along with Dr. Ibnesh, this conference open. And I would hand over to this microphone to very able Dr. Ebenesh, the past secretary of ASI. Thank you.
Thank you, sir. Thank you for your kind words. Dr. Ebnes, please.
Yeah.
Chairman of TNSI.
Am I audible?
Yes, sir. Yes, sir. It's very clear.
Respected President of IASO, Dr. Arnav Gupta, Chairman of the Chennai City Branch, Dr. M. Kanagavel, Vice Chairman and my close brother and an esteemed Executive Committee member, Dr. G. Chandrasekhar, Secretary, Dr. Uttarakumar, Treasurer Kannan, and the Director of Surgical Studies, Vivekanandan Subramanianathan, and office bearers of the IASO and Chennai City Branch, and the esteemed colleagues who are connected with us on Zoom. I deem it a great privilege and honor to inaugurate this gastric cancer update. As you know, in ASI, we have two organizations, the chapters and sections. Chapters are according to the domicile of each and every state. We have chapters. In states, in chapters, it is the sections are organ specific. We have 12 sections in ASI, of which IASO, Indian Association of Surgical Oncology, is one of the largest of the sections. And Tamil Nadu chapter is also the largest of the chapters. So it is really great that we have the largest chapter, largest section, as well as the largest city branch. The city branch is also the largest city branch in the whole nation is also Chennai, as it has more than 1,700, 1,800 members. So it is the largest of all coming together and organizing this gastric cancer update. And for the past 2 months, the Chennai ASI is in a geared up phase, conducting many meetings, very useful to the members across the country. And they have partnered with the Association of Colorectal Surgeons of India, as well as the Indian Association of Trauma and Critical Care also in conducting meetings. And I congratulate the efforts of the chairman, Dr. M. Kanagavel, the Chandrasekhar, Kannan, Uttarakumar, and for the united endeavors to take this organization to greater height. The topic gastric cancer is very useful and a must know for every surgeon. And it is worthwhile that the Chennai City Branch has taken this topic as a symposium, which shall be discussed from surgeons as well as general surgeons and the onco surgeons' perspective. I'm really happy to see a galaxy of world-renowned teachers being a part of this update. Thanks and best wishes to all of the participants. And I once again thank the office bearers of this branch to asking me to inaugurate the event along with the president of ISO. Hats off to you, my brother. I wish this event all the success. Long live ASI. Jai Hind.
Thank you.
Thank you, sir. Thank you for your kind words. Once again, I thank the Professor Dr. Arnav Gupta, President of IASO, and as well as Dr. J.W. Ebenesh Benson, Chairman, TNASI, for inaugurating our joint program. Now, let us go to the scientific program proper. The first topic, changing etiology of gastric cancer. None other than our Dr. P. Pramanayagam. He is consultant surgical gastroenterologist in the Department of Gastroenterology Hospital in Chennai. Dr. Pramanayagam has a large number of research papers, review articles, abstracts, and book chapters to his name as first author or co-author, published in peer-reviewed journals, books, etc. And also, he got the ISG Cystopic Award in 49th Annual Conference of the Indian Society of Gastroenterology held at New Delhi in 2008. And we know very well Dr. Pramanayagam is known for all his research work and as well as academic activities. Now it is open to Dr. Pramanayagam for the topic of changing etiology of gastric cancer.
Good afternoon to all. I thank the organizing committee for providing me with this opportunity to address this. I hope my screen is shared.
Yeah, clear.
Good afternoon, sir. Thank you very much for giving me this wonderful introduction, and I'm really indebted and I'm full of gratitude to Dr. Kanagavel and all the organizing committee for providing me with this opportunity. As I learn, I think this is one of the largest societies, and it's a proud privilege for me to be addressing this as an inaugural address from this for this update on gastric cancer. I've taken a little liberty in changing the topic by introducing one more word, changing etiopathogenesis of gastric cancer. And the next 15-20 minutes, let me go through as to what we have. So we will go through this in the following broad outline. Look at the epidemiology, a little bit about the risk factors and what was the traditional classification and what we understand till now in the form of pathogenesis of gastric cancer, and what is new, what has happened in the last 5-6 years that has changed about the classification of gastric cancer. There are some newer molecular classification that has come in, and what is its prognostic significance and how it is going to help in future. Hopefully it will help in future in finding good molecular targets. So let me go through this. And generally, what we assume is that what we see is that the gastric cancer incidence is gradually coming down. Even the last couple of decades, you find that the overall gastric cancer incidence has gradually come down across the races. But still, it remains the fifth most common cancer worldwide, incident cancer worldwide. And there seems to be a specific geographical distribution in its most often, predominantly it seems to be in East Asia, China, Russia, and part of South America, Venezuela, and Alaska. So the rest, India, even though we see a good amount of gastric cancers in our daily practice, but it still falls under a low prevalence group as compared to the high prevalence areas. And it's the third leading cause of cancer-related mortality as yet, and the age standardized mortality rates almost reflect the same age standardized incidence rates across the world. Over the last 3 decades, if you find there's been some small incremental improvement in the survival rate for gastric cancer, but the main problem that we think we face in India is that most often we find patients who come in pretty late, who are advanced in disease, who are advanced stages in disease. So probably the prognosis is not all that great. But a lot of stride has been made in the East, where they are doing regular screening programs. When they identified lesions in the T1 stage, they're able to offer very good 5-year survival. So coming to the risk factors for gastric cancer, we know that H. pylori is the most important risk factor. In 1983, it was diagnosed, and subsequently within about 15 years, it was classified as a class 1 carcinogen by WHO, and it accounts for more than 50 to 60% of the gastric cancer, and predominantly that's the reason for the non-cardiac gastric cancer. With improving sanitation, good good water resources, possibly the H. pylori infection may come down, but still the point prevalence increases with age. And but all those people who develop H. pylori infection do not develop cancer. So that must be something more than the bacteria alone. So there are some host of environmental factors and some host-related factors which also interact to increase the risk of gastric cancer. So if the environmental factors, again, salted food, smoking, particularly the nitrosamine compounds in the smoke, the tobacco, showing they increase the gastric cancer risk. We know these things. But the newer things that have come up is that Epstein-Barr virus, which has been associated with nasopharyngeal carcinomas and some lymphomas, are also known to contribute to about 5 to 10% of gastric cancer. And increasingly, iron deficiency seems to increase the H. pylori virulence, and that can cause gastric cancer. The traditional classification for gastric cancer has been based on either on the morphologic, if it is an early endoscopic classification, a lot from Japanese classifications. And for advanced one, we have the traditional Borman classification, which again, 4 types, which I think all of us are well aware of. Based on histology, we divide this into 4 different types: the tubular, papillary, mucinous, and signet cell ring carcinomas. Lawrence classification stands the test of time, in which we generally divide it into intestinal type, the diffuse type, and the mixed type. And the intestinal type is more common in the high-risk groups. And here, the malignant cells form a gland-like structure. On the other hand, in the diffuse cells, it's more common in the diffuse type. It's more common in the low-risk young people, and it tends to be more aggressive. And there is a group of things which won't fit in both, so that's called the mixed type. So this is good for a good pathological classification, but has very limited prognostic implication. So going down to the pathogenesis, we know that, since H. pylori is one of the commonest causes for gastric cancer, it is good for at least the postgraduates who will be part of this, to know that not everybody who's infected with H. pylori turns to a cancer. If you look at the progress of it, Most of them who have an acute infection go on to develop a chronic H. pylori infection, of which 15% will be only antral predominant gastritis, and this is the form which leads to duodenal ulcer. 80% of them are just a pan-gastritis, is non-atrophic initially, and about 5% are corpus predominant gastritis. Of these, again, 90% tend to have asymptomatic H. pylori infection. Of those with corpus predominant arthritis, about 1/4 develop intestinal metaplasia, and of these, about less than 10% develop dysplasia, and of these, only about 2% develop gastric cancer. So overall, given that we have a huge population, and in India, the H. pylori prevalence, as it increases with age, in about 6th or 7th decade, you find about 60%, 70% of the population have H. pylori prevalence. But still, the gastric cancer prevalence is comparatively less. And you clear the cumulative incidence with based on the initial histology. If you look at it and they follow for about 30 years, you find that the highest risk of gastric cancer is with dysplasia. They have dysplasia along on the background of an intestinal metaplasia. If it is a bland intestinal metaplasia, the risk is much less. It takes about 25 years for us to have about 40% incidence. This is the classical Coria's hypothesis, where they described how H. pylori leads to a gastric cancer. It's a stepwise progression from a normal epithelium to chronic gastritis, and this inflammatory milieu in the background of some environmental factors and some host factors, particularly some genetic polymorphisms, progress to a form of atrophic gastritis. In the stage of atrophic gastritis, the normal gastric lining then subsequently is replaced by an intestinal lining, which is a major change as a precursor to gastric cancer. Once this intestinal metaplasia occurs, a part of them develop dysplasia, and that progresses to gastric cancer. This is the classical cancer hypothesis proposed by Coria, which has been there for the last couple of decades. So what exactly are the genetic alterations that happen in gastric cancer? I will go through some basic cancer-related things before I move specifically to the gastric cancer, because most of the genetic things are just alphabets which won't make sense. So probably I'll spend about 5 minutes just explaining what the genetic pathways are. So here is a normal cell with a nucleus inside. So you have some cell membrane receptors, or the growth factor receptors, let us say, and there are some growth factors or hormones which, when they bind to these receptors, activate the intracellular pathways, which convey the second messengers, which actually go into the nucleus and then interact with the DNA to initiate them into a cell division. So there are multiple steps, like right from the growth factors, the growth factor receptors, the second messengers which go into the nucleus, and there are transcription factors. At each level, there can be genetic mutations which can increase the risk of gastric cancer. This is just an example that what we have just discussed. There's the growth factor, there is a receptor which gets activated. These are second messengers which go into the nucleus and then activate the cell proliferation pathways. The cell cycle also is important, that we have one mitotic phase, and then the other things are called as interphase, where the cell gets ready to multiply. So each step, the G1, the growth 1, or the synthetic phase and the growth 2 phase, each of them have a checkpoints. So at each point, if there are some self-regulatory mechanisms, if the DNA or the cellular contents are defective, then that can be stopped at that level. And P53, as we know, is called as a gatekeeper of the human genome. So it ties to any defective genes. It is cut short, that cell goes into apoptosis, and we don't find any genetic aberrations or mutations. But what happens in gastric cancer specifically? There are 4 major changes that happens in gastric cancer. One is a chromosomal instability. There are some somatic mutations. There are some epigenetic mechanisms which contribute, and microsatellite instability, which also contributes to the gastric cancer. So we'll go through that quickly. What do you mean by chromosomal instability? Generally, we have 46 chromosomes, 23 from each of our parents. So when they divide each of this into 2 cells, we need 46 in each. So it's a very balanced cell division. Sometimes there can be problems whereby one cell gets 3 copies of the same gene, or the other one gets left with 1. So that's called as an aneuploidy. Sometimes there can be unbalanced translocation of genes, whereby some part of it gets amplified and some have deletions. So these are called as where there are changes in the number of chromosomes or the structural pattern of chromosomes are called as chromosomal instability. There are other forms of changes called as somatic mutations, where these are point mutations in the genes. The most important one, the most common one in gastric cancer, is it involves the p53 gene. So there are many other point mutations which can affect the cell addition, cell motility, the Wnt signaling genes, and the tyrosine kinases, which increase the risk of mutant products. So they can involve any of the oncogenes, proto-oncogenes, or they can involve any of the tumor suppressor genes. Now, coming to microsatellite instability, I mean, there has been more and more interest on this in the field of colorectal cancer, but I think that is also finding more important in the setting of gastric cancer. What do you mean by microsatellite instability? So there are some repeat islands. When the replication occurs, sometimes there can be faulty insertion of new base pairs. But generally, when there is a good mismatch repair gene in progress, the next cycle itself that is repaired, and then it gets back to its original base pair configuration. But if there is a problem in this mismatch repair, then the additional inserted gene keeps growing on to the next progeny, and that leads to a genomic instability. So the most important genes which are involved in this mismatch repair are the MSH1, MSH2, MSH3, and MLH1. Either there can be mutations directly involving these genes, or there can be something called as epigenetic silencing. So the fourth thing that is important is the epigenetic mechanisms. Here, the particular genes are, there are no mutations in that genes which encode for the protein, but there are some upstream gene products which actually activate or initiate the transcription or the translation. So there may be some modifications in the form of DNA methylation or histone modification or interference, which block the post-transcriptional products or which can stop the initiation of translation. So these are the 3-4 mechanisms by which has more prominent pathways in gastric cancer. Now, based on these, we are coming to what we call as a newer classification that has come up in 2015, 14 and 15, molecular classification for gastric cancer. The Cancer Genome Atlas classification is from the US. So they have they took about 300 specimens of gastric cancer, and they did a plentiful arrays based on DNA, RNA, microRNAs, and they were able to classify the gastric cancers into 4 main types. One is the EBV type, other is a microsatellite instability, other is a genome stable, and a chromosomal instability type. Of this, EBV type constitute only about 8%, but they have extreme hypermethylation. What I mean was that the last one, the epigenetic changes that happen, there are multiple changes in the PDL1, that is the immune checkpoint pathway. In the microstat instability and the CIA, microstat instability is the one that I showed where you have mismatch repair problems. So they have the ones which have mutations in the mismatch repair genes. Genome stable ones are the ones which usually have a diffuse type based on their Lawrence classification. The problem is the mutations are here in the cell addition molecules, the CDHN1. So they are more likely to metastasize quickly, and they have a poor prognosis. The chromosomal instability ones are the ones where you have a lot of aneuploidy and genome amplifications and deletions. That's the one that we discussed first. They contribute to about 50% of all gastric cancers. The one drawback that they found with this TCGA classification was that there was not much prognostic significance associated with this. And at around the same time, the Asian Cancer Research Group involved from Singapore, the multiple sites from Asia, where they collected samples of gastric cancer, and they did genome-wide whole genome sequencing. And based on this, they were able to classify into 4 subdivisions: the microsite instability, the microsite stable with normal TP53 values, microsite stable with deletion of TP53, and the microsite stable with epidermal changes. So they also roughly correlate with what the TCGA classification is, but what you have to note here is that this classification also had prognostic implication, that microsite instability usually had the best prognosis, whereas the EMT pathway had the worst prognosis, and this EMT pathway has the one which is usually associated with the diffuse type of cancers. The other ones, the microsite stable, T53 intact, and the 353 mutant ones had intermediate prognosis. So if you look at the prognostic implications, we find that the MSI1 had the best 5-year survival as well. And if you look at the EMT component, they tend to have the worst 5-year survival. So what are the therapeutic implications of this newer classification? Do they help? Now we are moving into an era of personalized medicine. We have to try to look at specific markers from which we can prove. So here is a epidermal growth factor receptors HER2 receptor, which was identified as being more expressed in gastric cancers, and specific monoclonal antibodies have been approved for therapy for advanced and metastatic cancer. mTOR pathway, they have attempted with everolimus, but it was not very useful. But the VEGF inhibitors, ramucirumab, has been used as a second-line therapy for advanced cancers. Programmed cell death 1 ligand, this is called as an immunotherapy, where you can use it across cancers, but this has also been approved for therapy in gastric cancers, the pembrolizumab and nivolumab. These are newer personalized medicines which are in the anvil, which have been recently introduced for gastric cancer. So this roughly gives you a summary of what has happened in the last decade in gastric cancer. You find that in the initial part of this decade, we have VGF mutations which has occurred, then the HER2 amplification was occurred. Then you found important trials, the TOGA trial and the RIGARD trial and the KEYNOTE trial, which gave us important outlooks into the newer specific molecular agents which come up. So again, going back to this molecular classifications, though there are a lot of studies yet to come up, they are in the anvil where they are trying to use the information that they have gathered from the TCGA and the ACRG group. This is just one potential pathway where we find that if they are EBV predominant gastric cancers, the use of PD-L1 inhibitors might be useful. That the immunotherapy might be, checkpoint inhibitors may be used as a first-line therapy. If they are chromosomal unstable or genome stable, that is the diffuse type of gastric cancers, you may find a higher HER2 expression, and you may consider a HER2 inhibition. So this is the path in which your gastric cancer chemo or immunotherapy is going to come up in the next few years. And to summarize, gastric cancer remains a leading cause of cancer-related mortality. H. pylori is the main risk factor for gastric cancer. Korea's hypothesis stands the test of time, where we have stepwise progression noted in H. pylori-related gastric cancers, and host factors and environmental factors modulate the risk. We have looked at what are the various genetic factors which are involved in the formation of gastric cancer, and there are newer molecular classifications, one from the Cancer Genome Atlas group, another one the Asian Cancer Research Group, which gives us more inputs into the genetic alterations that have happened in gastric cancer. And hopefully this information will be carried over, and we'll have some more clinical trials which come up based on molecular targeted therapies and specific biomarkers which can be used in the gastric cancer management. And I thank you all for giving me this opportunity. I hope this was informative.
Thank you, Dr. Pranayam, for the elaboration of gastric cancer etiology. Here, I like to ask about the molecular targeted therapy.
Yes, sir.
So, what is in future regarding this molecular targeted therapy and as well as the biomarkers in the management of gastric cancer?
Right. Biomarkers, as of now, we still use only the HER2, which is easily available, but there will be hopefully more specific biomarkers that we look at for looking at the PD-L1. Right now, we are based on still limited to immunohistochemistry. And hopefully we will have in the next decade or so, we'll have whole wide genome sequencing, which should be available for us and a specific set of gene combinations, which will help us tailor our therapy further. But as of now, I think we are still in early steps in that area. But this has been only 5 years since this newer classification has come in. I think in the next decade or so, we'll be hearing more about it. And I would ask any of the other panelists also to comment, particularly surgeons or oncologists who are here, to elaborate more on this.
Regarding this H. pylori relation with the gastric cancer,
yes, sir.
Especially in South India, what is your personal experience? Because as a practicing physician, as we surgeons, invariably the question is, what about the relation between the H. pylori and as well as the gastric cancer? So what is your take-home message to the audience?
See, the interesting thing about H. pylori is that many times you may not find evidence of H. pylori at the time when we have advanced dysplasia or gastric cancer. So, but I mean, in India, I think H. pylori is still one of the leading causes for gastric cancer. And eradication as such in the eastern at least in Japan and other places, the insurance has already cleared and accepted it as a primary way of preventing gastric cancers. For the huge population like India, we still don't have such a huge volume of gastric cancer in relation to the population base, so it may not be a immediate treatment concerns, but I think, but we are no different. I think H. pylori is still the leading cause for gastric cancer.
Thank you. Thank you for your.
Thank you, sir.
Any other panelists? Any other questions? Dr. Kanagvel?
Yeah, Dr. Pirama, in fact, it was a lot of eye-opening points you shared with clear evidence. I have a totally different question.
Yes, sir.
With so much talked about aseptic disease and Helicobacter pylori towards carcinogenesis, all those things. I have a question. If in a case of diagnosed gastric cancer, at least in our series, we have close to 40 to 45% of them are HP positive. Of course, this is a GNSA method and the standard histopathology. I don't have evidence of talking about CAG or bacteria or anything. Do you advise, or does the current literature advise eradication of Helicobacter enhances the surveillance or enhances the effect of chemotherapy in the adjuvant phase?
Okay, so particularly, I think now with the advent of endoscopic therapies for gastric cancer, where it is minimally invasive, where they are able to carve out only one part of that part of the tumor where it is, that is going to be the next talk. I think Zahir will be addressing more to that. So in such a setting, I think it's one of the first line indications for H. pylori eradication. So if it has not been done already, I think we should think of eradicating H. pylori in people. But more and more, since if you are able to identify it early and we are only removing that lesion, I think it's well served that they have a H. pylori, anti-H. pylori treatment.
Thank you, Dr. Piramar. What is your take on in fact, as you rightly pointed out, the genome is being mapped. It is evident with the present translational science work which is happening. The Helicobacter is definitely altering the genetic makeup of the gastric cells. Apart from mere physical presence of the Helicobacter, it definitely affects the various cellular components, starting from adhesion, starting from signaling. It looks like Helicobacter works beyond the mere presence in the foveal or crypts or anything like that. So by mere eradication, are we only getting rid of the physical eradication, or the memories what has been left by Helicobacter in initiating the carcinogenesis? Do we have anything being looked upon to remove the genetic memory which the Helicobacter infection has laid behind the gastric cells?
Very, very pertinent question, sir. What they have identified, particularly in the Japan and other places, is that H. pylori eradication reduces the risk of gastric cancer if given early, that is before they have high-grade dysplasia or dysplastic changes. Once those dysplastic changes or genetic alterations are already set in, H. pylori eradication does not give that amount of survival benefit. So what it means is that there is some phase, a certain stage beyond which the genetic instability that has already set in probably has its own way of progressing. But H. pylori possibly initiates it, and the genes and the environmental factors, I think, take it further. So we are addressing one part of it, which we can address. There are some genetic changes which probably we cannot. There are non-modifiable risk factors which we cannot address. But I think H. pylori eradication, particularly in early phases, like before they form intestinal metaplasia, chronic gastritis, has been shown to decrease the risk of gastric cancer.
Thank you, sir. Thank you. Any other faculty in the Zoom or anyone would like to ask any question to Dr. Pirama?
So I'd like to make a comment, Professor Kanagvel.
Please
So,
welcome.
So this is regarding H. pylori therapy. Suppose if we don't detect H. pylori therapy, we have operated the patient for gastric cancer. What I believe is we have to take many factors into account. Many of these patients are on PPIs, and your detection rate of H. pylori may be significantly lower in these patients. So whatever, even if you don't find an H. pylori, I think H. pylori therapy is mandatory in these patients, because it takes hardly 2 weeks of H. pylori therapy, and the risk of metachronous malignancies may be reduced in these patients. So I believe H. pylori therapy for all who have been treated or operated for gastric cancers.
What phase do you advise therapy, Dr. Zahir? See, most of the time they come to us with a symptom, either to the physician or to the surgeon. When we do the endoscopy, at that time you advise the eradication, or after the completion, either an endotherapy or a surgical therapy. At what point of, because once we have the chemotherapy on, the cell cycle changes a lot. So there have been multiple publications addressing to this. This is the right time, this is the right time, this is the right time. But still the challenge is there is not very clear quotient or guideline which is coming, which has so far been available, at least to my knowledge, which says yes, helicobacter therapy eradication is mandatory in gastric established gastric cancer. What is your take on it?
So a 2 weeks therapy, either it is straight on once you diagnosed early or advanced whatever gastric cancer which has to be operated surgically, or anytime post operatively, starting whenever it permits according to the chemotherapeutic regimen and all. I think it should be given. If we see the chances of synchronous these metachronous malignancies, they start increasing after a while. So it's not that the patient is going to come back very soon with a metachronous malignancy, but then the only chance you have that you reduce the risk is by giving H. pylori therapy. Now, exactly the timing is not very well known, whether you should give straight on H. pylori therapy, whichever time is you need to have 2 weeks of H. pylori therapy. Either it's immediately post endoscopy that you see, and there is still some time, and the patient is definitely, it's an operable candidate. Of course, we are talking of operable candidates, not with metastatic disease, because I don't believe that metastatic disease is the fate is going to be changed with it. But in operable candidates, I think whatever time you is either pre-operatively or post-operatively, I think the key message is that they should receive H. pylori therapy.
In fact, I would like to share our experience in bleeding gastric cancers and bleeding duodenal cancers. We tried accumulating or associating intravenous Helicobacter therapy along with the conventional management. But we had say about 100 plus or 120 patients. But we don't really have a very statistically significant improvement on giving intravenous Helicobacter pylori eradication along with GA bleed management. Of course, ulcer bleed management, I'm not talking about the other bleeds. Maybe I think, as you rightly said, we need some more time and more larger studies to
Yeah.
light on it. Professor Chandramohan, sir, you would like to ask something? I could see you coming up. Yes.
Of course. I like to comment that, in a patient who has already diagnosed with cancer, and I don't think your priority is not to prevent cancer coming again. Rather, I think that the patient having a recurrence of the disease, the chance is much, much more. So if you like to do the H. pylori prevention, they are not the right kind of patients for you. I think you should be relying, this is a preventive modality, and when patients diagnosed with cancer, you are much more worried about the recurrence which is going to happen. And I don't insist or see any advantage in giving H. pylori treatment for this kind of patients. If you give prophylactically in a patient who are not diagnosed with cancer, I think then you have a role. And second to that, again, in Asian countries like Japan, they rely heavily on H. pylori prophylaxis. I think all my friends who are surgeons already received prophylaxis. But if you go to the West, I don't think that the kind of cancer is slightly different, and they don't advocate it. And so I think ours is a mixed bag of affairs. We have a H. pylori as an etiology, as well as the other kind of cancers, as rightly Peraman pointed out. So again, the utility of H. pylori prophylaxis in our population, I'm not very sure. But definitely not for a patient who is diagnosed with cancer.
Professor Arnab, yes, sir.
Yeah, the other problem is, the reinfection rate that we have in India. You can't just rely on one eradication therapy, and how often can you give it? So you can't give it every few months. We are going to have reinfection. So I don't think it's really valid to give eradication therapy for even post-op patients, not to talk about other patients as well.
Yes, sir.
Dr. Zahir Nabi, what is your practice in AAG regarding this H. pylori for the ulcer and the cancer?
So we give it routinely for the reason being that it's a 2-week therapy, and does not cost much, does not take much, and pretty much well tolerated in these patients. So any patients who has been successfully operated with the gastric cancer, or even if we are doing an endoscopic therapy for patients with early gastric cancer, the background mucosa is still it's a breeding ground for or for metachronous cancer. So what I believe is it's very difficult to say, because the number of patients, we haven't done a systematic analysis of our patients, whether they are getting benefited or not. But what we gain from the past experiences, the experiences from South Koreans and the Japanese, that the chances of getting a metachronous malignancy is maybe reduced if you treat H. pylori in these patients, because the background mucosa, the background gastric mucosa remains the same. It provides a breeding ground for malignancies coming again. Of course, the chances of recurrence at the same site may not be affected, and it all depends on the type of resection that you have done and how successfully you have resected the gastric cancer. So I believe our practice is to give H. pylori in all the patients. I will say that we need more evidence, as the eminent faculties have pointed out. It may be too early to say that in our population it's beneficial or not, or what happens if they get reinfected, because in our population reinfection is quite easy. So difficult to say, but an easy therapy, a 2 weeks therapy, and I believe that no harm at least in giving a 2-week H. pylori therapy.
Thank you, sir. Thank you for sharing your experience. Since we are having too many topics today, in fact, H. pylori is a very age-old disease, infection. We can discuss a day long also. Next, I request our EC, Dr. Pandiraja, to introduce the next speaker.
Thank you very much, sir, for joining us this evening. Stay with us. Thank you.
Good afternoon, everyone. On behalf of ASI Chennai City Branch and IASO, it is our honor to introduce Dr. Zahir Nabi. He is a consultant gastroenterologist from Asian Institute of Gastroenterology. He did his undergraduate in SMS Medical College and postgraduate in SN Medical College, and DNB Medical Gastroenterology from Asian Institute of Gastroenterology. He is now working as a consultant gastroenterologist in Asian Institute of Gastroenterology. His main area of interest, particularly interventional GI endoscopy, particularly as endoscopic mucosal resection and submucosal resection. And another important area of interest is third space endoscopy, particularly POEM. When I search his biodata, I able to see a lot of his research paper on POEM. He is published more than 100 national and international papers, particularly in endoscopy as well as in a third space endoscopy. He wrote book chapter in various aspects, particularly on ERCP in pancreatic biliary disease, role of metallic stent in biliary disease, and management of constipation, and management of liver disease in pregnancy, and non-cardiac chest pain evaluation, and infection in biliary tract. He is an invited orator and presenters in various national and international conference. It is our honor to be introduce Dr. Zahir Nabi as a part of this program. Thank you, sir. Over to you.
Thank you for the kind introduction, and I thank ISO and ASI Chennai chapter that they included me in this interesting discussion. So I'll be presenting my thoughts on early gastric cancer, and in the next few slides, I'll be presenting on how to diagnose and manage early gastric cancer. So I'll be talking about the definition, the identification of early gastric cancer on white light and NBI, and whether these patients can be managed surgically or an endoscopy is good enough, the role of endoscopic ultrasound for the diagnosis and palliation in these patients, and how to palliate gastric outlet obstruction in these patients. So early gastric cancer, as thought by many, it does not necessarily mean that the patient can be managed only with endoscopy. What endoscopists are interested in, that the tumors are located to mucosa, although the definition also includes that cancers located to submucosa, they can also be a part of early gastric cancer. So we are more interested in this portion of early gastric cancer because the chances of lymph nodal metastasis are lower and the chances of curative resection are higher if the cancer is located only to mucosa. So coming to what does the history say, because you'll see majority of the studies coming from Korea as well as Japan. And because the incidence of gastric cancer is very high and they have a standardized screening protocol in their countries and they detect gastric cancer in early phases in a large proportion of patients. So what this systematic review and meta-analysis, it suggests that that early the chances of early gastric curative rate of early gastric cancer is equivalent to surgery. The only thing is that metachronous cancer, they are high in endoscopy group as compared to surgical group. So that is one of the reasons that patients who undergo an endoscopic resection, it's mandatory that they should undergo surveillance for a variable interval of time. So the advantages of endoscopic resection in these patients is there's no scar, it preserves, it's an organ sparing therapy, and it provides with better quality of life in these patients. Now let's come to how to diagnose and assess the endoscopic resectability in these cases. So as an endoscopist, what I find more difficult is the diagnosis and characterization of these cancers into early gastric cancer, because this is what matters most to me, whether this is an early gastric cancer or the cancer is invading deeper into submucosa or muscularis. So this is very important for me. And the main challenge in these patients, patients with smaller lesions are diagnosed to have gastric cancer, whether the cancer is mucosal, submucosal, it's in early stage or advanced stage, whether this is a differentiated cancer or undifferentiated cancer. And all this, for all these things, I require a white light endoscopy as well as the newer modalities, which are narrowband imaging, magnification endoscopy, as well as endoscopic ultrasound. The task of after you classify is pretty easy. If the patient is having an advanced, straight away you send the patient for surgery. And if the patient is a candidate for endoscopic resection, you perform either an EMR or ESD in these patients. So the bulk of the task is diagnosis, and less of a task is resection part. So what do I see when I perform an endoscopy in a patient who has been referred to me to evaluate for endoscopic resectability? I see for the size and surface of the lesion, which is very important and is included as one of the criteria to determine the endoscopic resectability of that lesion. Then ulceration is equally important. Invasion depth, whether this lesion is mucosal or submucosal, whether this lesion is differentiated or undifferentiated. So I take help of all these modalities. I use white light endoscopy to see grossly what is the configuration of the lesion, chromoendoscopy, NBI magnification, endoscopic ultrasound, and biopsy to see if the lesion is differentiated or undifferentiated. So these are all the tools that I use, and to a reasonable degree of accuracy, you can identify based on your endoscopic examination whether this lesion can be resected endoscopically or it requires surgical approach. So for the undergraduate or postgraduate colleagues who are listening to the talk, I'll recommend that whenever a patient is being referred to us, these things should be kept into mind. And if I receive a patient, or I'm going to receive a patient from my surgical colleague who says that, look, this lesion looks to be an early gastric cancer, I always prefer that the preparation should be good. And I asked my surgeon colleague that, look, if you are referring the patient to me, ask him to take PPIs for a week before, because it will suppress the background inflammation and the lesion is going to be much clearly demarcated. And what I require is, or to my surgical colleagues, if they are sending a patient, then of course the expertise is required, along with some certain equipments like a high definition gastroscope, which is having a equipment with NBI and magnification function. This is mandatory to have before you evaluate these patients for endoscopic resectability. Now, how do you characterize this patient, whether this patient is having mucosal or deep submucosal invasion, or whether this is differentiated or undifferentiated gastric cancer? So these are some of the endoscopic images that I like you to see, which looking at which you can say that whether these lesions are invading deep or they are superficial. So look at the surface, irregular surface. This is a very important criteria. If you see this irregular surface and these whitish streaks inside, thickening of the folds, which are converging at the gastric cancer, because many of these patients, they are referred to as early gastric cancer, but in actual, they are not candidates, suitable candidates for endoscopic resection. So these are all are the endoscopic images which suggest deeper submucosal invasion, and these patients should be managed surgically and not endoscopically, although they look very small lesions, and you may be tempted to remove them endoscopically, but they are not ideal candidates for endoscopic submucosal dissection. Another sign which is very important, in fact, many of the surgical colleagues, they have also adopted endoscopy, and they perform endoscopy themselves before subjecting these patients to surgery or endoscopical resection. And if you see, this is a non-extension sign, which means that once you insufflate the stomach to full extent, this lesion does not flatten out. And this is mainly because of the submucosal involvement of the tumor. And this suggests that probably this patient should undergo a surgical resection, and endoscopy is not a good option for this patient. So these are some of the features. These are some of the images that can help you in defining whether this is a differentiated or undifferentiated cancer. So an elevated lesion or a protruded lesion, majority of the times, there is a 70–80% accuracy in defining that these are differentiated cancers, and probably these are also good candidates for endoscopic resection depending on other features. On the other hand, if you see a flat or depressed lesion, then if you see a whitish lesion, then probably this is an undifferentiated lesion, and you need to be more careful when you subject these patients to endoscopic resection. On the other hand, an angry red looking lesion, majority of the times they are differentiated lesions, and they provide you with a reassuring thing that these lesions probably can be resected endoscopically. So these are gross white light endoscopy, and now we have moved much ahead of pure gross examination with endoscopy. We have now narrowband imaging and magnification endoscopy, which provide you with enough information that whether this lesion is cancer or not cancer, or whether these lesions are operable or inoperable. So you can see that these initial two images of white light endoscopy and narrowband imaging, how beautiful image, how beautiful magnification. You can see these lesions in clear details, and they can provide you with a information whether these are cancers or not cancers. And you'll be surprised to know that the initial two lesions which look to be cancerous lesions, they are not actually cancers. And only the last one, which is a subtle looking lesion, this is a lesion of early gastric cancer, depending on the NBI findings of a demarcation line and irregularity which are present only in the third image. And this is how we define whether the lesion is a cancer or not lesion. So first two lesions, they don't require any therapy in the form of endoscopy. So differentiated or undifferentiated, again, I'll lay stress on the fact that NBI has provided us with so minute details that even subcentimetric lesions, they can be characterized whether they are differentiated lesions or undifferentiated lesions based on the findings of narrowband imaging. You can characterize these lesions very well, and then you can take a decision whether these lesions can be resected endoscopically or not. So this is one of our patients who was sent to us, and because this was a subtle looking lesions and could be barely recognized on CT. And this was an ulcerated lesions. Initially, I went ahead without a cap, but then finally you can see that there was a certain irregularity of pattern near this ulcer, and we were sent that this is a non-healing ulcer. Please take a call whether this defines for gastric cancer or not. So this is, you can see that there is a clear demarcation line between normal mucosa and irregular mucosa. Here is the irregular mucosal pattern, and for certainty we could say that this is a case of gastric cancer. Now whether this is an early gastric cancer or not, this could be further evaluated based on the endoscopy. Finally, this patient turned out to be a case with advanced gastric cancer, the reason being of thickening of these gastric folds that you can see here. And that is the reason that this case classified to be a case of advanced gastric cancer and not suitable for endoscopic management. So these are some of the our own images. You can see a very subtle subcentimetric lesion, and this lesion could have been easily missed if you are using a substandard scope and substandard imaging techniques. But then with NBI, you could recognize that there are subtle irregularities in this area. You applied near focus and magnification endoscopy, see these irregular vessels here, and you could characterize this patient. Okay, this patient is having a undifferentiated type of early gastric cancer, and because of the size and further evaluation, we could resect this patient endoscopically, and the patient was declared as cured. So this is the beauty of magnification endoscopy, that you can characterize even these small 5 to 6 millimeter lesions, whether this lesion is gastric cancer or not, and if it is a gastric cancer, whether it is differentiated or not. Of course, biopsy is complementary, and some of the cases when you cannot make out whether this is a differentiated or undifferentiated malignancy, you take a biopsy and subsequently take a call whether you can resect this patient endoscopically or not. So this is the beauty of imaging that has provided us with enough confidence that can you resect these lesions endoscopically or not. But look, not everything is black and white, and there are still loopholes, and the problem is the accuracy in submucosal invasion is
3 o'clock.
Is still suboptimal in these cases, and therefore the size estimation and interobserver variability is something. So what to do if you cannot say regarding the depth of submucosal invasion, and if you see this image, endoscopic ultrasound has of late come with a great help, because we can recognize the layers of a gastric wall with great accuracy, and you can see that on this CT we cannot identify the gastric layers, but on this endoscopic ultrasound you could characterize the lesions, whether these lesions are infiltrating into mucosa, submucosa, or deep muscularis, and they provide us with great confidence that, okay, these lesions can be managed endoscopically or not. So EOS has helped a lot, and it can provide you with a reasonable estimation of the depth of the lesion. So in cases we are not sure what is the depth of the lesion, we always use EOS and define the depth of invasion in these lesions and take a call accordingly whether these lesions can be resected or not. So which lesions can be resected endoscopically? So the ones I have marked in green and yellow, they are the lesions which can be resected endoscopically, depending on the presence or absence of ulcers, whether they are mucosal or submucosal, whether they are differentiated or undifferentiated. So these are the lesions which should be taken for endoscopy, and rest of the lesions straight away you should subject them to surgery, because the risk of lymph nodal metastasis is very high in these lesions. The type of resection that you want to take in these cases is all dependent on the operator and his expertise. But in my opinion, endoscopic submucosal dissection is the only therapy that you should deploy in these cases, and EMR should not be deployed unless you have a problem in expertise. So this is one of the videos of resection that the technique that we use. This is a case of early gastric cancer, and the modality, I especially prefer a pocket technique for endoscopic submucosal dissection. It's very easy, very effective, and with the availability of these special knives that we have for endoscopic resection, I think gastric ESD has become quite easy, and in many of these patients you can resect these lesions endoscopically. And this is quite a safe technique. Major complications are rare, and you can see that what I do is I just make a pocket beneath the lesions, reach to the other side of the lesion, and finally once I have reached to the other side of the lesions, I just make a round incision and resect these lesions endoscopically. So if you see, this is the final part of the resection. The resection has been completed, and the final call will be taken based on the final histopathology. So if on the final histopathology, I find any of these findings, these patients, they have high risk of lymph nodal metastasis, even if they are not visible on your initial imaging, they should be subjected to surgery. In other cases, you can assume that it's a curative resection, and you can follow these patients up in future. So what is the follow-up protocol? This is the follow-up protocol that I follow depending on curative or non-curative resection. These patients should be followed at 6 to 12 monthly interval, and how long they should be followed, it's a matter of debate, but then probably these patients should be followed for lifelong. So the palliation of advanced gastric cancer, these are the last couple of slides. What I want to show, that surgery is a very good modality for palliation, but then it's invasive, and many of the candidates, they are poor surgical risk. So that is the reason that enteral stents have come into place in those with malignant gastric outlet obstruction. But again, the problem with enteral stents is that because they are deployed at the region of tumor, there is always a risk of reocclusion due to tumor ingrowth. Now a new modality has come up, which is called endoscopic ultrasound guided gastrojejunostomy. And what you do in these cases is you go away from the tumor site. You are not actually including the tumor site to create a gastrojejunostomy. So you connect these two lumens with a metallic stent. You deploy a metallic stent here, and because this is away from the tumor site, the chances of reocclusion due to tumor ingrowth are very low. So these are some of the cases that we have done with the EUS guided gastrojejunostomy. You identify a jejunal loop from stomach here, and straight away you have a hot stent here, which can straight away puncture with this hot stent device and deploy this stent. It's a very easy procedure. The only difficult part is to identify a closed jejunal loop, which can be targeted using these endoscopic guided therapy. So you see a stent has been deployed and dye coming from the jejunal loop, which we had injected before. And this suggests that you have completed this procedure successfully. So EUS gastroenterostomy has been shown to be better than enteral stenting, higher clinical success and lower re-intervention rate. And that is the reason that now more and more people are especially in those with surgically unfit patients, we are moving towards EUS guided gastroenterostomy. The futuristic approach, I think it's a collaboration of both endoscopists and surgeons. And I think this is going to be the future of early gastric cancers, which are not ideal candidates for endoscopy, but then still you can do an organ preserving surgery. And I think many of you would be aware of these new therapies, which is called sentinel node navigation surgery and non-exposed endoscopic wall inversion surgery. So I think this is something new which is coming up for the management of gastric cancer, and this will be the future of management, in which both endoscopists and laparoscopists, they play a great role and manage these patients and preserve the organ and improve their quality of life. So to summarize, early gastric cancer does not always mean that these cancers can be managed endoscopically. Endoscopic assessment is still not optimal, and there are still loopholes. That's why we need to rely on many modalities and not just endoscopy. Metachronous cancer risk is always there when you are managing these patients with endoscopy, because you have not treated the background inflammation or H. pylori infection. So these patients need to stay on regular follow-up. And there has to be a balance between organ sparing and oncological safety. If I can do a resection, does not mean this patient has to go endoscopic resection. It has to be towards the side of the patient, towards the benefit of the patient. In future, I think we need to see how to collaborate laparoscopy with endoscopy, especially in Indian subcontinent, because many of these patients, they may be subjected to surgery even when they are candidates for endoscopic resection. Thank you all.
Thank you, sir. Thank you for the elaboration of both narrowband imaging and as well as the endoscopy technique. So what is your take-home message to the younger colleagues regarding the narrowband expanded imaging? Because some of them are very interested to learn about things. So how difficult, how easy, what is your take-home message to our younger audience?
So learning narrowband imaging is not difficult at all, and it's all you keep on doing endoscopy. You collaborate with some of your expert endoscopists, because we all started at some stage in our career when we knew nothing, and we are still learning how to perform a good narrowband imaging in these cases. So the learning curve is not very big. The only thing is that how sure you can be on narrowband. Even an expert cannot be 100% sure whether this patient is having deep submucosal invasion or not. So sometimes the decision has to be taken after that you resect the lesion, and finally when you identify there is a submucosal invasion or there are other risk factors, then these patients should undergo surgery. So to learn narrowband imaging, I think you have to get attached to somebody who has been doing narrowband imaging for quite some time. You need to have a good scope to identify these lesions, which is having good capacity with narrowband imaging and magnification.
Thank you, sir. Actually, stenting the duodenum is quite challenging, especially in gastric outlet obstruction of the gastric cancer. So what is your experience on that, and what will you advise as a surgeon? We like to know about.
So the success of enteral stenting depends on two factors. One is, of course, your expertise, because many of them, they have a near complete occlusion, and therefore we always do this enteral stenting under fluoroscopic guidance. We pass a guide wire across the obstruction, and see these images, whether the wire has crossed deep into duodenum or not under fluoroscopy. Whenever we have doubt, we also pass a luminal catheter there and inject some contrast so that we can opacify the duodenal limb. And once we are, only when we are sure that we have crossed the guide wire and catheter inside, then we proceed. If we are not sure, we never proceed, because this may lead to complications like perforations and all. So the other thing is, the success of enteral stenting also depends on the stage of the disease. So suppose somebody is having peritoneal carcinomatosis and diffuse disease, you have to explain the patient that, look, there may be obstruction at multiple levels, and stenting these patients may not help them always. So this has to be taken care before you subject these patients for enteral stenting.
Thank you, sir. Dr. Kanagvel, any questions
No,
from?
Professor Arnab is seeing to raise the hand.
Yeah, very fascinating talk, very interesting. Just one question, how do you get to oppose the jejunal loop to the stomach to do this enteral, stomach to jejunal stenting?
So
sounds very interesting. Yeah.
Yeah, so it's like what we do is we pass a tube through duodenum through the narrowing. It's a special tube that's available from our Japanese colleagues, and it's called an e-pass tube. So what we do is this tube has two balloons on its end that can be inflated. Once we insert this tube deep into duodenum and finally into jejunum, we inflate these balloons and inject a lot of contrast, which can be visible on fluoroscopy, as well as which can be appreciated on endoscopic ultrasound. And finally, when you distend the lumen of jejunum and the balloons are insufflated, you have a clear target. Okay, because the balloons are visible, the contrast inside is visible. You take the assistance of fluoroscopy, you take the assistance of endoscopic ultrasound, and finally puncture this jejunal loop. It's sometimes what is difficult is, as you rightly said, that you cannot find a jejunal limb which is near to the stomach. In these cases, of course, these are the limitations of endoscopic ultrasound, that you cannot be 100% successful in these cases. But majority of the cases, you do find a jejunal limb near the greater curvature of the stomach, and finally you get a great success.
Thank you, sir. And one question from Dr. Suraj. Sir, how do you mark the specimen when you send the specimen for the pathological analysis? And what is your strategy in case of a deep margin positivity and in case of a lateral margin positivity? Sorry.
So upcoming results, I'll tackle the lateral margin first, because this is quite easy for me. It's very important that where does your endoscopy limitations bring you down? So the limitations of endoscopy are especially in defining the margins of undifferentiated cancers, and sometimes you don't know exactly what are the margins of cancer. So in these cases, before we decide for endoscopic resection, we always take biopsies, not only from the tumor site, but also at a distance away from the tumor site that we mark before. That is 1 centimeter from the tumor site, 1.5 centimeter from the tumor site, so that we can define whether the margins that we see on endoscopy, they are clear of tumor or not. So lateral margins, if they come positive after, they can be again dealt with endoscopy. There's no problem with that. And in fact, there are upcoming studies which say that even if the lateral margins are positive, these patients don't have a very bad outcome if you again resect these lesions endoscopically. Regarding deep margin positivity, of course, depending on the surgical status of the patient, if the patient is a good surgical risk candidate, then he can be subjected to surgery. There is no point in again digging in that case. In cases who are not good risk for surgery, I think these patients should be followed up, nothing to be done, because many of these patients, they don't die actually of gastric cancer, they died of their comorbidities rather than gastric cancer. So these patients should be followed depending on their performance status and suitability for surgical resection.
Thank you, sir. Kanagvel, any questions from you?
I think Prema is coming up. I think he should be having questions. Then I'll take it later. Prema, please.
Just one question. Zahir, how often do you find, I mean, particularly in early gastric cancers in India, a raised lesion, a protruded lesion?
Raised lesions.
How often do you find a depressed lesion? Like, what is common?
So in my opinion, I think a raised lesion with a small ulcer is the most common type, because most of the times we are referred patients who in which this ulcer has not healed after a PPI therapy. So majority of the times we get a lesion which has slightly raised margins with a small ulcer in between, and the ulcer has not healed to H. pylori therapy, to PPI therapy and all. And these are the most common types of things. The problem is we don't know exactly which ones are the most common in Indian population, because we don't get to see so much of early gastric cancers. And this is where we lag behind. We have such a huge population that I don't know if a screening protocol in our population will be cost effective or not. And that I think if we have a screening protocol, we may be able to identify which one lesions are, which type of lesions are most common in Indian population.
Yeah, thanks.
Dr. Chandramohan.
So here, one question to you. It's an excellent talk, and actually it was very much an eye-opening for most of surgeons, because first time we are hearing the utility of the narrowband imaging. I think that is going to replace the biopsy in a significant way. And the way you have predicted that the deep invasion by narrowband imaging is a little nice to know. But regarding your procedure, you said that endoscopic guided gastroenterostomy. My query is, how do you know you are putting the stent into jejunum? Suppose if it goes in ileum, but how do you differentiate ileum from jejunum while you do endoscopy?
So again, sir, as I told, what we do actually is this is where we face a lot of problem. The major step when we are doing an EUS guided gastrojejunostomy is to pass a guide wire across into the jejunum. So this is where we have trouble in most of the initial cases. We pass a guide wire into the jejunum, and second, what we all this we do under a fluoroscopy guidance. And next, what we do is we insert a tube through into the jejunum and push a lot of fluid and contrast through that tube. So when we push a lot of contrast and then we try to localize that site under EUS guidance, because all this is going under in the real time, and we have two balloons as well on that attached on the tube, which are initially in a deflated state when we pass them into across the obstruction into the jejunum. Subsequently, we insufflate those two balloons so that we can concentrate all the fluid between those two balloons. So once we insufflate these balloons, once we push a lot of contrast between those two balloons, I think fluoroscopy gives us a lot of guidance that, okay, this is the limb which you have to target. And the next step, the next problem comes whether this limb is close enough to the gastric site or not. The other thing is, with the development of new lumen opposing stents, what they do is, even if there is some distance between gastric and jejunal this lumens, what we do is these lumen opposing stents, they bring the two walls close together. So ultimately the stent brings the two walls closer, close to each other and opposes these two walls. So this is how we target this jejunal limbs, and we are sure that because of the contrast and the balloons, that we are not going anywhere else but into the jejunum only.
Yeah, I think this is one thing you really we really appreciate your talk is you said that lot of exchange can happen between laparoscopic surgeons as well as endoscopists. I think that we should take forward, and perhaps a laparoscopist surgeon can help you, and he can bring the loop there, and you can continue with the procedure.
Definitely, definitely.
And so I think there is one question from Dr. Radhika Chavan. Sir, apparently she wants to know what's the difference between the first and second generation NBI.
So Radhika, the difference between first and second generation NBI is that now we are getting narrowband imaging with magnification as well as with near focus. So this is a difference that makes, because you not only need NBI can show you the lesion, but it cannot magnify for you to see the minute details, see the demarcation margins where the tumor lies and where the tumor ends and where the tumor begins. So this is the changes that have been occurring. And in fact, now we have closely being available is third generation NBI, which provides even a better resolution. So it's like a on-site histology that you can predict by looking from those advanced NBI scopes. This is the main difference between the generations of NBI.
And there is one question from Professor P.K. Das. Sir, what is the chance of spillage of internal contents when you do an endoscopic stenting? Maybe he wants to know possible peritonitis post-procedure, all those entities, how risky it is to do in your experience.
So all these are real possibilities, Dr. Das. The thing is, these are advanced EUS procedures, and of course there is a definite learning curve associated with these procedures. We have all gone through those nightmares of peritonitis, deploying the stent into peritoneum. We have all gone through those nightmares. So there are definitely chances, and if you are not sure that you are seeing the jejunal correct limb and your needle has not gone well into the jejunal limb, never deploy the stent. You just come out and leave the patients for the surgical colleagues, because this is going to be counterproductive if you are not sure.
Thank you, Dr. Zahir. I think we could see Dr. Rudra Acharya raising his hand. Dr. Rudra, would like to ask a question, please?
No, I was just giving a comment that whenever you are not sure that the jejunal loop is nearby, you can just put a trocar and do a hybrid technique and immediately put the loop. And it is hardly, it takes 5 minutes to put a trocar. And you are doubly sure from the outside laparoscope and endoscope that the GJ is done. And I think it is widely practiced in Europe. And even I had seen one procedure being done in Kenyatta Hospital in Nairobi. So you think these procedures are becoming common actually?
Yes, yes. In fact, that's a very good idea, Dr. Rudra. And I think endoscopists and laparoscopists and GI surgeons, we are not mutually exclusive, and we need to learn a lot from each other, and we can gain a lot from each other. And I appreciate your comment.
Thank you, Dr. Zahir, for saying with us. Kannan sir, please take over.
Thank you, sir. Thank you for the all elaborate answers for all the valid questions.
Thank you.
Next, I welcome Dr. P.K. Reddy, sir. Is a senior surgical gastroenterologist and as well as advanced laparoscopy surgeon, Apollo Hospital, Chennai. Sir is very much a special interest in case of gastroenterology surgery, hepatobiliary pancreatic surgery, laparoscopic GA surgery, and of course the bariatric surgery. Sir is having so many numerous publications in all index journals, and he is a member of all the laparoscopic associations and the world-renowned associations. Sir is special interest in GA surgery, especially in the advanced laparoscopy surgery, and that he had so many achievements in his father. The one is he only first established GA unit in Apollo Hospital, Chennai, and established an advanced laparoscopy unit in Apollo Hospital, and as well as he has award received for the completion of 20 years service at Apollo hospitals, and he trained so many number of surgeons in all over the country and from the abroad for a GA and as well as laparoscopy. And he oversees tutor for the Royal College of Surgeons, Edinburgh, and he is former executive committee member of IAGS in India. I warmly welcome Professor P.K. Reddy, sir, for talk about the gastrointestinal stomach tumor of the stomach. Over to you, sir.
Dr. Kannan, thank you very much for the introduction. And once again, I thank the Dr. Kanagavelu and the entire executive committee of City Branch of ASI for giving me an opportunity to participate in this symposium. You asked one question, Professor Kannan, and how difficult is NBI? Nothing is difficult. As long as we practice it, we perfect it, nothing is difficult. Because the reason I'll tell you why. When I started the endoscopic work in Apollo Hospital first. And one VIP was admitted. And I did an endoscopy for him. There is a small elevated lesion in the pyloric antrum, but a mild ulceration. I got the endoscopic scissor at that time. The endoscopic scissor, I excised that. And then I removed it. And the usual thing those days, only ranitidine was available. So I put him on ranitidine, we sent him. But surprisingly, the report came as adenocarcinoma of the stomach. And he being a very VIP in the city, and the biopsy was sent to Mayo Clinic. The Mayo Clinic reported as adenocarcinoma of the stomach, and the immediate surgery was advised. Since I was young, the hospital called a senior surgeon from outside to operate on this patient. And it happened in such a way, on that day, I was out of station when he was being operated. And the surgeon, as usual, those days were the big surgeons, big incisions and all, they were open. When he opened and he started looking for the tumor, you couldn't find anything. And they desperately tried for me. And see, those days there were no cell phones available, so they couldn't get hold of me. So he did a blind subtotal gastrectomy. The patient lived for more than 25 to 30 years, and he passed away with a cardiac problem not due to the stomach. Of course, a lot of water has flown under the bridge. Now the endoscopy and then the organ preservation have come in a big way. And in fact, as my talk itself is, it is the endoscopic assisted laparoscopic resection of the gastric juice. That means, as the previous speaker has mentioned, it is a multidisciplinary approach for all the things nowadays. Nowadays, we are not independent. We have to depend on other specialties as well. Now, coming back to my talk, gastrointestinal stromal tumors are an interesting group of tumors. Some of them are benign, and these are rare tumors as compared to the gastric cancer. And these are again, they are incidentally detected. A majority of them are detected incidentally, and then you do a wedge resection for them is a common procedure being done. The gastrointestinal stromal tumors, they are most common mesenchymal tumors of the GI tract. They arise from the interstitial cells of Cajal, which are concerned with the gastric motility. The most common site is stomach, accounts for about 60%, and this surgical resection is the treatment of choice. And in the past, 1 to 2 millimeters margin was must for an adequate resection, but now that concept seems to have changed a bit. And if you take in US, 4,000 to 6,000 new cases in the United States are diagnosed with gastric cyst each year. And the median age is 60 years, and there is no predilection for either gender. So if you take this thing, about 0.1 to 3% of this constitutes about 0.1 to 3% of GA malignant tumors, mostly result from mutation of KIT and PDGFR gene. Tumor size and mitotic rate determines metastatic potential, and lymphatic spread is rare. Metastasis at advanced stage to the liver is most common. One thing I forgot to mention, even after coming back to India, these were called as leiomyomas and leiomyosarcomas. Then after the introduction of the immunohistochemistry, these are separated into gastrointestinal stromal tumors. Till that time, we used to call them both in UK as well as here after coming in the beginning as leiomyomas, leiomyosarcomas. Subsequently, they are changed into gastrointestinal stromal tumors. As I mentioned, stomach is a commonest organ. I had an opportunity to operate from starting from the esophagus down to the rectum. And the clinical presentation, as I mentioned, majority of them are asymptomatic, and some of them what I counted was present with upper GA hemorrhage. And some they have a vague GA symptoms, but majority of them are instantly detected by doing a CT or ultrasound, depending on the size of those tumors. What are the diagnostic studies involved in it? So we have an excellent diagnostic studies for this. The CT scan for initial, it helps both for initial evaluation as well as surveillance for recurrence of these tumors. You will see a nice demarcated hypoechoic mass contiguous with the muscularis propria layer of the stomach is characteristic. Endoscopy and EUS determines size and extent of the tumor, and EUS helps in biopsy as well. The literature shows what is the difference between CT and EUS, but the literature says both are the same as far the diagnosis is concerned. The advantage of EUS is you can take a biopsy, field biopsy. But once again, the literature suggests by doing a needle biopsy, there is a chance of bleeding from there, what they have mentioned. Now, presently for any malignant tumors, most of them we try to do a PET. FDG PET reveals small metastasis and establish baseline metabolic activity and assess the therapy response. But however, routine use of PET for surveillance is not advised in these cases. You can see beautifully how the GIST positive kit, you can see C kit, that is the one which has completely changed the concept, and you can see how nicely it is stained. That is CD117, or it's commonly called as a CD kit, positive staining for the GIST. Of course, we have others like CD34, Vermentin, DOG1, Desmin, all these things. But CD117, that is C kit, tyrosine receptor kinase is the one which is the most commonly used, which is specific, is positive in more than 95% of cases. Do we need a biopsy for these tumors, gastrointestinal tumors? And for any malignancy, we usually prefer, if I want to send a patient, refer a patient to a medical oncologist, he will knock the patient unless he has a positive diagnosis is there with a histopathological diagnosis. That's where FNSA comes. But as far as the GISTs are concerned, if they are resectable, you resect them rather than doing a biopsies. Resectable lesion in the absence of metastatic disease, a preoperative tissue diagnosis may be unnecessary. The treatment. As I said, surgery is the mainstay of therapy till recently. The medical therapy, that is postoperative imatinib, that is first generation of tyrosine kinase receptors antagonists, is recommended at least for about 36 months in intermediate to high risk patients. Neo-adjuvant imatinib is also is advised in selected group of cases. Where do you give the neoadjuvant imatinib is particularly what our experience is. When the tumor is big and their metastases are there, you give them the imatinib, or post-operative recurrence is there, you give a adjuvant imatinib. And it works very well, in fact, actually. Those cases which are not responding to imatinib, that is first generation tyrosine receptor antagonist, you give the sunitinib. And now the third generation also has come, which are said to be more effective than the others. Now, the very important thing for as far as our surgeons are concerned is there are two things, because it's a very easy operation unlike gastrectomy and all. And what is most important thing is there are two sites in the stomach which are difficult to operate in these cases. One is the OG junction area. OG junction area, and other one is the pyloroduodenal junction. The reason for it is when you try to resect it, that is you do the segmental resection of the GIST tumor at the OG junction area, there is accidentally the stapling can happen and esophagus will be completely, totally stapled. Case reports are there. And similarly in the pyloric antral area, when I operated, it's technically also it is a bit difficult to do in this area, the segmental resections. Unlike in the cases of fundus and body of the stomach, where is shown in these yellow areas, it is much easier. You lift it and put a stapler and resect it. And these two areas which are the difficult ones, and the first one at the OG junction area, I will just show the video shortly. Now, anterior gastric wall, as I mentioned, it's very easy. You lift it with two sutures and then resect it with a stapler. It's perfectly simple. It hardly takes any time to do this. And similarly, if in the posterior wall also, you do the same thing. You do anterior gastrotomy and or the endoscopically localized lesion. That's where the endoscopists, we need their help. And DiMatteo is from Sloan Kettering Memorial Hospital. He demonstrated tumor size and not negative microscopic surgical margins determine the survival. See, previously when there is a positive margins, that means survival rate of these tumors is very, very low. But now with the advent of imatinib, this is not a major problem. The feasibility of laparoscopic resection of gastric cysts of more than 2 centimeters is well established laparoscopically. And long-term safety for more than 2 centimeters of gastric cysts, at that time when he published this paper, was doubtful. But now, even for the large cysts also, we are doing laparoscopically or laparoscopic assisted way or hybrid technique we used to do them. So we are doing them now. Now you see here, this is the one which is a large hypoechoic mass area arising from the fundus and then reaching the OG junction area. See, these are the ones which are difficult. And these are cases where you need an endoscopist's help to localize this tumor, where to open the stomach, and then how to resect it. For that, you have to place a gastric calibration tube. Since we're all of us are doing the bariatric surgery, gastric calibration tubes are available in all the theaters. You place a gastric calibration tube and then only staple it. Otherwise, once you narrow it, it's a very big thing to correct it again. So I'll show you this video. You can see it here. You see here, this is the stomach, and this is the OG junction. There is a hiatus hernia is there, and you can see you can see by pressing it, the tumor is seen there. You have to pull the stomach down by a little bit of opening the lesser sac on both sides, so that the esophagus can be mobilized down. Anyway, I need to do the pleural repair. That's why I thought I'll mobilize the whole thing. That's the posterior vagus nerve. That's the esophagus which has been mobilized now. Put a loop around the esophagus and pull it down. And this fat at the OG junction area that needs to be cleared completely before we plan where to do the anterior gastrotomy. So now that is the now you can see the tumor, and then we have done it. Now the endoscopy is coming. As soon as the endoscopy, it was done by Pirma only, and see in the esophagus itself, you can see the tumor is coming and blocking the OG junction. See now retroflexion of the endoscope. You can see nicely big tumor. He came presented to me with bleeding, upper GI bleeding, and then that's the laparoscopic, endoscopic and laparoscopic dose. So once we know where the tumor is exactly, you make a small gastrotomy. You don't need to make a big gastrotomy in these cases because you can dislocate the tumor very easily. What is important thing in the GIST is you should not damage the capsule of the tumor. And that is the most important thing. That's where we have to be very careful when we're doing it. Then once the tumor is dislocated outside, you put the stapler, adjust it in such a way, take a little cuff of normal stomach, and then pull it out. And most important thing, never forget, start passing the gastric calibration tube. You can see here, gastric calibration tube is coming there. See the gastric calibration tube, that's the one actually. Once the gastric calibration tube is there, I'm very comfortable. So put a 1 or 2 staplers and resect the tumor. These smaller ones can be done endoscopically also. And probably I forgot to mention it, but the ideal thing, what is accepted is when we do surgically, either by open or laparoscopic method, we do a total resection, total gastric wall resection, we do it. Whereas endoscopically, we can do only either EST or endoscopic dissection only they can do, even though their origin is from muscular, but we do a complete resection so that the entire stomach wall is removed in that part segmentally. Once you finish that one, closing, then put water and check the leak test. Very, very, very important. Leak test. And after doing all this thing, when these things leak, we will have a nightmare. So you cover that area after taking the leak test with a momental patch. May not be necessary, but however, we feel comfortable by putting a momental patch, and then nicely all it needs is one stitch. Then since the hiatal hernia was present and hiatus is so lax, I narrowed I did a chloroplasty, but I did not do a fundoplication because we have already taken the stomach from there. If I do a fundoplication in this case, it might cause narrowing. That's why I was careful. I was scared not to. I did not do. When you're removing these tumors, you should put it in a plastic bag and remove it out. You can't remove it just like that in a normal way, like what we do. So minimal access surgery for gastric gist. The role of laparoscopy in the resection of the gist continues to expand. From gastric gysts of less than 5 centimeters, laparoscopic wedge resection. Gysts of more than 5 centimeters, you can do the laparoscopy or laparoscopic assisted techniques. Why laparoscopy preferred modality for gastric gysts? Because we were doing this by open surgery. Even now we can do very comfortably by open surgery. Why? The tumor size in these gysts usually not large, but of course there are a number of them which I did, which are sometimes they are so large actually. And lymphadenectomy is not recommended as lymphatic involvement is rare in these tumors. Tumor characteristics and negative microscopic surgical margins determines survival. Therefore, complete resection with gross negative margins is a surgical goal. The minimal morbidity associated with laparoscopic approach has allowed us to be more aggressive with management of underdiagnosed GIST tumors. Does tumor size really matter? Which we have seen just now. These are all the references. They're all doing from smaller, slowly they're getting into the bigger ones. The NCCN guidelines mentioned a laparoscopic approach may be considered for the select GIST in favorable anatomic locations, that is greater curvature, anterior wall of the stomach, and the rest of the gastrointestinal tract. All oncologic principles of GIST resection must still be followed, including preservation of the pseudocapsule, avoidance of tumor spillage. That is the most important thing what they say actually. And resection specimen should be removed from the abdomen in a plastic bag to prevent spillage of seedling and sites. I remember one case which I operated about 6-7 years ago. I reviewed her recently also. It was a big exophytic gist from the fundus of the stomach. I thought I could remove it, and I tried. While mobilizing the tumor, I breached the capsule. But immediately I converted and resected it, washed well, and then closed. About 8 months or 9 months or so, she came with local recurrences. And surprisingly, when they put her on imatinib, all the recurrences have completely disappeared, and even today, she's well from that point of view. And Katie Vogleri is from Belgium. He did about 53 primary gastric gysts. He compared between the laparoscopy and open. He found the laparoscopic group fared much better, not only by way of discharge and then recovery and all, and of operative mortality, but the recurrence rate also he found laparoscopic recurrence rate is less than open recurrence rate. And in the comparative evaluation, this is what I said. And the other one is Akira from Japan. He has done about 44 cases, and his average tumor size is 3.2 centimeters, and mean operative time 100 minutes, and mean blood loss 10 mL, and mean hospital stay for 7 days, and mortality is nil, and recurrence is nil at that time. And we did about 12 cases, I did not add any of the cases which were converted to open. And in 12 cases, it was about 4.5 centimeters for each one. And it took about more than 1 hour to do. And then about 40 ml of blood or so, which was lost. And 3.1 days hospital stay. The mortality is nil and recurrence so far, they're nil. The pseudocapsule breaching is very, very, very important thing in these cases. So to conclude, laparoscopic resection for gastric cyst is safe and feasible. Resection should be on oncological principles. The resections were accomplished with no morbidity, no perioperative mortality, and no recurrence and short hospital stay. In conclusion, due to degree of efficacy and the advantage afforded by the laparoscopic surgery, it may be the preferred resection technique for small and medium and gastric cysts. But now we are doing even larger cysts also. Only thing is we have to give an incision and remove the tumor from the abdomen. So I thank you very much to all of you for giving me an opportunity to participate in this symposium, and in particular to Professor Kanagavelu for inviting me. And of course, my friends, Professor Kannan and all others are there. Thank you.
Thank you, sir. Thank you very much for the elaborate lecture about gist of the stomach. I like to know from your experience, sir, do you have come across any cases in the posterior wall of the stomach or tumor close to the gastroduodenal junction, sir?
What I showed on the video is the one close to the OG junction area. That's why we took care of the help of the endoscopist for localizing it. And we put a gastric calibration tube so that my stapling will not narrow the OG junction area. And there is another way of doing this one also, but that's little bit more cumbersome what I thought actually, where like some of the cases I'm sure you might have seen me showing, that's intracavitary pseudopancreatic cyst drainage. Like that, you put a trocar directly into the stomach, and one port will show the endoscope, one port will be the stapling area, endoscope will be showing the tumor. But that's a little bit more cumbersome. And if it is a bigger, you can't remove them. That's the problem through the trocar. And but these are the two. Another one at the pyloric area, I felt quite difficult to operate them actually when you do the segmental dissection. So that's one. But posterior wall is easy. So posterior wall is you do the anterior gastrotomy, and once the tumor is localized by the endoscopically, you take 2 stitches, lift it, and put a stapler and cut it off. So it is probably the easiest operation. And of course, we are going to listen next important operation.
Thank you, sir. And what is your take-home message about the omental patching? Especially there is controversy for the infected cases. It is not doing well much. For these cases, clean cases, there won't be any problem. So what is your take-home message about the omental wrapping?
Professor Kannan, that gives a good night's sleep. That's all actually.
Thank you, sir. Thank you very much, sir.
Yeah, now I'd like to ask Dr. Zakir as well as, can we have Zakir on the screen, please? I'm sure with the amount of ESD and endotherapy techniques, going for a full thickness resection by way of endoscopy is always possible. Reddy sir, what is your take on it? Maybe we can assist with one camera or something from outside, and the endoscopist can do the job. When they can do 2 layers and 3 layers of the stomach, it should not be a very difficult challenge for them to do all through layers. What is your take on it? More of, I don't know, but again, I am just boiling down to the same hybrid procedure what you told, but then giving the endotherapist more work and we assisting them or sort of thing. What do you think about that? Because that way it will be single port, allowing the endotherapist to finish the procedure from their side, and then we stepping in only if there is a need. What is your take on it, sir?
No. The endoscopists can do only certain small GIS. They will not do big GIS. And it is difficult also technically to do the big GIST also. And other thing is when they try to do the big GIST, the chances of the lifting the GIST, the tumor becomes difficult. No, they are helpful in localizing the GIST.
So,
And in fact, sorry, Zahir, I'd like to put a word here. Reddy sir, like with the advent of this endoscopic sleeve gastroplasty, their amount of getting into the surgeon's domain has widened now, and they are able to handle more stomach volume. Let us hear from Dr. Zahir, please.
so I'm sorry, I missed the original question.
No, Zahir, I wanted to check. Sir, you are talking about ESD, EMS, and other procedure. Reddy sir was eloquent in telling the indications, and he said, what is the honest, bias-free advice of what is that thing you need to know your limitation and what is the role of hybrid operations. I was wondering if you people can do a full thickness resection, do a full thickness closure, which at this point looks pretty much possible, especially when you're doing a TAF or a fundo which is available. You have one access through the esophagus into the peritoneum and one scope into the stomach should do same justice what we are trying to do. The POEM team is now almost like they are coming out with standard steps where TAFs are coming up in a big way. And it looks like TAF is going to open up a huge area of, again, I would say it's like a sort of an extended notes procedure, but the TAF gives very close access and having two scopes into the mouth, one onto the third space and one into the stomach. I think this procedure should be technically possible, thinking aloud. What is your take on it?
So I do believe that a lot many of these procedures now we are doing them endoscopically, but realizing the limitations that first is we very accurately characterize that the characteristic endoscopic ultrasound features of the tumor itself. There are many features which suggest that these lesions have worse features on endoscopic ultrasound, and we straight away refer these patients to surgery. The thing is, endoscopic full thickness resection is a reality now because we can close the full thickness wall defects with the suturing device that's available to us now. So previously the problem only was to close the defect. If you create a wide defect, how to close the defect securely before you start these patients on oral diet. But now even the larger, because our traditional limit is 3 centimeter, that we don't interfere with these lesions if these lesions are more than 3 centimeter long. So that is one limitations that we have when we resect these lesions endoscopically. So more than 3 centimeter, we send them for surgery, or a collaborative endoscopic approach is also a very good approach, where the laparoscopist assists the endoscopist in closing the defect, and we without a worry of closing the defect, we resect this in full thickness and take the whole lesion out without any worry. Another thing is the capsule thing, that because we are at endoscopy, sometimes we damage the capsule, and that is something we don't want when we are dealing with a GIST. In contrast to something like leiomyoma, where there is no problem even if you are resecting the lesion in pieces and bits. So in GIST, it has always to be in one piece and without interfering with the capsule of the lesion. So there is something some limitations with the endoscopy. So I think again, I'll say that surgeons and endoscopists, they have to come together to manage these lesions together.
Thank you, Dr. Sakit. I could see Dr. Arnab coming up. Sir, do you have a question?
Not really. It was quite impressive. I think I do also have interest in laparoscopy and endoscopy, and we have done some hybrid procedures. So maybe the kind of advice that he has given, putting a gastric tube, was very interesting. So that's something we could have tried. But we have tried to stay away from the G junction all the time. So we prefer giving imatinib before we actually venture into anything which is close to the G junction.
Thank you, sir. Thank you so much. PK Reddy, sir, thank you for being eloquent and giving a honest advice for the young surgeons here. And Zahir, I think you've been more than gracious to acknowledge the challenges what at this point of time endoscopy is facing. So let us hope both the sciences grow together for the welfare of the patient. Thank you, Dr. Zahir, and thank you, Dr. Reddy. Kannan sir, please take over. Kannan sir, you are in the mute mode, Dr. Kannan.
Okay. And only two questions from the Dr. Haridas and Alex Morai. Can I ask Professor P.K. Reddy, sir?
Please.
Sir, one question from Dr. Haridas. Is there any role of surgical debulking in case of metastatic GIST? Surgical debulking in case of metastatic GIST.
Metastatic GIST, first we always treat them with the imatinib or sunitinib first. Once it shrinks, even whether metastatics or the primary tumor shrinks, then there is every chance there is a role for surgery considering at that particular case.
Thank you, sir. And what is the adequate margin for the GIST excision?
GIST excision, as I mentioned, as one of the papers has suggested, at present with the advent of imatinib and sunitinib and a third generation this thing, even if the GIST margins are positive also, you don't need to worry. But as a surgeons, as we have to follow the oncological principles, for that we need to take at least about minimum 2 centimeters margin at least away from it, because it won't spread into the wall.
Thank you, sir. Thank you very much for your kind advice and an excellent lecture. Next, let us move to the D2 gastrectomy, the state-of-the-art lecture to be given by Professor Arnab Gupta, the president of IASO, and chaired by Dr. G. Chandrasekhar, the EC of National ASI, and as well as Professor Dr. Vivek S. Nathan, Director of Surgical Studies. Dr. Chandrasekhar, please introduce the speaker and proceed.
Good evening, sir. It's clear?
Yes. Yeah, it's very clear.
Okay. Welcome to our ASI Chennai City weekly academic program. And the Chennai, there is a gastro update, ASI Chennai gastro update. It's our privilege to welcome our Professor Dr. Arnab Gupta, the president of IASO. Now is the director of Saroj Gupta Cancer Institute and Research Institute director. He's a surgical oncologist since 1999 and is interested in GI surgery, colorectal surgery, and pancreatic biliary oncosurgery. And he is so much fond of the breast conservative, that is a oncoplastic breast surgeries. And he did his MBBS in Calcutta National Medical College and all specialities in Royal College of England, Edinburgh, and FLAP and FRCS and all the thing. And he is a visiting professor of most of the national and international hospitals. And is the examiner of IMRCS held in India, and also is an examiner for onco surgery, DIPNB also. And is a visiting consultant and a visiting professor and the advisory board for the major hospitals in India and international level. And is presented the lot of papers and publications, in national level and international journals, and is conducted more and more conferences, CME, and workshop in oncological procedures. And he is an international figure, and we invite in our Chennai city. It's a very pride for us. He is not only the academic, is so much interest in other activities like painting and photography and music also. And he is a two-seater aeroplane, is flying. And also did so many social works here. So he's a multi-task hero of our Indian continent. We welcome the president of IASO, Professor Dr. Arnab Gupta, to our today gastro update. Welcome, sir. Welcome.
Thank you very much, Dr. Chandrasekhar, for that very kind introduction. I don't know how you got to know about all this, because I thought my secretary has sent a very brief CV, but
you are a well-known person all over India. This is our pride, sir. Welcome, sir.
And Arnab is a great playback singer also, Dr. Rudra Archarya.
He is very much interested in music. Music also is very much interested.
Well, Well, that's my oxygen, unfortunately.
Yes,
Sir,
yes, yes,
musicians are so intelligent, sir. Their brain works very
many
fast.
of the surgeons in India, many of the surgeons are extracurricularly more active in music and playing instruments and all the other things. So it's our pride, it's our extra work, sir, national level. Very welcome, sir, welcome.
Thank you very much. Now, after all the wonderful speakers, I think my talk is going to be rather basic because I was going to be mostly general surgeon. So I selected a video which is kind of slightly basic to gastrectomy and even a laparoscopic one. But I think it's very important that we talk about the basics, especially when the postgraduates are around. So I will just start sharing my slides. Can you see my slide actually, by the way? Can you see my
Very well
slide?
seen, sir. Very well.
Are you able to see?
Yes, sir.
Perfect, sir.
Good. Okay. So there's a hospital I work in. It was founded by my late father. So after he passed away, the hospital got a new name. It's a charitable, not-for-profit cancer hospital made in 1973. So it's one of the oldest cancer hospitals, and we have all the facilities for 5-star treatment. It's not only the ambience, but the kind of treatment that we provide for even the poorest of the poor people. Now, I think most of the slides have been, which I wanted to talk about, have been mentioned by my previous speakers. One interesting thing, which is good thing for many of us, that the incidence and mortality are actually decreasing for gastric cancer. As you can see, it's gradually coming down. For India, it has been more or less stable. So that's only the bad thing in India, but more or less everywhere it's coming down. Now, is the second commonest GI cancer after is the second commonest GI cancer after esophagus cancer. And I believe that is more common in South India than North India. We see a fair number in Eastern India as well, but I believe that it's fairly common in South India. Surgery, unfortunately, when we are having a surgical forum, is possible only in 20% of patients when you're talking about curative surgery. For palliative surgery, maybe another 18 to 20%. Now, especially with this laparoscopic and endoscopic procedure, especially endoscopic procedure, you don't do open surgery in advanced cases anymore if you can really avoid. So the curative intent open surgery or laparoscopic surgery would be only 20%. And the overall survival, as you can see, is quite dismal, 5 to 18%, really bad. Now, I don't want to read you through this busy slide of NCCN, but basically, I think my previous speakers already highlighted that what is early gastric cancer and what is locally advanced gastric cancer. So basically, mucosal cancer, which is in situ, and when it's involving lamina propria or some mucosa, it's T1 basically. So that's only early gastric cancer, and that's hardly something we don't get to see. That's something we don't really get to see. Maybe the endoscopy see much more. In our cancer hospital, I do endoscopy, yes, but then most of them are diagnosed cases. I might be actually missing out small lesions because I don't have a narrowband imaging with my unit. So I think it's a good idea that I'll probably have to think about that we should have actually a proper narrowband imaging to detect early lesion, because we might be actually missing out on a few. Now, locally advanced, it might sound that these are patients who are not going to have operation, but these are the patients who are actually going to have operation. Quite contradictory to our normal belief that locally advanced, they don't go for operation. Now, what are the locally advanced things? Obviously, anything more than T1. So T2 up to 4B, even if the organ is involved, the adjacent organ, you can still resect. N0 to N3B, so you can have more than 17 lymph nodes positive. There could, and ideally, you should not be operating on a metastatic patient unless it's a palliative surgery. And these are the patients which we commonly see in India, unfortunately. Now, what is optimal surgery? I think this has been nicely covered by my previous speakers, so I'll skip this. Antral gastric cancer, obviously we have to resect the distal part of the stomach. And what is the normal margin? Proximally it should be, if it is a protuberant growth, at least 2 centimeter, but if it's an infiltrative growth, at least 5 centimeter. To be on the safe side, it should be at least 5 centimeter, and ideally you should be resecting at least 2/3 of the stomach. Ideally, you should go up to the first short gastric artery so that you don't actually end up with a positive margin in case it's an infiltrative growth somewhere. Now, about the distal margin, it's usually 2 centimeter. You don't want to cut the D2, obviously. You have to cut a D1. And if it's going anything beyond, if it's involving the head of pancreas, normally it's inoperable. Large tumors involving the gastric body. And if it's mostly involving the lesser cup, obviously it's very difficult to save the stomach. So you often end up doing a total gastrectomy. What about proximal gastric cancer? Many people are kind of in favor of doing proximal gastrectomy, but that's not recommended because you can have a lot of complications. There will be a lot of reflux esophagitis. So what you should ideally be doing, which will give a better quality of life, even a better chance of survival is a total gastrectomy. And obviously, you do a reconstruction. It's normally a Roux-en-Y reconstruction. Now, a lot of people, especially youngsters, are kind of confused. What is R0? What is D0? Whether they are interchangeable terms? No. R is resection factor. So depends, what sort of resection you've done. If it is a potentially curative resection, where the pathologist will tell you that you got a negative margin, that's R0 resection. Yes. What about R1? You thought you have done a proper R0 resection, but the pathologist will tell you that you actually have got a positive margin, either on frozen section, which is sometimes not easy, or on actual formal histopathology, that you got a positive microscopic margin. So that's R1. What about R2? When you know that you have left behind a lot of disease, you yourself know. So that's R2. That's a gross residual disease. What about D? D is basically lymph nodal dissection. So D0 obviously is inadequate. Even group 1 nodes are left. I'll come to what are group 1, group 2 nodes. And in D1, you remove the group 1 nodes, which are basically perigastric nodes, but you don't actually remove the group 2 nodes. And D2, obviously, where you remove both the group 1 and D2 group 2 nodes. So you have done an extended dissection to take away all the D1 and D2 group of lymph nodes. So I'll come to the picture straight away. So just to revise our anatomy, I'm sure you all know this. This is a very basic slide. But if you look at this picture, this is on the right side of the cardia. So that's station 1. On the left side is station 2. Anything along the lesser curve is station 3. Along the lesser greater curve is 4. 4 has got the S and D part as well. And then suprapyloric and subpyloric. So station 5 and 6. So that's all perigastric nodes. Along with that, actually in D1 dissection, you should actually be taking the station 7, which is not shown here. It will be shown in the next picture, which is along the left gastric artery. So that's also within D1 dissection. It's not a D2 dissection if you say remove the left gastric artery lymph node, because that's a new Japanese classification. If you talk about the group 2 lymph nodes, so let's start from 7. That's the left gastric artery I was talking about. 8 is the common hepatic artery, which runs along the superior border of pancreas. 9 is the celiac axis. 10 is the splenic hilum. 11 is the superior splenic artery. It has got a proximal part and a distal part. And 12, AV is there. A is something which has to be removed, which is along the left border of the porta, which is along the hepatic artery. So these are all within D2 dissection. You can remove other nodes as well, but that's not standard recommendation as per Japanese guideline as yet. Now, D2 lymph node dissection is traditionally recommended in Japan since 1960. They don't have a long-term trial on RCT actually between D1 and D2. You'll be surprised, but that's not unexpected, because the kind of result they have and the minimal complication they have from D2 dissection and the kind of long-term survival, there's no point doing any randomized control trial on D1 and D2. They have done trials between D2 and D3, but for the time being, we had a discussion recently with a Japanese surgeon, quite a famous surgeon. He also sticks to D2, not into D3. MRC and DAS trials have got certain criticism. These are mostly European studies. And the criticism is because most of them are not trained in doing D2 dissection. So there was a lot of lack of experience. And also many of them actually had been doing splenectomy and pancreatectomy as a routine procedure, which obviously increases the postoperative morbidity and mortality, and it offsets the benefits of D2 gastrectomy. But even then, if you look at, so that was the kind of early result they had. The mortality was quite high. 5-year survival almost similar because of these reasons. But Songan et al., he published his long-term survival on Dutch trial. That was in 2007. Now we have got more data on that. So there is actually a wide difference between D1, D2 dissection even in Dutch trial. So in D1, the overall survival is 21%. In D2 is 29%, which is statistically significant. Gastric cancer-related death is less in D2 dissection, and local recurrence rate is almost half. I've got 10 minutes video, so don't be kind of feeling bad that I'm actually talking about the basics, but unless I talk about the basics, it's difficult to explain the video. So the survival, if you see, between US and Japan, there's a huge lot of difference. And the reason, I'll come to that in a minute. Normally, it should be removing at least 15 lymph nodes. That was the normal recommendation. And if you look at the data from Europe and US, you'll be surprised. Only 18% had 15 or more nodes removed. So that was obviously very suboptimal surgery. In US, almost more than 50% of the patients undergo D0 dissection. I'm not talking about big centers like Memorial Sloan Kettering or MD Anderson, but many general hospitals, they will be doing only D0 dissection. And obviously the lymph nodal recurrence is much higher there, and you don't actually get to know the proper staging because you don't do a proper dissection. Whatever splenectomy and distal pancreatectomy, it has been clearly proved that is not much of a benefit unless there is a local infiltration. Now, just going before going on to the video, reconstruct a small sketch that I had managed to put up in the last minute before I could, show the video, because unless you understand what reconstruction is going to do, it's difficult to explain what is supposed to be done. So basically, I've taken 3/4 or at least 2/3 of the stomach off, along with all the nodes. D1, D2 dissection has been done. Now the duodenum has been stapled. Now, just a suggestion from my side. A lot of people try to save on cost and they don't actually staple the duodenum. In our early experience, maybe 15 years back, we had not quite a few, but at least 2-3% of them actually had a duodenal stump blowout, and that's a horrible thing to handle. So these poor patients actually will spend more on nutrition and many other things. So it's better you actually staple the duodenum. It's much easier, much safer. And then if you have the resources, obviously you staple the stomach along the lesser curve, and then you leave a gap here so that you can do a side-to-side bypass with the jejunum. It's Roux-en-Y bypass. There's no point doing a Bildroth 1 and Bildroth 2 nowadays. It's much better for better quality of life and oncological safety to do a proper D2 gastrectomy and then do a reconstruction of Roux-en-Y loop. So basically, the jejunum is divided beyond the first arcade. The stapled end is brought up. You do a side-to-side bypass, anastomosis between the stomach and the jejunum. And then you do a jejunal-jejunostomy, which has to be at least 40 centimeters away from the gastrojejunostomy. Otherwise, again, there's going to be a lot of bile reflux. So that 40 centimeters has to be there. In addition, what we also do, put an NG tube into the gastric tube, gastric remnant, so that you don't have a lot of reflux. Postoperatively, the patient might vomit actually, especially if the patient had a chronic obstruction. And secondly, we also put a Freca tube down the nose into the jejunum so that the patient can be started on enteral feeding pretty early. We have stopped doing feeding jejunostomy for a simple reason that it's an additional procedure. People can actually pull up their feeding jejunostomy tube while in the post-op phase. They can be in a kind of psychological stress. And I've had experiences where there was a lot of spillage of bile because of the tube being pulled out. So it's much easier and safer to put a Freca tube into the jejunum through the same anastomosis, and it's not much of a problem. Now coming to the video. I request to kindly mute the sound if you can from your end because there's a lot of noise, I think. So what we have done, we are putting omnitrack retractor. From your side, kindly, if you could kindly mute the sound because I think there's a background noise there. So now what we have done, we have lifted the stomach and made sure that is operable. We normally put a laparoscopy. It's not shown in the video before we actually venture into the operation. And normally we send a stomach wash, look for a frozen cytology on the fluid before we actually open up. Now, this is the first step. Normally, you dissect out the omentum from the transverse colon. People might argue whether you need to remove this gastrocolic omentum. Even the Japanese people, if it's a big tumor, this is a T4C tumor. Sorry, T4A tumor, pardon me. So there you ideally should take the omentum off. It takes hardly another 10-15 minutes. So along the congenital plane of adhesion, you dissect the gastrocolic omentum from the transverse colon. So you start from the left of the midline where the planes are easier, and then gradually come to the hepatic flexure. So it's that way you gradually come towards the hepatic flexure, bring it down, and if you see any vessel, obviously use the energy device. Otherwise, diathermy electrocautery is good enough. So now this patient, you can see, has got some subpyloric nodes. We are taking with the specimen. They're being dissected towards the stomach side. Now we're trying to identify the gastroepiploic vein and artery. They are usually secured separately. All the lymph nodes are being pushed towards the pylorus. So those are station 6 subpyloric group of lymph nodes. Now, if you can clearly see here, that's the gastroepiploic vein, and that's being secured, doubly ligated on the patient side, single ligation on the other side. That's the tumor just proximal to the gastroepiploic prepyloric vein of Mayo, prepyloric vein of Mayo, and there's a small serosal involvement that we saw. This is the gastroepiploic artery, which you can see has got a lumen, so that has to be transfixed and ligated as well. So that's being done. Now the duodenum, first part of duodenum is bared from all the fat and the lymphatic tissue. so that it's easy to divide the first part of duodenum. As I said, we normally staple it. So we have hooked the duodenum up and the pylorus up, put a finger behind, and now we're going to divide the lesser omentum. Now we are opening up the fascia in front of the portal structures, and that's where you're going to find the right gastric artery and vein. So those are the arteries and veins that you need to secure. These are going to be the tumor supplier. Veins can be divided by energy source, but arteries should be ideally ligated. So once you've done that, the next step we are going to do is expose the common hepatic artery by doing the lymph node dissection. So that's the linear cut I was talking about. Is might as well spend 4,000 or 5,000 rupees on that. Usually use a blue cartridge. Nowadays you got three rows of staples for which you don't need to oversew. But if you have 2 rows of staples, you might as well oversew because there can be bleeding. So that's the stapler which is going in. You fire the stapler and it's divided. You got safe margin from the tumor, at least 3 centimeters. It's well beyond the pre-pyloric vein of Mayo. The stomach is being held up with the retractor. Now we are going to oversew the stapled end of the duodenum. Interlocking stitches with triovical because it can bleed from the staple line. It's quite vascular actually. Now this is an important step. Like I said, expose the common hepatic artery. So we are using energy source to dissect off the lymph nodes from here. This is station 8 that I had mentioned earlier. So the station 8 lymph nodes are being sent separately. Now, if you see here, you'll see the common hepatic artery. That's the common hepatic artery. I'll show you. I'm so sorry. The video has skipped. Can I? So sorry about that. So that's the specimen. No. Oh. Yeah. So that's the station 8 lymph node. You can see the common hepatic artery. Now we are working on the left side of the porta, so exposing the hepatic artery. Sorry about all this skipping about the slides. So what we are doing now is the 12N lymph node dissection. So all those lymph nodes are being taken off. So common hepatic artery, proper hepatic artery, the left hepatic artery, they're all exposed. And these lymph nodes will be sent separately.
I think there is some technical difficulty. Connects.
Yeah. Okay, we will wait for sir to come in. Now, Sudipta, are you with us?
Yeah, I am here.
Yeah, Sudipta, like as sir comes in back to us, I would like to bring in one important question, which is a little out of the topic. How do you say the learning curve of B2 gastrectomy is? See, many studies have told the number of nodes, many studies have told what is the extent of resection, how much you clear, radial clearances, all those things have been talked about. But I know you've been in the teaching side, imparting both specialty and super specialty education for almost 2 decades now. The radicality, do you think it increases with the experience, or it is fundamentally the same with everyone?
Yeah, definitely. With progress, like even if you you do like your 10th case, the lymph node dissection, you should have an interest and you should be interested to improve your learning curve and your lymph node harvest. So by 10th case, definitely it will go up, and by 25th case, you'll be your lymph node not 15, you'll be reaching like 25 to 30 if you do a standard D2 lymph node dissection. So due to the most difficult part, what we get is going around the celiac and taking out and the splenic, both the 10 and 11 stations. These are the difficult places which you have to master with experience. And of course, one point, if you think you are a good surgeon, your lymph node harvest should be good, and it is not coming as it is always 15, 16. You have to hammer your pathologist, not hammer, it's the wrong word. You have to sit down with your pathologist. I have done that. I have done that with my Whipples, and I have got increased number after that.
I understand. I could see Dr. Rudracharya raising the hand. Rudra sir, can you switch on your video, please, and give your thoughts?
Yeah, to increase the lymph node harvest, the best part will be when you are doing a open surgery, always use the vascular loops and completely dissect the arteries, hepatic artery, and lift the vessels. Because sometimes what happens is you are simply doing the surface lymph nodes, and there are some amount of nodal tissue remaining behind, which I find very common at the 12A, B, P, behind the portal vein, behind the common hepatic. So these are the places where we leave the lymph node tissue, which might be carrying the microscopic. So to increase the harvest, if you use the vascular loops, completely bare the vessels, and do the nodal dissection around, because nodes are nothing but it is not only on the surface, it is on the 360 degrees, it can be on the anterior posterior side, everywhere. So with that, I have found the lymph node harvest going up to more than 40 actually.
Point is well taken, sir. Now I'd like to hear from Professor Tabish Shala, sir. Tabish sir has a lot of experience working both in UK. He has worked in the Johns Hopkins and multiple hospitals in the United Kingdom before returning back to the Pakistan for his tenure. In Pakistan, when does a resident get to do a gastrectomy, and then when is given full autonomous like what he can do an autonomous on his own gastrectomy? So how do you go for the education part of it in training resident?
Right. Thank you very much for this opportunity and inviting me. Thank you for Indian Association for Surgeons. Now, as is the case in most of the subcontinent hospitals, there are two kind of systems. Now, the public sector and the private sector. Now, in public sector systems, as I understand, everywhere, the trainees get to do a lot more, mostly under supervision, but earlier in their training. In private sector, because the patients are paying either themselves or a third-party payer, the consultant involvement increases. But having said that, we in our hospital have a 5-year residency program. The College of Physicians and Surgeons of Pakistan requires 4-year training. So we have one additional year of kind of elective rotations, and that gives us more time to train our residents. If we start taking them along from year 1 and their independence increases, but they are not allowed to do an independent gastrectomy even when they are in the 5th year of their training. The extent of they are able to do dissection, including the lymph node dissection and everything, depends on individual skills. The consultant is always scrubbed and they get to do the whole thing, but consultant has to scrub in such cases. But then we have post FCPS fellowship. And for post FCPS fellowship, the fellows get to do a lot more and mostly independent. The surgeon has to be in the operating room, may or may not scrub depending on the expertise, but those are 2 years of advanced fellowship where they get to do independent cases more often.
Point is well taken, sir. Like we are waiting for you to hear the talk on the complications of gastric surgery. In the meantime, I will have a couple of questions to the other faculty. Dr. Sharad Desai, are you with us? I think we have Dr.
Yeah,
Arnab
of
back
course.
with.
Yeah.
Dr. Sharad, what is your take on it? I'm sure Maharashtra is another major training point for surgical oncology. Starting from TMH, you have multiple training facilities. You have already specialized on MCH in GI oncology in Maharashtra, first to start in the entire country. Then now organ-specific oncology is also coming up. What is your outlook on long-term organ-based oncology training? What is the prospect of things are going to happen, Dr. Sharad?
Yeah, it's very interesting that you asked me this question. Let me clarify one important thing. I come from a very small town in Maharashtra. I come from Miraz. Miraz is on the border of Karnataka and Maharashtra. And it's not even a district place; it's a taluka place. So I'm practicing in a very different atmosphere compared to all of you people, especially sitting in Chennai. Yeah. So what I look at, see, Maharashtra, unlike Tamil Nadu, is a very heterogeneous state. At some areas, the East Maharashtra and all that very backward, and at some places like Bombay, Pune, it's quite far ahead. In places like Bombay, even in the private sector, people are specializing in organ-specific branches, which is little difficult to accept in the rest of the country. In a place like mine, it's not possible to practice organ-specific oncology. Though in my particular hospital, we have divided our oncology in two parts. That's head and neck, which takes the bulk of oncology, and the non-head and neck. The future, I presume, and I hope it will come, because there is an increasing number of specialists coming all over, that we should go to have organ-specific oncology sooner. I mean, in another 5 to 10 years, probably in the smaller towns also, we should be able to get organ-specific specialists. And definitely in places like China, I think people have to sacrifice and specialize in one small organs.
Perfect, sir. Perfect. I think, in fact,
have I made my point clear?
Yeah, very clear. And in fact, we appreciate the services which is being rendered from a tier 3 city or tier 4 city, what you're talking about, like a taluk place, and still giving the best of the oncology services to the residents of that part of country. My viewpoint, I'm from a very small town of Tamil Nadu. Now, having settled down in Chennai, I still feel the cancer is the same wherever people reside. Okay, people's behavior may change, or people's lifestyle may change depending on where they are residing. But if it is a gastric cancer, the behavior of gastric cancer is its own, and I'm sure the amount of commitment and amount of energy a doctor spends in is definitely the same. But the challenges a doctor faces in a taluk level place is definitely higher, both on financial side and technical side and training side. We appreciate your hard work, sir.
Yeah.
Yes, sir.
Different. Yeah, I will again elaborate on this. The challenges are different in two types. There are some challenges which we do probably as amongst the best places. Like, let us say, the microvascular surgeries. In microvascular, you don't really need any high level equipment, not high costs also. So we tend to do them right, left, center. And in fact, even supra major surgeries, like here in my town, we do a lot of liver resections. We do even Whipples with the portal vein resections and all that. Such kind of surgeries is just easily possible here. But then when we say about something about laparoscopy, robotics, the staplers and all that, it costs. And that is not possible in the smaller towns.
I think I'm back actually. I mean, if I'm still audible.
Arnab sir, thank you, Dr. Sharad Desai. We will now get back to Arnab sir for his talk. Arnab sir, you can start sharing the screen and continue your presentation.
Yeah, I will just manage to put the video on back again.
You want me to show the video? I can do. You let me know.
So I think Dr. Arnab is here.
Sir, Arnab sir, should I show the video for you? What is that you want me to do, sir?
Is it visible video now, or is it not?
Sir, we are able to hear you well, but unfortunately, we are not able to see your video, sir.
Well, I think you can play a video from your side, because otherwise.
Let me try, sir. Let me try. Give me a minute. Give me a minute.
Sorry about this.
No worry at all, sir. We understand. Are you able to see this, sir?
Yes.
No.
Yes.
Yes, sir. You can now. Is this point okay for you, or you want me to advance or back? Go back. You let me know.
Hello.
Yes, sir. We are with you, sir.
Okay, right.
We are playing the video.
Okay, if you can,
We are restoring the continuity. You are doing a GJ now. Hands-on GJ is being shown, sir. Are you able to watch the video, sir?
I'm not able to watch. Sorry.
Sir, what I will do is, I will right now stop the video. We will wait for your connection to get restored fully, sir. We can definitely have this at a little later point also. Will that be fine? Anytime you are okay to do it from your side, you let us know, sir. We'll be happy to have you.
No, it's okay.
Now, with your no, sir, please stay with us at your convenience. Once the internet gets fully restored, you should be able to do it by yourself, because I guess you have challenges both transmitting and receiving the video. So that will make your talk difficult, because unless the synchronization of your video steps and the talk has to be going well. Sir, we have another 1.5 hours to go, so no worries at all. We will be having your talk little later. Is that fine, sir? Dr. Rudra, can you try reaching out Arnab, Dr. Rudra?
Yeah, I will call him. Okay, okay.
Yeah, you can tell this. Anytime sir's thing is getting all right, you can ask us to inform, then we can have him back again.
We can go to the next speaker if possible.
Yeah, Kannan sir, I think we will have the next talk.
I asked Dr. Pandirajan.
1 second. 1 second. Arnab sir, your video is back.
I've just managed to log in from my mobile. So if you can play the video, I should be able to.
Let me try, sir. Let me try. Give me a minute.
Yeah.
Just check. Are you able to see this?
Yeah, it just popped up now. Yes.
Yes.
So basically, what we are doing now is dissecting along the celiac axis, left gastric artery, proximal part of the splenic artery. So we are dissecting all the lymph nodes from there. And then we'll also be dissecting down the pericardial node from the station 2. It's just in the right hepatic artery, sorry, the common hepatic artery, all the lymph nodes being taken off. So all you are left with is station 1, which will be taken down in a minute. So what we have done now, I think, because we are doing the resection now, we have put soft clamps on the stomach. We made an opening, which is going to be anastomosed, and then using a green stapler, the gastric wall was very thick. So removed the specimen, and we are overseeing the staple line with 2O silk. And then when you come to the corner, obviously you put a corner stitch so that there's no angle of sorrow. The staple line is totally secured. The opening is at least 3 fingers for the anastomosis to be done. This is the jejunal loop. We are dividing beyond the first arcade. So obviously any vessel in between has to be divided. And that's the jejunum beyond the first arcade, which is going to be divided between clamps. Here we are using a blue cartridge. You can do a hand-sewn closure of the blind end, but here we are using a blue veneer stapler. for the distal end of the jejunum, which is going to be brought up for the anastomosis. So there's the proximal end, which is going to be used for end to side jejunostomy. There's the distal end, which has been brought up. We have made a similar opening, three fingers, and it has been placed next to the gastric opening. Now, this anastomotic technique is slightly different. I know there are different ways of doing it. You probably will be different in different way. This one is, we are starting right in the middle on the posterior wall, through and through, inside out on the stomach, outside to the jejunum. So right in the center, we start there, and then we'll go up all the way towards the superior corner. We'll put another stitch in the middle and we'll come down to the inferior corner. So 2 separate stitches, full thickness. So that's the superior corner. Once that's reached, we'll start doing the inferior aspect of the anastomosis, posterior wall. Another suture right in the center on the posterior wall, full thickness, and then gradually we'll come down to the inferior corner, and then gradually to the anterior wall. So now we have come to the anterior wall, again full thickness stitches, and we'll meet in the middle. So the one at the superior aspect, one at the inferior aspect are going to be joined together in the middle. There will be a complete closure. That's the one. And then we'll start the seromuscular suture with 2O silk, starting at the inferior aspect on the anterior wall, going up to the superior corner. And then we'll turn the anastomosis so that you can see the posterior wall, and then we'll continue the suture posteriorly, the seromuscular suture, to complete the anastomosis. So that's the complete seromuscular layer. And then, like I mentioned, it's probably not shown on the video that the trachea tube has been passed down the jejunum, past the jejunostomy side, so that is used for the feeding soon after the operation. That's the end to side jejunostomy. Posterior wall is through and through, and
Dr. Arnab, you would like to have the PowerPoint again, sir? I think we again lost it. Dr. Arnab, sir? Okay. Kannan, sir, I think we will have questions a little later for Dr. Arnab. We move on to the next talk.
Dr. Pandiraj, you please kindly introduce the next speaker. Dr. Pandiraj?
Yes, sir, I am online.
Yes, please go.
Good evening, everyone. It is a great honor for a student to introduce his teacher. I am honored to introduce my teacher, Dr. Sudipta Kumar Singh. He is a consultant surgeon from Apollo Hospital, Maine, Grimswood. His special interest in laparoscopic and robotic surgery, particularly GI oncology and HPV surgery. He did his undergraduate and postgraduate in SCB Medical College, Cuttack, Odisha, followed by years in fellowship in minimal access surgery and fellowship in gastrointestinal endoscopy and colonoscopy, followed which he did his super specialty surgical gastroenterology training. Then later he underwent training in robotic surgery and cytoreductive surgery and HIPEC. He has a lot of publications, both national and international journals. He is a reviewer as well as editor in many national and international journals. He is an invited presenter and orator in most of the national and international conferences, particularly in GI as well as in HPV conference. He received a lot of awards. His renowned award is Best Faculty Awards in MGMCRI and South Zone Surgical Gastroenterology Young Scholar Award in 2005. He is a faculty for DNB Gastroenterology training as well as faculty for JJ Institute for Animal Lab and Cadaver Training. And thank you very much, sir. He is also as a executive member in ASI Chennai City branch. Over to you, sir.
One moment, Dr. Sudhita. I think we have Arnab sir back. Arnab sir, you would like to have the questions here. You want to have your PowerPoint shown before Sudhita is part of us. I can request him to wait. Should you need to finish your talk?
If you really want to, I've finished with the video almost, but no.
Video is completed, sir. Your video is over. You want me to show the PowerPoint?
Just 2-3 slides I had, but it's not
Yeah,
important.
I will do that because
Okay.
let us allow you to finish so that you are at comfort. One moment, sir.
It's never had happened to me.
Not at all, sir. We understand
Okay,
this
sir.
type of
Sometimes
internet challenges are always trouble.
And that's one reason we postponed the NatCon for this year, because we have
I understand, sir.
of technology problem.
Sir, are you able to see the slides now?
Not come up in a minute. Yeah, I think it's coming up slowly. Yes.
Sir,
Yeah,
you please guide me where from you want to
go past the video slide. Go past
yes,
the
sir.
video
I'm doing it. I'm doing it.
Yes.
Can I leave you here?
Just stay here for a second. Yeah. So just to show you that this patient, this elderly man, he's quite happy. You know, his nutrition status was not brilliant, but he's quite happy with a nasogastric tube and a trachea tube down the nose. And we actually obviously removed the NG tube when it was not draining much. And once he was eating adequately, we removed the trachea tube as well. And the drain when it was not draining much, and it was almost 5-7 days after the operation. So that's a normal thing that we do. Initially, we had been doing feeding geniostomy, but I think trachea tube is a better idea. So next slide, please. Next. Yeah. So I think we have covered this. We also do a lot of enteral stenting, especially in people who have ascites. Not even a gastrogenostomy is recommended for this sort of patients. So stenting is good enough for the next couple of months that they're going to leave. Next. Coming to the next part, yes. Laparoscopy is very important. It only takes 5 minutes to put a laparoscope and assess the disease before you actually open this patient up. You can pick up occult metastases which are not shown up on the CT, even a good high definition CT scan, and it has happened to us on almost 5-7% of cases. And ideally, you should be sending a washout even before a very clean cut case for a cytology report to come through. That's what the Japanese people do. So it takes about half an hour to know whether the cytology is positive. If it's positive, ideally you should not proceed anymore unless the patient needs some form of surgery for his obstruction. And next, we have some experience in laparoscopic gastrectomy next, but that's not something we're going to show here. It's still mostly recommended for early gastric cancer, not for locally advanced gastric cancer. I know a lot of people are doing in India as well. It has got a lot of advantages, but long-term results have to be awaited before we actually do it as a routine procedure like lap cholecystectomy or lap colorectal surgery. Next. Next. So take-home messages. Next. It's quite a busy slide, but I think we have covered that T1A should be an endoscopic resection. Anything beyond that should be a proper resection. And that's all been nicely laid out in NCCN guideline. I'm not going to read out that. Next. So D2 gastrectomy should be done. If it's done properly, it increases the disease-free survival and overall survival. But you should try and preserve pancreas and spleen unless it's really recommended. Large tumor at the greater curve, close to the splenic hilum, you might have to do a splenectomy, but not otherwise, not routinely. And D2 is definitely better than D1 and is definitely better than D0, as we all know. Next. Thank you very much, ASI Chennai. Thank you, Dr. Kanagavel, and all the faculties for inviting me and partnering with ISO. It's a great honor to be here. I'm sorry about all the technical hitches, but I hope I could convey at least the basic message to the junior people. Thank you very much. Next slide. Thank you.
1 second, sir.
If you have any questions, I'm quite happy to answer. Otherwise, we can also move to the next speaker.
Is that the last one, sir?
The last slide. We, like I said, even for the poorest of the poor, they get all the latest facilities. That's the kind of ambience. My elder brother happens to be an architect, and we make sure all the children are happy. We got a toy train and all the latest facilities that is required for cancer treatment. And I would invite all of you to visit the hospital when you have an opportunity. Thank you.
That's so very amazing to have a president and secretary talking about economically challenged provision of cancer care. state of our cancer care to the any common person, and we have worked hard to provide the best of the care, irrespective of the economical background. It's nice to see a president and secretary on the same harmony, catering to the poorest of the and the most neediest one in the country. And I think I could see Dr. Tabish showing up his hand. Dr. Sudipta, give me a minute. Let Dr. Tabish.
Sure.
Tabish, I wanted to tell something, sir. Professor Tabish Chavi.
I just wanted to ask a question.
Please, sir.
Professor Arnab, what is your routine about MDTs? Do you have regular MDTs pre-operatively?
100%. Not even for pre-operative. Even if they have to go on to palliative chemotherapy or any treatment, they'll definitely go through MDT. So that's a routine thing we have on every OPD. And not only about the guidelines, but we also look at the patient holistically. That's something I want to convey to the junior staff. We don't want to prescribe the most expensive chemotherapy to a patient who can't afford 2 square meals in a day. So apart from the normal guidelines that we have, but we also should look at the patient holistically, especially the socioeconomic status.
Dr. Arnab sir, there is a question from the floor. Dr. Haridas is asking you, the level 10 station in the Japanese classification is D2 plus dissection. What are your thoughts about this change, sir?
The change in what? Sorry, I couldn't hear properly.
Sir, he goes on to say the level 10 node.
Yeah.
Level 10, I would say 10 station. It should not be level 10. It should be 10 station.
For distal gastrectomy, it's not a routine thing, but for total gastrectomy, yes, it should be done. Like I said, if you're having difficulty, dissecting the station node, especially for total gastrectomy or for proximal gastric cancer, then you might have to do a splenectomy to get a proper clearance, especially for a big tumor around the greater curve proximally.
No, it is not here.
So for a distal tumor, like I said, it's not a routine thing.
That's what I'm telling you. If you've got some next minute, it will take 1 hour to do and come.
Sir,
I hope I was
audible. Yes, sir. And one more question from Dr. Suraj. Do you offer neo-adjuvant chemo and reassessment of surgery in a patient who has only cytology positive disease but no peritoneal disease? What is your experience, and also what is the panelist comment?
Sorry, the experience on neo-adjuvant.
Yes,
neo-adjuvant, if we have a patient who doesn't have any obstructive symptom, number one, GC is not bad, and thirdly, the patient is upfront operable. It's not a bulky disease. It hasn't got much of lymph nodes. We'll probably operate straight away. But any doubt on the resectability, any loss of fat plane between the stomach and the pancreas, any bulky lymph node around maybe say celiac axis, these are the patients who definitely will have neo-adjuvant treatment. Nowadays, plot regime is the recommended one. But if it's having obstructive symptom and the patient hasn't got obvious metastasis, then upfront surgery will be recommended.
Thank you, sir.
Obstructive symptom, the patient will go for surgery. If not obstructive symptom, if it's an early disease and the nodes are not that much, again, upfront surgery. But anything in between, which has got a big tumor, we're not very sure about the plane, the lymph nodal stations might be quite heavily involved. So these are the patients who will definitely undergo magic trial, neo-adjuvant chemotherapy. But again, we have to decide according to the patient's perspective. So it's not a routine thing that we always recommend magic trial for everybody.
Thank you, Dr. Arnab. We urge you to stay back so that we can hear to your wisdom during the multidisciplinary panel, which we have planned just after this couple of talks. Thank you, Dr. Arnab, sir, for this contribution. I'm not sure what the challenges have been on the internet rather than the science of surgical oncology or science of the management of gastric cancer. But then it happens. Thank you for being patient. And in fact, the idea of you sharing the video to me definitely has worked, and you are able to foresee the troubles. Thank you so much, sir. It's a lesson learned for us also. Dr. Sudipta, you can take over again.
Yeah, thank you. Am I audible?
Very well.
Okay. So this is a bit difficult topic what I'm going to tell because we are talking about last few presentations about conservative surgery which and more of safety. This is like how much radical we can be and what extent we can go. Like a little bit of thinking in Japanese way. So when 2 days ago I was asked to present, I thought I'll discuss this and mostly the evidence what we have in last 1 decade or last 1 or 2 decades and discuss what inference we have got from that regarding the radicality beyond the standard what we are discussing. So what is radical in gastric cancer when you discuss? So radical means, is it just the lymphadenectomy, D1, D2, D3? Is it the bossectomy or omentectomy? Or is it the multi-organ resection? Is it the metastasectomy? Is it the cytoreductive surgery which has been added to gastric cancer surgery? So is more radical and extended resection better in gastric cancer? Hope it is not always, but there will be specific group of patients where it may be useful. We have to look into evidence. So I will be mostly discussing evidence, nothing else other than that. So this is the standard description of lymph node stations and the D1, D2, D1 plus. So then we'll be coming to like what is the recommendation to do D1, D2 and beyond that. So D2 is the standard for most of the T2 to T4 with lymph node positive tumors. D1, particularly if it is very small like early lesion, very early lesion or selected T1B lesions without any adverse factors like not poorly differentiated or not a large T1B lesion may be considered, otherwise D2. Where can we consider D3? That is the para-aortic lymph node dissection or the station 13 to 16 dissection. Does it have survival benefit over D2 dissection? What is the mortality? What is the morbidity in these patients? So we are still discussing about the Japanese trial 9501, but there are many other trials which have come up, many other meta-analysis which have come up to tell there are a specific group of patients where you can think of. So this is the 2006, the trial from Taiwan, discussing that whether we can think of doing D3 dissection. So this is a randomized trial, 221 patients, 110 and 111 in both the arms with curative intent. The most important thing is always whenever you think of doing a proper D2 or going for a D3 dissection, trying for that, the surgeon should be experienced, you should be trained. So that is what happened in this trial also. 3 participating surgeons who had done at least 25 D3 dissections. And the main endpoint was overall survival and disease-free survival, that is long-term 5-year survival. So the 5-year survival in D3 surgery, those who assigned like in D3 category was slightly better, and it was not only slightly better, it was statistically significant, though it is looking like 59 was at 53%. And those patients who had R0 resection, if you divide into 1 and 2 groups, then we had better benefit in D3 dissection, and it is mainly when considered experienced surgeons. This is the trial which we are discussing and quoting even the NCCN, the Japanese trial 9501, which happened in the randomized trial 2008, comparing D3 with D2 with D3. Large number of patients, 260 and 263 in either arm. What we got in that, as we know, Japanese, they are good in lymph node dissection, and even though there was quite significant increased duration of surgery, the blood loss was higher in D3 group. Surgery-related complications were more in D3. The 5-year survival rate and disease recurrence-free survival rate were not different, either both in one-sided and two-sided. P-values were not significant. So the conclusion was extended D2 or D3 dissection involving the para-aortic lymph node dissection, particularly in advanced case like T3, T4 tumors, is not going to help. and it increases the morbidity and mortality. But if you do the subgroup analysis of this study, you see the 5-year overall survival rate in histologically detected para-aortic positive node was more in D3 group, 18.2% versus 8.5%. That's significant. So if your para-aortic node is positive and doing a D3, probably it may help. The complications were not significant for major complications on either arm. It is only because the minor complications numbers were more, and when you compare, it becomes statistically significant. No patient disease received adjuvant therapy till they developed recurrence. So there are a lot of things, subgroup analysis and the disadvantage of adjuvant, not getting adjuvant therapy is there. In same Japan, now there is a phase 2 clinical trial where the earlier report after 3 years overall survival has been seen to be quite significant, 59% for like with para-aortic node dissection, particularly with off-front chemotherapy involving cisplatin. So things may change. We have technologically we are improving chemotherapy and other biological drugs have come up. So this is another trial from same Japan multi-institutional study regarding para-aortic lymph node dissection comparing D2 versus D3. At the same time, this is not a RCT, but involving 580 patients, and they compared 430 versus 115 D3, and they found tumors, particularly which are large, more than like 10 centimeter or at least 5 centimeter, and with positive lymph nodes, probably have a better survival with D3 dissection. What are the other RCTs and meta-analysis talk about when we discuss D3 lymphadenectomy? So these are the articles from like 2008, 10. Like all the articles do not give any survival advantages, though safety have been proved in 2 of these articles. Like Wang, he told there is a safe operation, also para-aortic, what we get in 2010. That time also he proved that D3 doesn't carry significant more complications than D2 dissection. Same if you see another article which was published in 2015 from Italy, where they didn't find any extra morbidity or mortality in D3 dissection, and particularly if it is done by an expert's hand. We have other studies, though they are not RCTs. We have good meta-analysis, multi-center observational studies, where we find that the D3 dissection may help in a specific group of patients, particularly when it is advanced stage like T3, T4, diffuse histology, location is either upper third or middle. So probably D3 gives an advantage. So then another group where they found that particularly when you do this, what I was talking about in 2014 trial that from the Japan, that probably when you give upfront chemotherapy with cisplatin, maybe we have a longer survival. So we have to wait for further RCTs to prove this. So this is a picture which we love to discuss, like different groups. When you have extensive metastasis, we don't have to think, chemotherapy is the answer. When we have a standard like a T1 lesion or T2 lesion with lymph nodes, so most likely D through lymphadenectomy is the standard. But is it like a small metastasis in a D3 lymph node? Is it going to benefit by dissection and removing that lymph node? Whether upfront helps in giving a better survival with D3 lymphadenectomy, that's a gray area we have to see in coming next few years. So still the NCCN stands with D2 lymphadenectomy. It says spleen and pancreas should be preserved as far as possible. The standard is 16 or greater lymph nodes. Next, coming to the omental or the bossectomy, are they same? First, this question for the postgraduates, we use it synonymously, omentum and bursa, omentectomy, bursectomy. But there is a trial which I will be coming later, where they describe it as two different things. Like the omentum is mainly what hangs from the transverse colon to the greater curvature of the stomach, and the bursa is like what goes over along the transverse mesocolon, along the anterior surface of the pancreas. If you take out the whole thing is bossectomy. If you just remove the omentum from the transverse colon marching to the greater curvature, it is omentectomy. So does it add morbidity? Hope not in a good hand. This is a multi-center RCT by Imamura et al., where they have experienced surgeon when they do bossectomy with D2 dissection, do not have increased complication. Is 210 patients. Does it increase survival? This is another RCT by Fujita et al. In 2012. It says higher 3-year survival rate with decreased chance of peritoneal recurrence. So this is a long-term outcome study, which is RCT, multicenter RCT particularly, involving prophylactic bossectomy. The follow-up is quite long, 18 months. And they have found in a multivariate analysis that bossectomy gives a good prognostic factor and good overall survival. And the subgroup analysis, they have found particularly the distal tumors, mid and lower with serosa positive tumors, it may help. It is a non-inferiority trial, so they told we cannot omit bossectomy completely. It should not be abandoned. Maybe we have to think which cases we have to do. So this is the bossectomy versus omentectomy RCT. That is, this is Japanese trial, which happened recently in 2018, and it was done in 57 hospitals, 1,204 patients, in 602 in each arm. And it has been seen that this the primary endpoint was overall survival. So they has seen particularly specifically with a good performance starters, good BMI, do not have poor like aggressive primary disease. They do well with bossectomy. The 5-year overall survival was 76%. But when comparing to the statistics, they didn't find any statistical significant. Rather the pancreatic fistula was more in the bossectomy group, so they ended with that bossectomy is not going to give any extra advantage. This is a comparison between bossectomy and omentectomy. We are not discussing bossectomy and no bossectomy. So that doesn't provide. Probably omentectomy is enough for a T3, T4 tumor. So there are other meta-analysis and systemic reviews where we see that bossectomy doesn't give any special advantage, unless one study which has shown this, like Luigi Marano from Italy, 2017, he included a number of good quality studies in this meta-analysis to prove that probably it helps to improve the overall survival only in serosa positive, the T4A gastric cancer patient. We have to note that. Next, I'll be coming to multi-organ resection in gastric cancer. Why multi-organ resection? It gives a better chance of survival. These are the few studies I have quoted. From the studies we have got that this survival is quite more significant, particularly when you have a R0 resection. The skills and technology have improved. We have more gadgets. The surgery for curative intent with R0 resection is possible even if it is an advanced localized disease. We have good neo-adjuvant and adjuvant therapy to control the systemic microscopic spread or previous spread. We have good critical care for a long duration multi-organ resection with even some complications. So probably these all are affecting our decisions now. So this is, we do not have any good RCT on this. So I am discussing few systemic chromatic review and meta-analysis. This is the meta-analysis 2017 from China, 9 studies, 941 patients where he had T4 lesions involving when the multi-organ resection was done. And specifically they noted well or moderately differentiation, Borman's classification up to 2, no lymph node metastasis, more than 2 organs resected, ENM. This more than 2 organ resected varies from study to study. Some studies they say when the organ resection is 2 or less, the outcome is, but this particular study says that more than 2 or 2 organs resection. TNM staging 2 or 3 with a curative resection, that means that is R0 resection. These are the positive factors for overall survival. So it increased the overall survival curative resection with a good odd ratio, which is like 4 to 5, quite significant. So this is a very interesting RCT from Taiwan, where they have taken like T3, T4 tumors, multi-organ resection, no multi-organ resection. So 3 groups, T3, T and T4 multi-organ resection, 1 no multi-organ resection. So they have found that when particularly the R0 resection with multi-organ resection, we have a good outcome. So what are the factors which influences the outcome? The lymph node status, involvement of the liver, where either it is R0 or R1 resection. So multi-organ resection or a localized advanced disease should be considered if we can target R0 resection. Metastatectomy in gastric cancer, it all started with the thinking of colorectal, like can we do metastatectomy for other organ cancers other than colorectal, because we get a very good result in colorectal resection, resection. So this paper long ago, like 2006, discussed about the benefit of hepatic metastatectomy in a select group of people. Metachronous metastatectomy are better. Tumor size and location also influences. This is we don't have good RCT to describe. We have only good systematic review and meta-analysis. This is published in Journal of Surgical Oncology 2015, describing like involving 6 studies, 17 a large number of patients, and they found that metastatectomy in a select group of patients has increased the survival like up to 15 months. The interesting part is they didn't find any influence of age and performance status. Difficult to believe. Factors affecting, let us consider only liver metastatectomy. So I went through the 2 good systematic review and meta-analysis, which is published very recently, like 2015 and 18. So what are the they found both overall survival and in 5 years and 10 years are slightly better. What influences? Lower T stage and the lymph node less or no lymph node involvement. Usually there will be lymph node involvement in a multi-organ resection, but should be minimum. No lymphovascular or serosal invasion. Metachronous lesions like previous studies do better. When you are doing a liver metastatectomy in a select group patient with good performance status, all the favorable factors, we have to look that it should be 3 or less, small metastasis, unilobar involvement, that is what small, greatest lesions to be less than 5 centimeters, R0 resection. If you have a very high CA or CA19, particularly CA, then you should abandon, and chemotherapy is must. Pulmonary metastasis, not the standard of the care at this moment, but it has been done in case series where they have even resected more than 1 lesion with all favorable factors, like what I'm telling, patient doesn't carry any adverse prognostic markers. And if you have an advanced primary, it itself is a contraindication, and they found some improvement at 3 years in regarding overall survival. Rukenberg tumor, we all know many studies now, which is like mostly from Japan, Italy. They have mentioned that if you have excluded metastasis at other organs, then we can do Rukenberg resection. But what are the factors it affects? R0 resection. The metachronous, again, metachronous metastasis does have a longer overall survival. Size also matters. If it is like going beyond the pelvis, raise CA, poor performance status, or free fluid in the abdomen, also that those are negative factors. So the coming to the last This is one of our patient. I do closed method. What you are seeing on the left, the cytoreductive surgery and the hypothermic intraperitoneal chemotherapy. So why has cytoreductive surgery in gastric cancer? Where we consider this is the standard recommendation. Then I'll come to the study for limited peritoneal carcinomatosis, no extra-abdominal metastasis. The cytoreduction for this is mainly for the postgraduate, the youngsters who are taking or thinking of or going to start. So it includes gastrectomy in the standard D2 lymphadenectomy, peritonectomy, omentectomy, and sometimes limited visceral resection selected. So we give very high concentration of chemotherapy agent. We started with mitomycin C, then we progressed to cisplatin, oxaliplatin, docetaxel, and it is given at 41 to 43 degrees centigrade to penetrate and to kill the left out microscopic cells. It is run by a specific machine to maintain the temperature, runs for 60 to 90 minutes. There are different protocols now. So 3 common methods are there: open, closed, and coliseum. Open is you do open, every type has its own advantage and disadvantage. I do closed. Closed doesn't expose others to the chemotherapy agents, and it maintains the temperature probably quite early, but it has its own disadvantages also. The coliseum is like a combined method. So this is PCI index you have to calculate. For again, for the postgraduate, we have 13 regions. So you have to each region, it is done by both image and the laparoscopy is the main thing which helps. Sometimes after opening also you can calculate. So it is like up to 0.5 centimeter, then 0.5 to 5, the tumor more than 5. So you get 3 points. So total maximum is 39 points. So most of the tumors, when you're thinking of doing HIPEC, we consider less than 20, but for stomach, the PCI index is quite low. I'll tell you in the next slide. So, and not only that, the completeness score is very important. No residual tumor is 0. Residual tumor less than 2.5 is 1. 2.5 to 25 millimeter is 2, more than 25. So it should be maximum 2.5 millimeter residual tumor. Better is no residual tumor. That is complete cytoreductiveness or completeness. So there are many studies. I'll just discuss few RCTs. This is a RCT from China, 2011, comparing like what is role of HIPEC and cytoreductive surgery in advanced gastric cancer. They took median PCI index like their study was 15, and it had patients were given both cisplatin and mitomycin in either arm. And in one arm they got cisplatin, mitomycin, other one was compared with other. So then median survival was quite significantly higher where they got HIPEC with cytoreductive surgery, and the factors which were predictor of better survival were completeness, synchronous, like not here, not metachronous, not like he had peritoneal metastasis later, and where the patient received chemotherapy agents with no complications. This is another trial. It's it's a meta-analysis of RCTs, which was published in 2017 European Journal of Cancer. 11 RCTs were included. It's and 21 non-randomized control trials, and they found that the overall survival between the HIPEC and control group were quite different at 3 years and 5 years. Though there were more complications in HIPEC, not anastomotic complications. So patients who have less disease burden, probably positive cytology or a limited metastasis are good candidates for cytoreductive surgery, and we should target for a CC score of 0. This is interim report from GIMSA trial, like what we got. It was randomized to two. This is some small number actually, 9 and 7 patients. So, but they did a lot of resections along with that, like metastasectomy, and they included systemic full chemotherapy and only chemotherapy. And it was found that the group which had cytoreductive surgery, metastasis, including metastasectomy, did better. Even some were surviving after 6 years. But the PCI index should be less than 15, not 20. There are many other trials which that's mostly systemic reviews. So that is why I didn't go into details except the Inaugural, which is like RCT. So they found that survival rates are better, and they all stressed on completeness of resection, the cytoreduction, with a score of 0 to 1. And 2 studies were like, both are from Italy and published in 2014 and 15. They mentioned the PCA index should be, one told it is should be less than 12, the other one told it should be less than 6 or equal to 6. This is very important to know in a gastric cancer when you're doing a cytoreductive surgery. So there are other ongoing trials, particularly the GIMSA trial long-term outcome we have to see, and we have to also see the HIPEC trial, which is Periscope trial. Periscope trial is very interesting. They have a different protocol. They give both oxaliplatin doses Taxol in a consecutive manner, one with a high temperature, one with a normal temperature. This is happening in Netherlands, and we have to wait for the final report. So coming to the summary, D2 lymphadenectomy is the standard. There is no confusion on that so far. But D3 dissection may be beneficial in a select group of patients. We have to wait for the evidence to validate. Gastrectomy may help in surface positive cases, T4A distal tumors, but omentectomy, D2 lymphadenectomy is an acceptable approach for most of our gastric cancer, even if it is T3, T4. Multi-organ resection should be considered whenever indicated, means locally advanced without any extra abdominal or intraperitoneal involvement, with a target of R0 resection. Metastasectomy, very selected group of patient with all favorable condition, young patient, good performance status, is selected single tumor, see everything is tumor markers are normal, or in a clinical trial. Cytoreductive surgery, HIPEC, very limited number of patients again with a very low PCA index. We prefer a PCA index of around 6 or less with a target of completeness score of 0. So that completes my presentation. Thank you.
Thank you, Sudip, for the elaborative lecture. And I like to ask, since you are having very much experience about the laparoscopic and as well as the implant surgery, and you are doing a lot of work in the gastric cancer and colorectal surgery. So what is your experience about the multi-organ resection in case of CS stomach? The growth directly involves the organ, and what is your experience, what is the outcome, and what is your take-home message for the younger colleagues?
Sir, good question. Thank you, sir. So multi-organ resection, starting from histology to the other factors, like if it is a poorly differentiated cancer and we have multi-organ involvement, so they don't do well. So we should be very careful when we are doing resection on this. And most of these patients, they go for upfront therapy unless they have a fistula with a lot of complications. So they go for a upfront chemotherapy, and that also helps us to know the disease biology. By the time they finish the chemotherapy, it helps to know the disease biology, and they do well after chemotherapy, and they have all the favorable factors. There is no that they give a good result even after multi-organ resection.
Thank you. And Dr. Suraj wants to know about the role of total omentectomy for locally advanced gastric cancer. Question from Dr. Suraj. Role of total omentectomy for locally advanced gastric cancer.
So as far as we practice and from the evidence what we have got, like if you have a D2, like a lesion, T3 lesion, then you just go for a omentectomy. Don't try to take out the anterior layer from the transverse mesocolon or the pancreatic capsule. But if you have a T4A lesion, particularly the distal one or the mid one, then you think of doing a bursectomy, complete bursectomy. We don't have a like level 1 or level 2 evidence to tell that, but that is what we practice, and we find this results. Probably this gives a completeness to the resection.
Okay, thank you. Dr. Kanagal and any other panelists, any other comments or questions?
I could see Dr. Rudra raising his hand. Dr. Rudra, your question, please.
Yeah, it is not a question. Just I was supporting Dr. Swami that whenever you have a posterior lesion, it is very commonly that it is not the practically the involvement of the anterior pancreatic fossa, but sometimes there are inflammatory reaction and the pancreas is adherent on the posterior aspect. But when you do the bursectomy, you find a very good plan and get away with it. And when you ultimately do the histopathology, you find the posterior margin negative, which
Right,
most
sir.
of the patient person sometimes say that the pancreas is fixed and you should leave it. So my point is, you should just be out of experience. You should be knowing that what is inflammatory and what is because whenever there is a carcinomatous lesion and there is infiltration, there will be surrounding inflammation. So the inflammation part should not be confused with the infiltration. And still, if you do a proper D2 gastrectomy, you will get good number of lymph nodes and this patient will going to do well. Similarly, whenever there is a greater curvature involvement with a omental involvement, sometimes the colonic transverse colon margin comes into continuity involvement. There, I think doing a sleeve resection of the colon or even a segmental resection is worth it than leaving it, because these patients are going to definitely do well when you do the resection and later on do the chemotherapy. And the third point is that regarding the D2 plus lymphadenectomy, the commonest problem that you face is big nodes in the 16A and 16B nodes around the celiac axis. 16A, 16B classification wise are paraiotic nodes. But if you see the regional part, if it is a mid-gastric curvature tumor, the 16A, 16B will come as a regional node around the celiac axis. So D2 plus at that area definitely has advantage that if you find a 16A, 16B positive node, it will upgrade the staging, and it is not like a M1, it is like a regional node, so which is otherwise called as D2 plus or D3 dissection, in especially in that area.
Can I make a comment, Dr. Chandramohan?
Thank you, Dr. Rudra. I think Chandramohan sir, please.
Yeah. So I think as we know, year by year, the radicality of the procedures are going down. Am I audible enough?
Very well, sir.
So, all the controversies like vasectomy, omentectomy, all this is mainly helping is in the context of doing a laparoscopy. So I know the stomach cancer is the only cancer where many of my friends who are the well-versed laparoscopic surgeon are holding back, and they are still relying on open surgery because it is. They are almost, me also think that doing a picture perfect omentectomy or bursectomy is almost impossible in laparoscopy. So the moment lymphadenectomy can be done very well, the moment bursectomy and omentectomy, especially bursectomy, moves out of the oncological radicality principles, I think laparoscopy will having a lot of role here. So that's why the lot of interest is going on that area. So Rudra as well as Dr. Sudeep, can you comment on my question whether laparoscopy can you do the beautiful laparoscopy doing omentectomy? And I know of course a few people can do it, but if you think about hundreds of gastric surgeons doing it, is it easy or difficult?
Particularly laparoscopy, if you are trying to take I also tried through robotic, taking out the anterior layer from the transverse colon. Taking out the pancreas is not difficult, sir. Main difficulty comes when you take out from the anterior layer of transverse colon with laparoscopy. So taking out the anterior pancreatic cancer, that is not difficult. That is quite possible, feasible with both laparoscopy and robotic. But we always, it is a challenge to take out. It becomes like we get a lot of holes, as you told, in the transverse major colon anterior layer when you do, not in the pancreatic capsule. I agree on that.
Yeah, thank you.
So if you see my take on this is that laparoscopy definitely has a role in gastrectomy, but it's the cases should be selected. Like, let us say for a T3 tumor, you can go for it, but where there is no bursectomy needed. But if it is a T3 or plus or a T4 tumor where bursectomy is needed to get a clearance, I think better to get it open. So the
Agreed, sir.
selection of the case is very important as regards the laparoscopy gastrectomy, because the lymph node dissection has been proved that it can be equal, at least non-inferior. But if you want the completeness of the radicality in a T4 tumor, it may not be there. So it has to be T3 and less to select for a laparoscopy D2 gastrectomy.
Agreed, sir.
Can I say something?
Yes, sir, please.
Yeah, I just wanted to mention about like just Dr. Chandramohan raised the point that the radicality in stomach is decreasing. Why? If we compare it with the other GI organs like esophagus and rectum have got a potential for additional local therapy like radiation therapy, which technically is not easily possible in stomach, because the stomach is a very mobile organ and it's not very possible to properly to stomach. So surgery still has the main role in other things. It's the only local therapy available for the treatment of the stomach. So the radicality should remain. We can the radicality in treatment of CS stomach.
We value your points, sir. Thank you for sharing. If there are any other questions or comments, can we move to the next
Kanagavel, can I make a comment?
Ramesh sir, good evening, sir. Dr. Ramesh Ardhanari is the chairman of the Surgical Gastroenterology Department, and he's also the superintendent and the director of the Madurai Meenakshi Mission Hospital, and an ardent laparoscopic surgeon. I remember sir demonstrating laparoscopic gastrectomy as early as 95, 96 when we were young students.
I started doing gastrectomy in 96, but radical gastrectomy D2, first case I did in 99, in
okay, sir. Okay.
99.
Yes,
and what I want to say is that the D2 gastrectomy, both by open and by laparoscopy, becomes easier if you take the greater momentum of the transverse colon and enter into the plane between the anterior and posterior layers at that point. And then with the modern energy systems like harmonic or Thunderbeat, you can do a very good dissection laparoscopically also. That's what I feel. I think that much of the inhibition is, I'll be very frank, is because the surgical gastroenterologists, when they train and you do cholecystectomy, you do appendicectomy, you do fundoplication, so your laparoscopic skills are already developed to some degree. Many oncologists have to develop it in a cancer case. They don't have the opportunity to do that much of gallbladders and appendix and hernias to do dissection and learn. So I think that is one reason why there's a slight fear in their minds. But I can assure them that if they just start following the same principles as an open surgery, it should be possible to do. Of course, I don't do it very often these days because 95% of these CS stomachs are done by our postgraduates and junior faculty. And to do a D2 gastrectomy laparoscopically, one of the senior surgeons has to do it. And I don't want to take away the chances, and I want them to learn in their training also. So I do less now, but once in a while I do it just because they want to see how it is done. But one need not be afraid. It is not that difficult. It is possible. But you have to start from that place, and you have to be very sure that you avoid bleeding, and you keep yourself in such a way that you expose the vessels to the colon and the colonic mesentery, and you keep taking everything superficial to it. I think we'll get along very well.
Thank you, sir. And I know how vociferous you are for the training of younger surgeons. and you always believed giving a younger surgeon a chance to do does not compromise the outcome. You have been always vociferous for that. We look forward to hear more about your thoughts during the panel, sir. I thank the speaker, Dr. Sudipta, for sharing his thoughts on tailored and radical gastrectomy. Now, Kanan sir, with your permission, I will introduce the invited faculty for the evening from Pakistan. We have
Thank you, everybody. Thank you.
Thank you, Dr. Sudipta. We have Professor Tabish Shala. Professor Tabish Shala is a chief of surgical services from Aga Khan University, Karachi. On behalf of the Indian Association of Surgical Oncology and Association of Surgeons of India, Chennai City branch, we warmly welcome you, sir, for this evening academic deliberation. Thank you, Dr. Tabish Shala, for accepting to contribute for this important gastric cancer update. For people who are unaware of Professor Tabish Shala, he was educated in Punjab Medical College from the Faisalabad, and he went on to have his residency training in Aga Khan University. And later he moved on to UK for his fellowship exam. And for fellowship exam, he spent most of the time around Worcestershire and Hull Hospital. And then he went on to Johns Hopkins for more specialized training before returning eventually back to the Pakistan. He spent the initial time on teaching and regulating the academic part of the general and GI surgery. He also has a special interest in pediatric surgery, but now he is now being the head of surgical sciences. He is also the board of the member for the board of surgical academic committee of general surgery, and he has, to his credit, 56 original publications. More than publications, I would like to bring in something more exciting or more pertinent to that. Of the 56 publications, he has close to 462 citations. Now, it is not the number of publication which matter, the amount of citation which matters on the strength of the publication. And he has a H index of 12 and I-10 index of more than 15. So that indicates the strength of the research work which is done by Professor Tabish Shala. And in fact, I would say Professor Tabish Shala has translational research happening in his department, and also the most recent robotic work or most recent laparoscopic work on hernia, which has been, he is the principal investigator. He also has a principal investigatorship of a stem cell influence in pancreatic cancer work is happening in his department. And I think he has a long CV, but out of time constraint, I'm told you the most important things. Thank you, Professor Tabish Shala, for joining us today. Over to you for your lecture. We welcome you to share your screen, and please go ahead with your presentation, Dr.
Thank you very much. I'm finding it difficult to share my screen. I'm trying a new laptop.
Yes, sir. If you want, you can share me your PowerPoint through my WhatsApp. I can immediately project it, sir, unless you have videos.
Right. So can you help me? How do I share from this? So I go on a screen share.
Yes, sir.
And then
No, sir. No, not really like that, sir. If you go down through the Zoom, there is one green button on the with up arrow called share screen.
Yes, I'm doing that.
Yeah, if you open, there will be multiple subscreens coming up in the column.
Yes.
You can see your PowerPoint also in one of the icons.
No, I can't see that. I can't see my.
Sir, you please open your PowerPoint now.
Yeah,
minimize the Zoom screen.
Pardon?
You please open your PowerPoint, sir.
All right. Sorry.
No problem.
And minimize the Zoom screen, right?
Not necessary to minimize, sir. When you share the screen.
Now you open share screen, you will find application folder. In that you will find your PowerPoint there.
Right. Okay. I'm really sorry, but sir, this is,
No worries, sir. No worries.
So,
are you okay now?
If I open the Zoom screen.
Yes, sir. Now go to the share screen, as Ramesh has said. You have all the subscreens in the folder.
Share screen.
You could see your PowerPoint there.
There should be one application window. There should be one application window.
I have basic and advanced and files. I have 3 options.
In the files, do you see your open PowerPoint?
No, I can only see the I can only see the Google Drive there.
Dr. Tavesh, I will ask you one question. Do you have videos or you have only slides?
I only have slides.
What you do is, if you can mail me to my email ID, is that possible?
Yes, it's very much possible.
So you please mail me. I can show it from my screen.
Right. So, I mean, I'm really sorry for this.
No worries, sir. No worries. No worries at all.
Right.
In the meantime, Dr. Rameshar, I have a question for you. To start with, you have been trained on the open era and laparoscopic era, and now you're moving on to the next generation laparoscopy also. Gastrectomy at least needs very clear understanding of the anatomy to move towards laparoscopic surgery. So does it mean someone who wants to pursue a laparoscopic gastrectomy should have adequate open gastrectomy experience prior to laparoscopic one? What is your take on it, sir?
You see, we always say that, but let me ask you that today we all drive cars, okay? Do we know how to drive a bullock cart? So it's an analogy which is probably a little far-fetched, but similar to that. So I think that the new generation of surgeons who are coming are more familiar with laparoscopy, and they will do things laparoscopically this thing. In an ideal world, they would learn open, but then if everybody is doing laparoscopically, where do they get the chance to do open? Unless institutions say that, no, we will teach open surgery. So that is what is the problem. In a private setting, in many places, the drive is to project laparoscopy, and so the consultant keeps doing all the cases. And I know many PGs are unhappy because it's all done by one person. Whereas, so to avoid that bias, I have kept I do few cases only laparoscopically. So majority of gastrectomies, Whipples are done by open, so that the boys get a training. Most colorectal surgery we do laparoscopically because the patients come for colorectal laparoscope. They ask for laparoscopic surgery. So but we do have a lot of open colorectal obstruction cases, advanced tumors, bigger tumors, multi-organ resections. We do that open. So I think so if you are not a training institute, you are one and you are only going to be doing the procedures in a nursing home or in a specialty center and doing, then you can do everything laparoscopically because only you are going to do. But if you are in a training center and you have a lot of people to train, I think you have to find a balance. That is one of the things that limits my laparoscopic work now.
Actually, sir, if it is an open surgery, you give graded participation of your assistants, sub-juniors.
Yeah.
They start with incision closure, then they start mobilizing, then you go for vessels, and finally you give lymphadenectomy and restoration. But laparoscopy definitely cripples that part because the surgeon does everything. Maybe the camera surgeon happens to show or retract.
No, but then
how do you manage this part of the lacuna, sir? How do you manage this lacuna? Go ahead,
no, the camera person is not very much of a problem because most of our MCH PGs will know the steps of the operation of a gastrectomy or of a Whipple. And so they can hold the camera, and once they hold in one case, then they learn how to hold it in the next case. So that is not a problem. So I don't foresee that as a major barrier to my not doing. The boys are pretty good. And I know that some consultants are very particular. They want the same person. So they have one assistant for many years. That fellow is a poor fellow. He is always number 2 and he's only holding the camera, which I don't believe is a good. So I like to, so the people who hold my cameras will sooner or later start doing things. So my our colleague consultants are allowed to do laparoscopic work so that they get familiar with it. So I have to distribute it between the various people. So to do that, I have to reduce my operating. Otherwise, I can't do that.
That is more than gracious of you, sir. Allowing your chances to your students, that needs a lot of effort from a teacher. Thank you, sir. Thank you. Dr. Tabesh, how your place, sir?
Yeah, so I have emailed you, but I think it's, and I have WhatsApp you.
1 second, sir.
I'm
yet to receive both. Is your folder very big, sir? File very big?
Well, it is 55.4 MB.
Then it definitely takes longer time.
Email, it will be a problem. I think they have
Sir,
a 40,
can you
50
put in a
GB.
Google Drive? What I will do is, I will give a Google ID. You can Google Drive it because 55 MB definitely takes Yahoo and regular Gmail to have challenges.
Right. So I can put it in the Google Drive.
Yeah, that makes easier, sir. I'm sending you the mail ID. In the meantime, I would request the panel to start with so that we can have the discussion on. And I will request the panel after the panel has 2 cases, if I can recall what Dr. Ramkrishnan sir has planned. So I will request the panelists to halt after your first case so that we can listen to the complications talk from Professor Professor Tabish Chawla, sir. And we will be able to look into the second case after he finishes his talk. Will that be agreeable to the panelists?
Yeah, I'm fine with that.
Yes, sir. Yes, sir. I think all the other panelists are in mute mode. Let me quickly say. Yeah, I got the Tabish Chawla's presentation. Give me a minute. I think we can have this presentation upfront. We have the presentation of SIRS one, which is ready and to go. Give me a minute. And sir, by the time if you have any questions from the YouTube, you can start. Give me a minute to download this and show it up.
It's a question to Ramesh sir. Ramesh sir, Dr. Maura asking, what is your approach on distal gastric cancers infiltrating the pancreas?
If it is obstructing, I will do, and it is possible to do either a GJ or a palliative gastrectomy. I will do that so that the patient's obstruction is relieved. If the patient is not obstructed, these patients I sent for neo-adjuvant chemoradiotherapy. Specifically, I'm saying chemoradiotherapy. That's what now we use routinely for these patients. And if it downstages and the pancreas becomes free, I would go ahead and resect. I am not inclined to do a Whipple's on these patients. I did 4 cases in my early enthusiastic years, and none of them survived beyond a year. They all had recurrences, and so and also the literature suggests it's not worth doing Whipple's for a gastric cancer.
Sir, and interestingly, Dr. Ambujam is asking you specifically, dear sir, at the times of some inadvertent complications, what will be their capacity for conversion?
I think most of them will have enough capacity. If they can do laparoscopy, they'll be able to do some conversion and do set right the complication. Most of the time, the complications that require conversion will be either there'll be a bleeding or there'll be a duodenal injury, which will require conversion. I think they can manage that. Most of the GI surgeons are trained to do that, and oncologists are trained to do that. They can manage that.
Thank you, sir. And Dr. Suraj is asking, in case of multivisceral resection or just liver resection, what is the reasonable approach based on evidence, sir? Upfront surgical or neo-adjuvant and reassessment followed by resection, if the response is good. So what is your comment?
See, even if the response is good, once a metastatic disease, in gastric cancer, it will always be a metastatic disease. It's unlikely to disappear. So I would give neoadjuvant, and if it responds, and if the patient has either bleeding or obstruction, I would operate. If neither is there, I would continue with the chemotherapy on a long-term basis till survival, because I don't think you will ever be able to curatively operate them. And already with an advanced cancer, operating them, taking away valuable time from their life is not worth it in my opinion.
And we like to know about your experience, sir. What is your message to us regarding the multivisceral resection for the gastric cancer?
No, my idea is that the only part of the thing that I will resect is if I have a transverse mesocolon or transverse colon alone is taken up, there is no other disease anywhere else, then I will and I can do an R0 resection. I will take up the transverse colon. Yes, I will do that resection. But liver, I don't think it is worth it unless you have an OG junction or lesser curved tumor which is directly infiltrating the liver. In that case, you can get an R0 with the left lobe resection. But that is actually not a metastasis, it's a direct infiltration. So if you clear the whole thing, you may get the occasional long-term survival.
So what about infiltrating directly to the spleen or the anterior surface of the pancreas?
Spleen, no problem. You can take it out with that. Anterior surface of the pancreas, you can shave it off. If it is beyond the towards the spleen, the pancreas, you can do a distal pancreatectomy, splenectomy with not much morbidity. But a Whipple, I'm reluctant to do. I won't do it, to be frank.
And finally, Dr. Haridas is asking, laparoscopic assessment of operability will be done irrespective of T stage.
The laparoscopic assessment that we do is not just putting a scope in. I think you should put a couple of accessory ports, and then you should try to move the tumor, lift the tumor, see the proximal and distal margins, see whether the duodenum is involved far into the first part, in which case doing a good resection becomes very difficult because you'll have to go to the second part and you may injure the bile duct and pancreatic duct. And of course, you look at peritoneal metastasis, liver metastasis, ascites, and omental metastasis. You will look at all these obviously, but the assessment has to be a little more than just looking. You have to move, see, feel, and I think now with people doing so much of laparoscopic operative work, these things can be done.
Thank you, sir. Thank you very much. I think Dr. Sabash Shavala is ready for the presentation. Dr. Kanagavel?
Yes, sir. Give me a minute, sir.
Otherwise, like you said, we can take the first case of the panel discussion and then ask him to come in.
Yes, sir. I've got the slides up and ready.
Because
some or other, I understand, sir. We are running little over time.
Yeah,
we are ready to go. Dr. Tabesh, I'm sharing your PowerPoint.
Right. Please go ahead.
Yeah, please go ahead with the lecture.
Right. Thank you very much. And thank you for the invitation. And I'm extremely sorry for this mix-up. Just trying the new laptop and the software on it was not configured properly. So the topic given to me is very simple and very easy. This is post-gastrectomy complications. Next, please. This is where I work. This is Aga Khan University Hospital, Karachi, a private tertiary care hospital and a university. Next, please. Now, the best management of a complication is its prevention. Nothing better than that. And it is more true in gastric surgery, in gastrectomies. Next, please. Post-gastrectomy complication incidence varies from 4.2% to 23.3%, a huge range. But there are many complications, and this range is not surprising. Next, please. In radical gastrectomy with D2 lymphadenectomy, next, please. One click more, please.
Give me a minute, sir. Give me a minute.
Right.
There is some challenge I'm facing. Give me a minute.
Right. If you're talking about radical gastrectomy with D2 lymphadenectomy.
Sir, you keep talking, sir. I will sort this out.
Right. So we have different data, and interestingly, but understandably so, the data from the East is better than the West. And by East, we know that we have Japanese experience. So that adds to the figure. So the morbidity in the data coming from the East ranges from 13.7% to 16.4%, and mortality 0 to 0.6%. But data from the West has a higher rate of morbidity between 25 to 46%, and the mortality 4 to 13%. Now, next, please. So post-operative complication is an independent prognostic factor following gastric cancer surgery. So complications change the prognosis, as we all understand and know. Active treatment of a complication in clinical practice improves the short-term efficacy and reduces the effect of complication on the cancer-specific survival rate. Next, please. Complicated post-operative recovery process may inhibit the immune response to the spreading of tumor cells, resulting in a reduced cancer-specific survival rate. So the body is, involved in dealing with the complications. The immune response to the spreading tumor cell may get compromised. Next, please. Goldfarb et al. Showed that enhancing perioperative cellular immunity while inhibiting excessive catecholamine and prostaglandin responses can effectively reduce the immune suppression of the body and the recurrence and metastasis of the tumors. Next, please. Post-operative complications not only prolong the post-operative inflammatory response time, but also affect the overall survival and cancer-specific survival of the patient after the radical resection of the gastric cancer. Next, please. So what are the risk factors? Age more than 60 years, total gastrectomy versus distal gastrectomy, patients with ASA score 3 or 4, moderate to severe malnutrition with a serum albumin level of less than 3 milligram per deciliter, race in American literature, Asian American versus African American versus Caucasian. Next, please. Is laparoscopic gastrectomy safer than the open gastrectomy in elderly patients? Chen in his study demonstrated yes, with good p-values. There was a low rate of surgical complication, low rate of overall severe complications, shorter post-operative hospital stay, and lower readmission rate. Next, please. So we have a whole list of early complications: hemorrhages, leakage, obstructions, herniations, gastric remnant necrosis, injuries to the bile duct, injuries to omental infarction. Next, please. The late complications: dumping, early late dumping, recurrent ulcers, small gastric remnant syndrome, remnant carcinoma, Roux stasis syndrome, fistulas, obstructions, herniations, interceptions. So I'll only discuss the more important ones. Next, please. So intraoperatively, we can all encounter hemorrhage, which can be controlled in majority of the situation. But if we deal with an aberrant left hepatic artery and we inadvertently damage or ligate it, there can be an acute ischemia of the left lobe of the liver. We can cause injuries to the spleen, pancreas, common bile duct, and ampulla of Vetter. Next, please. But post-operative anastomotic hemorrhage is a very common complication, which can be extraluminal, intra-abdominal, or intraluminal. Back, please. One slide back, please. Yeah. So if we have bloody fluid and we may need to do an exploration, or if we have the facility available, we do an angioembolization. Next, please. Next, please. Now, anastomotic leakage, which is very frequent for gastrojejunal anastomosis if it happens. And it is usually intra-abdominal leak leading to sepsis and may lead to multi-organ failures. Early signs we all know: fever, persistent tachycardia, and worsening abdominal pain and signs. Next, please. So does anastomotic leak affect the survival in gastric patients? One more click. Severe anastomotic leak was independently associated with overall survival hazard ratio of 3.96 with 90% confidence interval and a good p-value, but not recurrence-free survival. So overall survival was affected by anastomosis leak, but not the recurrence-free survival in a study done by Kamarajan SK. Next, please. Neo-adjuvant therapy does not increase chances of anastomosis leak. We have enough literature on that. Next, please. Very much favored by industry and some of us. Can indocyanine green, fluorescein, and geography predicts anastomotic leakage in gastric cancer surgery. The time difference between ICG seen at first and second time of anastomotic site was an independent predictor of anastomotic leak with an odds ratio of 35.361 in a 95% interval and a p-value of 0.027 in a study by Murray. Next, please. For small leaks, which are picked up early, a fully or partially covered self-expanding metal stent can help in sealing the leak, and we have seen this in bariatric surgery. If the leak persists, we may need to re-explore, do a washout, and repair or control or repair the leak or make a controlled fistula. Next, please. The duodenal stump leak, the incidence is not very high, but still 1.6% to 5%. Minor leak is well managed conservatively with percutaneous drainage and antibiotics. However, major leak at times can lead to mortality despite of medical and surgical management. Next, please. We'll discuss it further. The duodenal stump blowout, usually seen in Billroth 2 reconstructions. The incidence is 3.5%. The commonest cause is excessive dissection of the duodenal stump, which compromises the blood supply. So the caution on dissecting at that area. Other causes may include ischemia or necrosis, sometimes closing the stump if we close due to suturing overzealously, and increased tension or duodenal stump on the duodenal stump caused by acute afferent loop obstruction. The afferent loop obstruction may cause back pressure, and that can lead to duodenal leak out if the afferent loop is having resistance distally. Next, please. The stoma itself from inside can get obstructed. We have seen it sometimes. The good functional anastomosis, good surgery, but anastomosis is not functioning. And there is post-op gastric outlet obstruction. Usually, these are inflammatory adhesions, and patients have dysphagia, nausea, vomiting, abdominal pain. And we can do an endoscopic dilatation, sometimes just endoscopy and putting the endoscope through the efferent orifice may solve the problem, or we may need to do a balloon dilatation, occasionally requiring surgical release of adhesions or redoing the anastomosis. Next, please. Delayed anastomotic stricture, usually in gastrojejunal anastomosis. This is maybe because of tension or ischemia, a progressive dysphagia, vomiting, and minimal abdominal pain. Endoscopic dilatation usually solves the problem, which can be supplemented with a stent placement if needed. Next, please. Marginal ulcer bleeding, sometimes very troublesome. This is the ulceration inside the margin. We have seen them on many surgeries, can happen in gastrectomy, and which patient may present with pain. Endoscopy may diagnose it. We can manage it endoscopically, most of the time either clipping or coagulation, or may require very occasionally angioembolization. Next, please. The long-term sequelae after gastrectomy maybe gastric reservoir dysfunction or due to vagal denervation or some problem after the reconstruction. So these are the three main main causes seen after the long-term sequelae after gastrectomy. Next, please. Dumping syndrome, we all know, we have seen it or in our or others' patients, and dumping can be next. Early dumping, about 15 to 30 minutes after a meal, affected patients develop gastrointestinal discomfort, nausea, vomiting, cramps, diarrhea, and as well as vasomotor symptoms such as diaphoresis, palpitation, flushing, and these are referred as early dumping. Next, please. But there can be, next slide. Late dumping, less often. Okay, we can skip that. So we know what late dumping is. One slide back, please. The treatment is mostly, you diagnose clinically and you treat patient conservatively. You do dietary change, low carbohydrate diet. You want to decrease the osmotic load. Small meal with solid and liquid food. Sometimes giving octreotide helps, and alpha glucosidase inhibitor may help in late dumping, very occasionally seen and can be managed still medically. Next slide. Sometimes we need to manage surgically, again, very rare. ISO anti-peristaltic segment of jejunum interposed between stomach and small intestine, about a 10 to 20 centimeter segment is interposed to slow down, and sometime we need to convert a Bilrod 2 into a Roux-en-Y gastrojejunostomy to prevent dumping. Next, please. We know that we do see motility disorders after vagal denervation. Patient may have diarrhea, and patient may develop gallstones secondary to gallbladder dysmotility, a common complication in delayed seen in after gastrectomy. Next, please. Patients may get bile reflux gastritis, afferent and efferent loop obstruction, which is seen not very often, but in a good number of patients, jejunogastric intussusception or Roux syndrome. A little bit about them. Next, please. Roux stasis syndrome, after undergoing Roux-en-Y, a subset of patients develop vomiting, epigastric pain, and weight loss. Roux stasis is caused by disordered motility of the Roux loop with net propulsive activity towards instead of away from the stomach. So reverse propulsion, and patients suspected of Roux stasis syndrome should undergo evaluation, and upper gastrointestinal series X-ray should be done, maybe endoscopy, and sometime gastric emptying study can be done. The findings are similar to gastric stasis, and one can find a dilated, flaccid Roux loop. Next. We do see bile reflux gastritis in most patients, just the symptoms, epigastric burning, pain, nausea, not very significant clinically. Diagnosis can be made by symptoms only or endoscopy and can be treated medically. Next, please. The obstruction we encountered after gastrectomy, which can be afferent and efferent loop syndrome, jejunal intussusception, and internal herniation. Next. Cause of afferent and efferent loop syndrome can be excessive length of the afferent loop. One can diagnose it doing a CT scan where an afferent loop is seen extremely dilated, And the prevention is that the length of the afferent loop, which is taken, should not be more than 15 centimeter from the GJ flexure. And the first arch can be one indication, one sign of where it should be taken. Next. So the management is EUS guided stand placement. We saw a wonderful presentation today where our gastroenterologist friend was doing endoscopic gastrojejunostomy. Sometimes revision of gastrojejunostomy is needed or conversion to a Roux-en-Y gastrojejunostomy. And next slide, please. The jejunal intersusception, the incidence is less than about 0.5%. The cause is jejuno-jejunar intersusception or afferent-efferent loop telescoping into each other. One can do a CT scan diagnosis, occasionally endoscopy or contrast study under fluoroscopy can show the intersusception, which can be transient. Next, please. So how do we manage? There was a study by Lee. In their study in 2,300 gastrectomy patients, only 12 had this kind of intersusception. 4 required laparoscopic reduction without bowel resection and some fixation of the afferent loop and small bowel mesentery was done. 1 required open reduction and 7 resolved spontaneously. Next, please. Internal herniation after gastrectomy in minimally invasive era. If we compare the incidences in a study from Kong, they had 6,474 patients and they encountered 111 internal herniations, about 1.7%. Comparing open versus laparoscopic, 0.9 in open and 2 in laparoscopic surgery. 59 out of those 111 required surgery. As per as the site of intersusception, usually jejunostomy site for a Roux anastomosis, or if there was a Peterson's defect, or but there was none in the transverse colon mesentery. Next, please. Depending on the construction and internal herniation after reconstruction, the highest incidence was uncut Roux loop, Roux-en-Y, and that was 56%, followed by Roux-en-Y loop 40%. The Billroth one, obviously nobody does them at the moment. Billroth 2 had 1.1% and smaller percentage. So this is fairly common in Roux-en-Y reconstruction. Next, please. So if I summarize, post-op complications can be picked up early if we have a high index of suspicion and a comprehensive knowledge of what can happen. For the young surgeons and for all of us, we should not be skeletonizing the duodenum more than 2 centimeters, and we should be preserving the blood supply. Usually the late complications are seen after 6 months. Patient needs to be counseled properly about dumping, what to expect and how can they avoid it. And most of those patients are managed conservatively with dietary changes and when they are advised properly and counseled. There can be nutritional deficiencies, anemias, and vitamin deficiencies. Next, please. Thank you. This is Karachi, Pakistan.
Thank you, sir. In fact, it was a very elaborate postgraduate review of all the complications. I'm sure there will be few questions definitely based on this. I would request you to stay back for the panel so that you can take the questions together. Will that be fine, Professor Shala?
Yeah, sure.
Okay. Yes. So that will make things easier for all of us. Kannan sir, I think we can go ahead with the panel now.
Yeah, thank you, Dr. Kanavel. Now let us go to proceed the panel discussion. It's none other than moderated by Professor Ramakrishnan. The topic is multidisciplinary approach to advanced gastric cancer. Dr. Ramakrishnan is the Dean and the Professor of Surgical Oncology of Cancer Institute. He is in charge Clinical Research Institute and the Chairman of Scientific Advisory Committee, Cancer Institute, Adayar. He is having so many publications, research debuts in his credit. 62 publications in national and international indexed peer-reviewed journals and 2 book chapters. And he is having a research grant for the award of the Global Challenges Research Networking Fund grant by the Academy of Medical Sciences, UK, for the project titled Largeable Microbiome Disease Network, creation of a proof of principle exemplar in colorectal cancer across 3 continents. And travel grants from Department of Science and Technology, Center for International Cooperation in Science, Appendix Cancer Pseudomyxoma Peritoneal Foundation, and as well as Science and Engineering Research Board. And is having fellowships in Indo-Oxford Cancer Research Network Fellowship and UICC, that's ICRETT Fellowship. And so many things are there. In fact, he is the principal investigator in 4 investigator-initiated clinical trials and also co-investigator in 4 trials. Of course, he is the reviewer for colorectal disease, Annals of Oncology, British Journal of Surgery, World Journal of Surgical Oncology, Melanoma Research, Gynecology, Oncology, and the World Journal of Gastroenterology, and Indian Journal of Cancer, Indian Journal of Surgical Oncology, and so on. And none other than the panelist, Dr. Ramesh Ardhanari, no need of any introduction. He's one of the senior most surgical gastroenterology and advanced laparoscopic surgeon of our country. He only did the first laparoscopic D2 gastrectomy in India, and now currently he is the consultant surgical gastroenterologist and director of surgical sciences in Madurai Meenakshi Medical Mission and Research Institute. And he is having so many publications, researches, and awards in his credit. And he has awarded the best IMA Academy of Medical Specialties Tamil Nadu chapter has awarded recent advances in gastrointestinal cancer in 1994. And he is having so many credits of awards and publications and research work in index, both national and international journals. And next, Dr. Vikas Magajan. Currently, he is the consultant surgical oncologist, Apollo Cancer Institute, Chennai, and he is also director of Medical Cancer Foundation. And also formerly, he was a professor and head GI and thoracic oncology in Adayar Cancer Institute. And he is a teacher for the DNB surgical oncology in Apollo Cancer Institute, and as well as is a DNB of examiner. And he is having so many publications and research works in national and international index journals. Next, none other than Dr. Inian Samarazam. He is currently Professor of Surgery in CMC Hospital, Vellore. His special interest in upper GI surgery, had fellowship in upper GI surgery in Geelong Hospital in 2009. Is having so many awards, research works, and index journals and publications in national and international journals. And he acquired a fellowship in upper GI surgery in Australian and New Zealand Gastroesophageal Surgical Association. Next, Dr. Raju Rajendranath is the senior consultant medical oncologist, and he is senior consultant medical oncologist for the integrated cancer group of Apollo Cancer Institute, and is having so many research papers and as well as awards in his credit. Some of them are Dr. K.S. Sanjeevi Award for the Selfless Voluntary Service to the Poor, and he got the Best Paper Award in National Indian Society of Oncology biennial meeting in Bhubaneswar, February 2011, and Best Doctor Award from Tamil Nadu Dr. Medical University in recognition of contributions in field of medical sciences, and so many publications in national and international index journals. Finally, Dr. Manigantan Danish Kodi He is the assistant professor of Cancer Institute in medical oncology, and he has acquired education and as well in IACA John F. Kapoor Fellowship, observer in solid tumor oncology in Tosser Cancer Institute, Cleveland Clinic. And he is having so many publications in national and international journals. And especially the publication of the evaluation of the polymorphism in MOB-PC3 in patients with anthracycline-induced cardiotoxicity and cyclosporine-induced posterior reversible encephalopathy syndrome. And so many awards. Just I want to mention Professor K. Ramachandra Ennoman Goldman Award and Best Outgoing Student Medical Oncology and Best Orator Award medalist in otorhinolaryngology and ASUO Virtual Mentor Program and Dr. Kalla Venkat Young Researchers Award in Indian Cancer Congress 2017 ISMPO Travel Grant. Over to Dr. Ramakrishnan to proceed the panel discussion. Dr. Ramakrishnan, please.
Thank you, Dr. Kannan, Dr. Kanagavel, and all members of ASI Chennai. On behalf of all the galaxy of panelists, I wish to thank the ASI Chennai chapter and IASO for involving us in this wonderful program. I hope my screen is visible.
Yeah, it's visible.
Yeah. So I would like to just take a moment to pay tribute to the doyen of gastric cancer in Chennai, Dr. Chandra Mohan, surgeon, doctor, administrator par excellence, a wonderful human being, someone who was always ready to help his colleagues, no matter how junior they are. And I have experienced this personally. So with that, just to recap what has probably been told multiple times through the course of this webinar, this stomach cancer is one of the most common cancers in the world and the third leading cause of cancer deaths worldwide in both males as well as females. India, we don't see too many stomach cancers. Most of the stomach cancers in India are concentrated in the northeastern part of the country. But among the rest of the country, the south, especially Chennai and Bangalore, Trivandrum, accounts for a major proportion of cancers that we see in South India. Thankfully, the incidence seems to be coming down slightly. So hope this trend continues and we see less and less of stomach cancers. So this is what I would like to share with you. This is data from the National Cancer Registry Program, the latest publication. So as you can see, most of the cancers that of the stomach that we see in India are in the loco-regional advanced cancers, nearly half of them. Almost a quarter of them have distant metastasis. So this is relevant with regards to what we are going to discuss today, that is multimodal management of cancers. I know there has been a lot of discussion on open versus laparoscopic surgery, but what the young surgeons must realize is regardless of your approach, whether you do an open approach or a laparoscopic approach, it is not going to alter the overall outcomes. Both laparoscopy and open have comparable outcomes. But what is really going to make a difference is what additional treatment you do either before or after surgery as far as stomach cancer goes. So that is what we will try and discuss here today. I thought I would use the help of a patient scenario to help us through this discussion. So this is a 65-year-old gentleman, a chronic smoker, as most of our stomach cancers tend to be. He has a history of vomiting for 3 months, loss of appetite. He is able to take liquids, although. Clinical examination, his performance status was 2. There was mild dehydration, bilateral pedal edema. There's a mass palpable in the right hypochondrium. He has visible gastric peristalsis and no other signs of distant metastasis clinically. Endoscopy showed a Bormann 3 growth in the antrum and pylorus. It was causing gastric outlet obstruction as per the endoscopy report. Biopsy turned out to be a signet ring cell carcinoma. And these are the blood investigations. This is quite a common scenario, as most of you would agree, patient coming with dehydration leading to deranged RFT and altered electrolytes and malnourished patient. So as always for all stomach cancers, we did a CT scan. I'm sorry, these are only two pictures that are I'm available. I can show to you right now. So the radiologist labeled this as a clinically T3 or a T4A tumor with enlarged nodes, so an N1 disease. So my first question to the panelists, I would request the surgeons to take up this question. How many of you would ask for a PET scan in this situation? You know how you have a patient with gastric outlet obstruction, diagnosed carcinoma stomach, you have a CT scan. Would you do a PET scan at this moment? Dr. Vikas, can I start with you, sir?
Yeah. Can you hear me?
Yes.
Hello. Yeah, you can hear me. Yeah. So this is a signet ring cell carcinoma, and all of us know that PET CT is not a good investigation for a signet ring cell carcinoma. So this situation, I would not like to do a PET CT. I would have a good CT scan, and that is enough for me.
What if it were not a signet ring cell carcinoma?
So if it is not a signet ring cell carcinoma on a routine basis, I would not ask again for a PET CT scan, because at the present moment, there is not much of benefit of doing a PET CT scan in stomach cancer, and it's not a recommended investigation. So routinely, I don't ask for it.
Dr. Inian, if I can bring you in, are there any specific indications where you would ask for a PET CT scan?
Yeah, firstly, I would agree with Dr. Vikas. I would not do a CT scan in this situation. With regards to when, perhaps if there is something that a CT scan cannot clarify, if there is a possibility of a distant metastasis, or if there is something in doubt that CT scan does not clarify, perhaps there is a role for a PET CT scan. I would perhaps do a PET CT scan in a junctional carcinoma if it was a more proximal, or definitely for an esophageal carcinoma, I would do a PET CT scan. So
I do agree. I also agree on that.
Yeah. So
Dr.
essentially,
Ramesh,
junctional tumors I would do.
Okay. Dr. Ramesh,
I completely agree with the previous two speakers. I won't do a PET CT scan. But having said that, 70% of the patients that I see today usually come with a PET CT already.
Yeah. That is what I was trying to point out. Most of them do come.
Yeah, because they've already had it done. But I won't ask for it. It is not necessary.
In those situations, how often have you found that PET CT scan has actually changed the way you would manage the patient?
Actually, in stomach, not very often. Now, sometimes they will say that there is omental metastasis or ascites. If you had done a good CT, you would have picked up the same thing. So I don't find it changing the opinion. When I look at the plain CT, the ordinary CT, not the PET CT, I find that it is already picked up the same things, and same things have been confirmed by the PET CT. So the number of times it changes is probably less than 5%. So I would not today embark upon it. But as I said, most of them come with it.
So this is an important point for the postgraduates, whoever are listening into this program, that you don't normally order for a PET CT scan in a patient with carcinoma stomach. So now, Dr. Ramesh, how would you manage this patient? Would you prefer to operate on him first? He has gastric outlet obstruction, but he's able to take liquids.
So he has gastric outlet obstruction enough to cause low serum albumin, bilateral pedal edema. So I don't think that he's a good candidate for surgery at the moment, unless we do just a gastrojejunostomy if there is enough stomach to do a good bypass and where he can eat. Otherwise, maybe the best method is to place a nasojejunal tube into the duodenum past the growth and start feeds. And I would do a diagnostic laparoscopy once he has stabilized a little bit before referring for neoadjuvant, because that is our protocol. We find that it helps to differentiate those who would be labeled for neoadjuvant and those who would be labeled for palliative in a significant percentage of patients. So we would do a diagnostic laparoscopy up front, and then after the neoadjuvant, if they've gone through, we would do a diagnostic laparoscopy before surgery on the table, and then proceed.
We'll come to that. So you would not prefer to do a radical surgery for this patient up front?
Not at this moment. He's not fit for a radical surgery. His
what about the other? What about the other surgeons, Dr. Vikas and Dr. Inian? What would be your approach be?
So this patient definitely has got a poor general condition, but he has gastric outlet obstruction, and he will be, it needs to be prepared. So, but chemotherapy, I'm not sure it will help him, because it's, first thing is it's a signet ring cell carcinoma. Response rates are very poor, and the longer we wait for the surgery, the less is the chance of this patient coming up for the surgery. So maybe in this case, if the patient can afford TPN for 5-6 days, give him good hydration, correct his renal parameters as far as possible, and then take it up for surgery.
Dr. Inian, would you do the same, or would you differ?
Yeah, so I would probably go with what Dr. Ramesh had said. I would probably think of giving him, definitely putting a nasojejunal tube for feeding. See how he tolerates. I mean, at least try an attempt of neoadjuvant for him. Obviously, we do a staging laparoscopy before any neoadjuvant that is there. But I would probably err towards neoadjuvant, but with a low threshold of going to surgery if he doesn't tolerate or if there is any issues.
All right. So if I can bring in the medical oncologist, Dr. Rajiv, suppose this patient were referred to you for neoadjuvant chemotherapy. What would you say? Would you accept it, or would you send back to the surgeon saying no?
So as we discussed in many of the multidisciplinary board, somebody who is not fit for a major surgery is a very challenging candidate for getting a good quality neoadjuvant chemotherapy also. So here in neo patient, we have performance status 2 in a 65-year-old gentleman. So we need to look at it in more detail. What are the comorbidities? What is the real frailty index? And what are the other associated factors which is leading to the performance status 2? And more importantly, I will be worried about the creatinine and albumin values. I hope it is the gastric outlet obstruction which is causing, and it should improve.
Yeah.
But
So,
if it doesn't,
what I did
then,
not reveal here.
Yeah, if it
what
doesn't,
I did not
then,
reveal
yeah,
here
sure.
is that the patient was admitted. He was given corrective hydration therapy, and the renal parameters came back to normal. Now, see, this is a situation that we see very often. Patient come with hypoalbuminemia and deranged RFT. Most often with IV fluids, the RFT gets corrected. Hypoalbuminemia, of course, it doesn't get corrected immediately, even with TPN or fees. That takes some time. So, but I should not be giving you the wrong impression. As a surgeon, I felt this patient was suitable to undergo a surgery, not immediately, but after little correction of his deranged parameters.
So
that
from a
was my
medical
assessment of this
oncologist point of view, also a good neoadjuvant chemotherapy would be a flawed regimen, which will include giving docetaxel as well as platinum, or at least a 2-drug regimen that is FOLFOX.
Yeah,
so
that we will come to that.
Yeah, so the platinum will be a problem where we have both hypoalbuminemia and creatinine, which is not reversible.
Yeah. So at this point, can I ask all the delegates who are listening into this to just share their thoughts on what they would do, just whether they would do surgery or neoadjuvant treatment. If they can just type that in the chat box, and maybe Dr. Kannan or somebody can just have a look at that. Meanwhile, Dr. Manikantan, could you just emphasize once again to the younger crowd here, what do you mean by neoadjuvant treatment? What do you mean by an adjuvant treatment? So
yes, sir.
Just,
so,
I know it's very basic, but just for the younger students.
So neoadjuvant therapy is the systemic therapy that is given before the definitive local therapy, that is predominantly a surgery. And adjuvant therapy, adjuvant chemotherapy is basically chemotherapy that is given after the definitive modality of treatment, that is either surgery or radiation. Sir, if I can just add just 1 or 2 points on the surgery versus neo-adjuvant. Like our predominant, like we know, as Dr. Rajiv already told, FLOT is the standard of care, but this patient has got renal failure, hypoalbuminemia, and outlet obstruction, and we think that he may not tolerate. So we would choose an alternative regimen that is like usually K-POX, so that has capecitabine and oxaliplatin. So our concern is daily the patient has to take 5 tablets per day in divided doses. So with outlet obstruction, that could be a challenge. Secondly, when the patient has
vomit out.
He may vomit out. We need to calculate again. And also sometimes we actually dissolve the capecitabine in water and then make the patient to drink. So in terms of the bioavailability, we don't know how much the drug has gone in. The second point is when the patient vomits post chemotherapy, we will not know whether it is related to the chemotherapy associated CINV, chemotherapy induced nausea vomiting, or related to GEO. There could be some clinical diagnostic challenge. And third, I mean, you said, of course, the creatinine normalized. We also know that this capecitabine is not absolutely safe in patients with renal failure. So if creatinine clearance is less than 30, then capecitabine also could be a contraindication.
So yeah, that's a very good point.
I'd like to add
by...
one more thing.
Yes.
Yeah, the point which I wanted to make is that if it was not a signet ring cell carcinoma, the point which Dr. Ardhanari made, that you can put in a nasojejunal tube and probably hydrate the patient and nutritionally improve for a few days and then take it up for surgery would be a very good idea. Routinely, we do not do that. So, but the other point which I would make is that after surgery, because the patient is hypoalbuminic, you will like to achieve the nutritional requirement on the day first post-op day itself. So you will add TPN and the nasojejunal feeds or jejunospal feeds immediately.
Yeah. So I think there are
I think,
points that have been.
Dr. Ramakrishnan, there is one alternate treatment which nowadays is becoming a little more popular. If the length of the obstruction is not too much, then we have to think of the viability of putting a temporary stent across the obstruction endoscopically, so that the patient can eat better quality food than you can give through a jejunostomy, and then he may improve more rapidly for you to do a neo-adjuvant or go for a surgery.
Yeah, your point is taken. Provided all the, the situation is ideal for inserting a stent, that is something that we could consider. So this is not a straightforward situation, although it may seem very simple. A patient with gastric outlet obstruction, he will require surgery or he would require neo-adjuvant treatment. The things that we need to understand is he may not be a good candidate for a major surgery in the first place, but for the same reasons, he may not be a good candidate to receive the ideal chemotherapy. And if you choose a less ideal chemotherapy, like what Dr. Manikantan said, alternative option of capecitabine and oxaliplatin. Capecitabine is given in the tablet form, and it may be difficult to administer that in a patient with an outlet obstruction, even through a nasojejunal tube. We are not sure how much of it is actually absorbed. So it is not a straightforward decision. I think this is something that needs to be individualized, and you can't say that for all gastric outlet obstruction you would operate or you would give neo-adjuvant chemotherapy. So do we have any responses on the on this question from the delegates? Anyway, so again, this is data from the National Cancer Registry Program. As you can see, in India now, multimodal therapy is becoming quite popular. And this is the situation that we are discussing about, the loco-regional disease. And as you can see, a very small proportion of patients receive only surgery. Most of them receive some form of adjuvant or neo-adjuvant therapy, either systemic therapy or multimodal therapy, which may include radiation as well. So it is a good thing that the concept of multimodal management in stomach cancer is slowly becoming popular. I think this question was already answered either by a nasojejunal tube or, as Dr. Vikas suggested, by TPN. So Dr. Rajiv, can you tell us what is the evidence for giving neo-adjuvant therapy in gastric cancers?
So in this, we are actually calling it as a perioperative chemotherapy. where we will give around 3 to 4 cycles of chemotherapy before surgery and 3 to 4 cycles of chemotherapy if possible after surgery. A well-conducted phase 3 randomized trial many years back, the MAGIC trial, which told us that the 3-drug regimen constituting of epirubicin, cisplatin, and 5-FU, ECF regimen, which was compared to surgery alone, there was significant improvement in the resectability rate as well as the achievement of PCR. In the last few years, this regimen was again compared to a FLOT regimen. FLOT regimen consists of 5-fluorouracil, leucovorin, oxaliplatin, and docetaxel. Now, this is an anthracycline-free regimen, which will be useful for many of the elderly patients. But mind you, this is a very toxic regimen. We need to select out patients for really good performance status before we decide, because there is significant febrile neutropenia and we might lose patients also here. But if properly subjected and selected, then we can apply 4 cycles of FLOT before surgery. And we have significant improvement in resectability, PCR, as well as improvement in disease-free survival. So if possible, FLOT should be the ideal.
Yeah. So is that what is the current preferred regimen to be used in neo-adjuvant chemotherapy?
In a multimodality discussion, we have been sort of decided on a perioperative regimen. Then FLOT is the ideal way and with the most robust evidence. As Manikandan was mentioning, we will not be able to deliver in our subset for quite a number of patients FLOT. Then FOLFOX or CAPOX are alternative regimen, but then the numbers come down regarding the resectability as well as the PCR.
So, Dr. Manikandan, what about adjuvant chemotherapy? What is the evidence for adjuvant chemotherapy?
So the adjuvant, the first trial we had is the classic trial that resected post D2 resection. We had the regimen that was CAPOX was used for 6 to 8 cycles. So that clearly improved the DFS and OS, and that set the standard that if a patient undergoes straight surgery, then CAPOX would be the standard of care. And there was also a few studies from Japan where they used the S1, that is an oral drug. Again, this was a completely resected tumor post D2 resection. There was a clear improvement in the DFS and OS. And then we had a few other studies, the ARTIST trial that actually in more of chemoradiation, and the intergroup trial also is for a selected subgroup of where we give chemoradiation. So in the adjuvant setting, we don't have evidence for using anthracycline. It's usually a non-anthracycline based regimen for 6 to 8 cycles. That will be roughly 6 months post-operatively.
So coming back to Dr. Rajiv again, what is the need for giving neoadjuvant treatment? I mean, stomach cancers are basically surgically treated tumors. So what is the need for giving chemotherapy before surgery?
Before answering that, I'll just add on to the adjuvant chemotherapy part.
Yes.
For the younger surgeons in the group. So the adjuvant chemotherapy that Mani described, that is the capecitabine plus oxaliplatin that we give based on classic trial, is only for patients who has undergone D2 dissection. So a surgery should be a complete before we offer adjuvant chemotherapy, and it should be a D2 dissection. That is what the trial was meant for. If we have a less than D2 dissection, then adjuvant chemotherapy alone may not be enough, and we might have to discuss about post-operative chemoradiation based on the intergroup trial. Now, coming to the question of neo-adjuvant chemotherapy, as we discussed, surgery alone in a locally advanced stomach cancer has shown not so good results. So when we add chemotherapy earlier, that is the perioperative or the neo-adjuvant approach, we actually are improving the resectability. We are actually improving patients who undergo PCR. PCR is pathological complete remission, where there is no tumor at the end of 4 cycles after we do a surgery, and that is the best case scenario. In any patient who has undergone a PCR has shown to have the best survival. So we actually prognosticate and predict the patients who can do better in our subset of patients, which we may lose in an straight surgery and if you're doing an adjuvant chemotherapy approach. Third wise, and it actually assess the response to chemotherapy. So there are some trials which are going on where if there is any inadequate response to chemotherapy, whether we can change the agents and use a different agent, though that is not yet standard. And of course, we as medical oncologists feel that these aggressive regimens like FLOT are better delivered when there is a stomach in situ. After a gastrectomy, it becomes challenging to deliver adjuvant chemotherapy, and the tolerance also comes down compared to a neo-adjuvant approach if we can select out our patients. So I think these are the few reasons. As medical oncologist, after MDT discussion, if the patient comes into the criteria, a neo-adjuvant chemotherapy should be offered to majority of the locally advanced stomach cancer.
Okay, so let me ask the surgeons, do you agree with this concept of neo-adjuvant chemotherapy, especially that their compliance, Rajiv was suggesting that the surgery that we perform may probably render the patient incapable of receiving further chemotherapy after surgery. So is this a common scenario that you come across, that patients after surgery, that they do not complete the chemotherapy?
Professor Ramakrishnan, sorry
Yeah,
to disrupt you. One moment, sir. One moment.
Yeah.
Yes.
We have Professor Tabish Chawla from Pakistan also along with us. Maybe you can also take
Sure,
his
sure.
point.
Yeah.
Thank you.
Sure. Yeah.
Right. Yes. The new adjuvant treatment for locally advanced CA stomach has virtually become a standard of practice. So how we do it, that we get the referral for staging laparoscopy and feeding jejunostomy in one setting. This is what we do, and then our oncology colleagues give the new adjuvant. And in some of, obviously this is anecdotal, in some of our patients we have seen excellent response, and the resectability improved remarkably. But this is what we do.
So coming back to the earlier question, Dr. Vikas or Dr. Inian, have you seen patients not being able to complete the chemotherapy after they undergo surgery? Is it quite common? Or?
Yeah, I think that's quite common. Even if they have a minor complication like a pneumonia or a minor duodenal leak, they go down, and then to get them back to the condition where they can tolerate aggressive chemotherapy is less. So I think that we have all now seen that it's better for patients. They tolerate the neoadjuvant. And there's one more advantage, which I, at least as a surgeon, I see, and that is if the neoadjuvant chemotherapy has been given, and I find that the disease has progressed in spite of that at the end of 3 months, then that patient is a very bad case for surgery. They don't do well at all.
So I just want to bring in a point whether we are overestimating the non-compliance rates, because this is a good table that I found in a good review article about multimodal management of gastric cancers. Contrary to our belief, most of the trials of surgery versus adjuvant chemotherapy, the compliance of adjuvant chemotherapy has been pretty high. More than 2/3 of the patient have actually completed the adjuvant treatment, whether it is radiation or chemotherapy. Whereas if you look at the perioperative trials, where chemotherapy is given before and after, the compliance rates are actually less than what you see in patients who undergo adjuvant chemotherapy. Now, I don't know the reason for this, but I just thought this should stimulate some thought as to whether the compliance is really an issue in the post-operative setting.
Just to add on, so
Yes.
all the preoperative chemotherapy where the chemotherapy delivery was the issue was in the post-operative setting. So it is after the most of the patients get the first 4 cycles, especially in the MAGIC trial, only 42% of the patients actually receive the post-operative setting.
I understand.
So adjuvant, which is usually a concern, and the classic trial is a well-conducted trial from Korea and Japan. Their tolerance is at a different level, and usually they'll have a much better compliance. So the point here is, if anything less than capox is given, then it is not a good adjuvant chemotherapy as per evidence. So we should be making sure that if patient is fit enough, they should get capox, and if feasible, because of the other advantages, they should get a perioperative regimen. Either way, they have to be fit for the standard protocol.
Okay, so Dr. Manikandan, what are the disadvantages of giving neoadjuvant chemotherapy? Dr. Ramesh mentioned that there is a possibility that the tumors may progress in spite of chemotherapy. Is that a reason to fear for the surgeon? So won't the patient say, you delayed surgery and that is the reason why I progressed? how do you answer a patient in such a scenario?
Probably we will look at it in the way that you have actually selected out a poor prognostic factor tumor. Like if you have operated, maybe the patient would have had early recurrence before he has recovered out of the post-operative time. So in essence, the people who progress on neo-adjuvant chemotherapy, the rates is going to be very less. So I don't see as a point of disadvantage of neo-adjuvant chemotherapy. And so can I add one point?
Sure, sir.
Hello?
Yes, sir. Please go ahead.
Yes. So the problem here is of Indian patients. So Indian patients post-operatively do not tolerate so easily. This is a problem which we see in ovarian cancer also. There are a lot of patients who come in a very poor general condition, and post-chemotherapy, they are ready for a very major surgery after the chemotherapy. The same thing applies to stomach cancer also. But of course, what I do is that if it is, we have to now look at patients who have who are likely to have a good response to the chemotherapy. So in this particular case, that's why I mentioned that it's a signet ring cell carcinoma. The response to chemotherapy for signet ring cell per se is very poor. And this is a kind of patients where if it is operable, you will preferably go ahead with surgery rather than giving chemotherapy, and you will otherwise post chemotherapy, you make the progression of the disease. So, but the other point is very true, which all the medical oncologists are pointing out, that the tolerance or they go through the chemotherapy much better in the pre-operative setting than in the post-operative setting. And of course, the number of patients who are operable, especially patients who may not be operable, may become operable. The operability rate definitely improves if it is done post-chemotherapy. On the other hand, the surgery, although Dr. Ramesh said it has become much more easier, I have seen a lot of fibrosis, and the oozing is terrible.
We will come to that.
sometimes.
We will come to that
So
point. We will come to that point, sir. So I just
Yeah,
want
I'll
to
stop.
ask Dr. Manikantan. Now we have two schools of thought. One is to operate first and give adjuvant chemotherapy. The other is to give chemotherapy first and then perform surgery. Is there any direct head-to-head comparison? Can you say that all patients should receive neoadjuvant, and that should be the standard of care? Because many guidelines now seem to be recommending neoadjuvant chemotherapy or perioperative chemotherapy, and for some reason this is being propagated that all patients should receive neoadjuvant chemotherapy. Is that true? Is there any evidence to say for or against it?
yeah, so one of the limitations is at the moment we don't have a trial that compares total neoadjuvant therapy versus total adjuvant therapy. So all the studies are either in the adjuvant setting or in the perioperative setting. So I mean, of late, Dr. Biswajit from JIPMER is planning for a randomized control study of total neoadjuvant versus total adjuvant. So that question may be answered by whether total neoadjuvant could be better or adjuvant may be better. So I think if patients present with obstruction, they do very poorly in terms of giving a neoadjuvant systemic therapy. These patients should probably undergo surgery. And we also, Dr. Ramakrishnan has actually, this is a major publication from our institute. And we were all thinking that patients who receive this obstruction, who undergo straight surgery, they'll have a poor prognosis. But in this propensity score matched analysis, there was no difference in the outcome. Even patients who underwent straight surgery and adjuvant therapy had the same outcome as compared to the perioperative chemotherapy.
Yeah. So the reason we undertook this study is because there is no direct head-to-head comparison between perioperative versus adjuvant. We have trials comparing perioperative versus surgery or adjuvant chemotherapy versus surgery. So that is the reason we looked at our patients because we have treated patients by both methods. So this was a propensity score matched analysis, and we found that there is no difference in the 3-year disease-free survival whether the patient undergoes neoadjuvant or the perioperative chemotherapy or adjuvant chemotherapy. And more surprising, we found that all the number of patients who completed all cycles of chemotherapy was not significantly different whether you gave it as a perioperative or as adjuvant. So this is something that I think we all should take up and notice that contrary to our expectations, even Indian patients do complete the planned chemotherapy to a great extent. So coming back to Dr. Vikas, you were mentioning about operating in patients who have had neo-adjuvant chemotherapy. So do you think it really makes the surgery more difficult, and does it increase post-op complications? I would also like to ask Dr. Tabish, because he was talking about surgical complications, whether neo-adjuvant treatment increases post-operative complications. So Dr. Vikas and Dr. Tabish and the rest of the surgeons can also please give their opinions.
Based on the increase in the complications, but what I see is surgery wise, the difficulty of surgery somewhat increases. There's a lot of oozing, as I mentioned. As far as the post-op complications, per se, post-op complications do not increase. But what happens is that the recovery of the patient is delayed. So normally, if a patient undergoes primary surgery, his recovery will be within 10 days, he will be off. But post-op, this thing in after the neoadjuvant chemotherapy, I find that sometimes they take much longer, even a month before they become more normal, and all the nutritional problem goes away in spite of very aggressive pre-operative preparation, or when they are getting the chemotherapy. That time, if it is prepared, then also we find post-op problems are more.
Dr. Tabi, what is your take on?
I don't know what is the experience which you have. This is the problem I am facing repeatedly. So sometimes I get a little this thing about pre-operative or neoadjuvant chemo sometimes.
Right. It all depends on the general status of that particular patient at the time of diagnosis and post neoadjuvant treatment. And if we have a patient who is emaciated, frail, then obviously the outcome of surgery, which may be related to the surgery, or general outcomes may differ. But if a patient is adequately, fed during the chemotherapy, and that's why, as I mentioned earlier, we almost make feeding genostomy in all of our patients before neoadjuvant, leaving one or two aside depending on some reasons. But so if the feeding is established and feeding has been adequate, then we haven't seen any patients having increased risk if they maintain a general physical status reasonable throughout the neoadjuvant treatment and are just before the surgery. But if you have a patient who we haven't been able to establish good nutrition, then there are high chances that we may end up not doing the surgery and continuing with some kind of palliation, or they are having bad outcome. It all is relevant.
So Dr. Ramesh and Dr. Inian, you perform laparoscopic surgery. So does laparoscopic surgery become more difficult after neoadjuvant chemotherapy?
Okay, I'll answer first if that's okay.
Sure.
Basically, we have been in our institute giving neoadjuvant therapy for quite a number of years. And we personally did not feel that it made surgery too much more difficult, or the outcome certainly wasn't affected by the fact that the patient had neoadjuvant therapy. I agree with Dr. Vikas, probably at least during laparoscopic surgery, maybe there is the oozing maybe slightly more, but it isn't something that would prevent us from saying, no, we would rather give it post-op. So, and I would completely agree with Dr. Tabish in that the patient's nutritional status is very, very important. The patient should not be nutritionally more depleted than when we start the chemotherapy. So if you take that into consideration, and if you do a meticulous surgery, I think it doesn't make much of a difference. That is our personal experience. Dr. Ramesh can add to it.
What is your opinion, sir?
I completely agree with Inian. Personally, I have not felt either the open or the laparoscopic operation to be more difficult in these patients. The only time that I think the operation becomes more difficult and you get this fibrosis is if you have given radiotherapy and the patient has crossed that golden period of 8 weeks inside which at which time we should operate. If they for some reason delay because they are feeling all right, they're able to eat, and they come at 4 months or 5 months, yes, the addition of radiotherapy can make at that time a fibrosis more difficult, but not in the early parts.
So while we were looking at our data, one interesting thing that we found was, like Dr. Vikas mentioned, the incidence of fibrosis and difficulty in nodal dissection was correlating with the pathological response of the tumor. Patients who had a very good tumor regression grading or even a complete pathological response were the patients who we found most difficult in doing the nodal dissection. And most of these patients, most of these patients had a complete pathological response. So now we have come to a stage where if we find during the course of surgery that nodal dissection is becoming very troublesome and with a lot of bleeding, we can be fairly sure this patient has got a complete pathological response or at least a very good pathological response. So, and this is even more in patients who initially presented with bulky nodes and following chemotherapy, the nodes have regressed considerably.
Very true.
Enable
Very
us
true.
to undergo surgery. So I think in these sort of situations, we found that it is better not to abandon the surgery, but even a less than a D2 dissection would help this patient because he is ultimately going to have a good pathological response to chemotherapy. Now, let us look at the factors that would affect the choice of treatment. We have already discussed about gastric outlet obstruction. That was this patient. And Dr. Vikas did mention that signet ring cell cancers do not respond very well to chemotherapy. What about the location of the tumor? Will a location in a proximal tumor or whether it is a distal make a difference in choosing whether to give chemotherapy or operating first? Anybody would like to answer this?
Proximal, we would certainly go out a lot more to give chemotherapy as in the neoadjuvant setting as compared to distal. So our threshold for upfront surgery would be more for distal tumors rather than proximal tumors. So that is our experience so far, at least.
I would completely agree with Inian.
Yes, Dr. Vikas.
So we normally give it for proximal as well as distal, provided in the distal tumors, in the history, there is hardly any this thing of vomiting, and endoscopically, you are able to either cross this thing in spite of that kind of an obstruction. In those cases, we normally start and we advise the patient about the nutrition part of it with liquids, and we find that they do respond pretty well. So both proximal and distal, this case which you showed, of course, had practically complete obstruction. It's a different thing. That case, we will preferably go ahead with surgery first.
What about
clinically
about
node
the
negative
signet
ring versus clinically node negative? I normally would have not gone for chemotherapy first, and this poorly differentiated versus signet ring. Some poorly differentiated with signet ring, we will go with chemo. But only signet ring are the ones which are worst. They did not respond to chemotherapy. So
would Dr. Rajiv agree with that? That signet ring or probably even mucinous tumors may not respond so well to chemotherapy?
Yeah, as a general dictum, yes, they may not respond as well, but we don't have a guideline to choose which subtype will benefit from what type of chemotherapy, because basically the trials were conducted with all comers. But
so you would not refuse chemotherapy just because he's a signet ring.
That's true. Yeah, and coming to the proximal versus distal, I think the whole world is for perioperative chemotherapy, and chemoradiation is not considered generally in gastric cancer. But if there is a subset who will benefit from a chemoradiation approach, that would be an OG junction or a much proximal tumor, where the cross trial had significant number of patients who had an OG junction tumor and they had a good result. So if at all we are using preoperative chemoradiation, that would be in a proximal tumor. And I agree with Dr. Vikas that node negative, it becomes a good idea to exactly stage the disease initially, so that we, at least in a small subset, we can avoid chemotherapy if they are pretty early stage.
So the general feeling is node negative tends to do pretty well, which is all right. But there are subsets even within node negative tumors that do not do so well. In our experience, we have seen that T3 tumors or tumor size more than 3 centimeters, these were independent predictors of poor prognosis, even if they were node negative. So probably we should take other things also into consideration before deciding on chemotherapy in node negative tumors. So
see the real world situation is, if it is a T3 tumor, it is very difficult to predict also unless you do all kinds of investigations to rule out a nodal metastasis. So those cases will invariably go in for chemotherapy.
So, Dr. Manikandan, can you predict the response to chemo? I mean, can you choose patients that, okay, they are not going to respond to chemo, so I will probably not give? Or would you want to give a trial of chemo, like Dr. Inian said, maybe 1 or 2 cycles and then see? So how would you predict response to chemo?
Yeah, I think at the moment for eligible patients, we would offer systemic therapy. But more recently, we have more data coming up that patients with high tumor infiltrating lymphocytes, they have a very good prognosis. And probably these patients may not benefit from therapy. That is again very recent.
What about PET scan? Would a PET scan help in predicting response to chemo?
I'm not aware of, sorry, sir.
No, I mean, you do a PET scan, you give 1 cycle of chemo, and then you do another PET scan. There are some reports that,
Yes.
you know, Dr. Reggie, would you like to comment?
Yeah, so again, to the younger audience, this is not standard treatment, but there have been studies looking at it where 2 cycles of chemotherapy was given with a baseline PET scan comparison. And then the metabolic response criteria correlated with the PCR rate. But then, you know, we should not be using it in standard practice to really predict.
But Rajiv, this has been more extensively studied in esophageal cancer.
Yes,
And
G junction and esophageal.
They don't recommend follow-up PET scan because they say it's a very poor factor to predict response. The literature actually doesn't favor follow-up PET scan.
So coming back
So
to
there is a
yes sir, yes.
So there is a particular study in which they have used it for G junction tumors, where they start with 1 type of chemotherapy, and after 1 cycle itself they do the PET scan, and if they see that there is no response, they change the chemotherapy and then go, because in the proximal tumors chemotherapy is very important to be given as a neo-adjuvant setting, and if the tumor doesn't respond to the first line chemotherapy, then maybe the second type, say either capox or your FLOT regimen can. So that one particular study, maybe more studies have come. This study maybe is already 3-4 years old, which I had read. So,
but
it's not a standard of practice.
I was looking up this recently in UpToDate and looking at the current recommendation based on all the studies up to 2019. The current recommendation in esophageal cancer, because gastric cancer, I don't think there are any studies, is that you don't do a follow-up PET scan. It is not recommended.
Agreed.
So at the moment, there is in the real world practice, we don't really look at anything to predict the response to chemotherapy. If you decide on neo-adjuvant chemotherapy, we complete the planned course, isn't it?
Yes.
So how many cycles would you prefer, Dr. Rajiv?
So if it is a FLOT regimen or a FOLFOX, which is the one which we usually use, then it will be 4 cycles. 4 cycles of FLOT, and then we will have a reassessment.
And Dr. Manikandan, how will you assess the response?
So we assess response. Yeah. If we use, as Sir told, if it is FLOT regimen, it is 2 weekly. After 4 cycles, we assess clinically and by radiologically by a CT imaging. And if we use the EOX or CAPOX based regimen, is usually after 3 cycles, we reassess for response for surgery.
Okay. So now, coming back to the surgeons, I think the first question is probably irrelevant, or everybody does laparoscopy for gastric cancer. But the question is, when you plan for neo-adjuvant, I think Dr. Ramesh had already answered this. When do you do a laparoscopy? Do you do a laparoscopy at the very beginning, before even planning neo-adjuvant chemotherapy? Or do you do it at the time of surgery as part of the major surgery? Because especially in India, this is a huge logistic issue, because if you're doing it as a separate procedure, the patient has to pay for another surgery. So how do you plan this?
We did one thesis. So we did one thesis in which we looked at the laparoscopy before neo-adjuvant to see how many percentage of patients it changed, and it was about 30% before neo-adjuvant that it showed metastasis along the peritoneum, along the surface of the liver. So in our opinion, this changed it from neo-adjuvant to palliative treatment. And so we send these patients for palliative to the medical oncologist for palliative care. And some people could argue that chemotherapy could be given and these would, but I think once it has gone to the peritoneum and to the surface of the liver, it doesn't change. The prognosis is bad.
And
so we would do it.
Yes, Dr. Emil.
Yeah, sorry. So our protocol is almost similar. So we do prior to NACT, we do staging laparoscopy. Again, I think it was around the same time that we also looked at, and about 20 to 25% of there was a change in treatment plan based on the preliminary staging laparoscopy. So the laparoscopy is still part of the staging investigation, and we do it as a standalone procedure before we give neoadjuvant chemotherapy. Now, to answer the second part of the question, would you then, after giving neoadjuvant chemotherapy, do another staging laparoscopy? We don't do it now. We just do a CECT, unless the only one situation where we would repeat is perhaps a cytology positive, but no peritoneal disease, where we don't change the management of the patient. In that situation, maybe we would repeat the staging laparoscopy. But otherwise, if we do see peritoneal nodules, then at this stage we send them for we don't come back to surgery. So
if I can just add one point.
Yes, Manikandan.
Yeah, so I mean, the current guidelines recommend T3, T4 or node positive to do diagnostic laparoscopy. So at our institute, we found that one of the retrospective studies, the signet ring histology has the highest risk of having a peritoneal disease. And in our institute, because of the load and the logistics, actually sometimes we avoid laparoscopy and go for straight surgery. So there is one issue, like in case after neoadjuvant chemotherapy and then when we open up and there is a lot of peritoneal disease, we may not know whether it is a response to whether the patient has progressed on therapy or it has been an extensive peritoneal disease that has responded. So in terms of explaining to the patient, this has caused some concern, especially when we've missed pre-op laparoscopy and post chemotherapy. When we fight peritoneal disease, we have had some kind of difficulty in that area.
So this is a very fine line to walk, because on one hand, you have to tell the patient, look, you're going to need 2 surgeries. You need to pay upfront for a laparoscopy first, and then you will have chemotherapy and then another surgery, which many of our patients find it difficult. But on the other hand, like Manikandan rightly pointed out, if you do not do a complete staging, there is always 15 to 20% chance, especially in signet ring cell cancers, that after chemotherapy, when you do surgery and you do a laparoscopy at that time, you find that the patient has got peritoneal disease. So it is not uncommon for the patient and the attenders to think that your chemotherapy did not work, you unnecessarily prolonged the surgery, and that is why he has developed metastasis. So it is a fine balance that you need to maintain. Take the patient and attenders into confidence if you're not planning for upfront laparoscopy. That is what we practice, especially in signet ring cell cancers. We somehow try and get the laparoscopy done because we found that the incidence of peritoneal metastasis is high. Yes, Dr. Vikas, please, sir.
Yeah, so the same thing, you need to, based on the CT scan, if you think that the patient is likely to have peritoneal disease pre-op, pre-chemotherapy, it is better to do the laparoscopy, or at least explain to the patient that if you do laparoscopy as a separate procedure in this situation, it is better. But a lot of patients, of course, logistics, as you said, is very important in most of our patients. And of course, if you are into a more aggressive treatment regimen, then definitely this will work out very well. You can put an intraperitoneal chemotherapy port and you can combine chemotherapy intraperitoneal with IV chemotherapy as a neoadjuvant in the neoadjuvant setting, especially if the wash is positive or if there is some minimal amount of peritoneal disease. You can elaborate on that, of course.
Dr. Indian, you were mentioning about the peritoneal cytology turning negative after an initial positive, or the other way around. So do you routinely practice peritoneal lavage cytology whenever you do a laparoscopy for a gastric cancer?
Yeah, so when we do the staging laparoscopy upfront, we send it for peritoneal lavage cytology.
And what percentage of patients has it generally turned out to be positive?
Yeah, so the positive, that is the thing. So initially, when we looked at just normal cytology, the positive rate was very, very low. And in fact, even patients who had obvious ascites, when you send it for cytology, sometimes it comes as negative. I'm talking about gross peritoneal disease with ascitic. You send it for cytology, it's negative, which is which is hard to believe. So anyway, the last couple of years we've been looking at doing RT-PCR on these, which is a little bit of an overkill, but one of our PG students has just finished or just finishing his study on this. So maybe we will know a little bit more on how, whether we need to look at it in a little bit more than just doing normal H&E stain. But the
generally
the practical things are, one is as soon as you take it, it should be immediately sent. You can't sit it lie in the fridge and then send it the next day. It needs to be spun immediately and centrifuged and looked at. So I think as long as you do that, there are practical issues with doing that, but that would be an ideal situation. And I personally think the RT-PCR may be too much of an overkill, where we may not be able to change our treatment plan based on that. But just as a study, we are doing that, and we'll be able to tell you.
So for the benefit of postgraduate students, one thing you need to understand is peritoneal lavage cytology is not something like frozen section where you get the report immediately in 10 minutes, because it needs to be spun, cell blocks needs to be made, and they have to be stained and studied. This takes time. It takes at least 4 to 5 hours. So other than doing it as part of your routine procedure, you cannot make treatment decisions on table with peritoneal lavage cytology results. Am I correct, Dr. Renian?
Yeah, exactly.
Yes.
That's true.
Yes, that is true.
So, so this is why the peritoneal lavage cytology is important, because even though the pickup rate is very low in our own center, postgraduate thesis was done, and even with addition of immunohistochemistry, the pickup rate was only around 5 to 6%. I'm sure with RT-PCR the rates are going to be at least double or more, but in general the pickup rate of positive lavage cytology is quite less. But the significance of identifying a positive lavage cytology is that the survival of patients who have a positive lavage cytology in the absence of gross overt peritoneal metastasis is quite poor, almost 0% at 5 years. So which is actually as the same as a patient who would have a peritoneal metastasis. So the reason, the previous AJCC system itself classified a peritoneal lavage positive cytology in the absence of a peritoneal disease also as M1 disease. But the whole issue here is there is still no clarity on what you would do for a patient with a positive lavage cytology. I think the general tendency would be to go for neo-adjuvant chemotherapy. Is that correct? Or are there other options? Would you operate on a patient who has a positive lavage cytology? Dr. Ramesh, what would be your take on that?
I would send the patient for neo-adjuvant, and after instead of 3 cycles, I would even ask my oncologist to go for 6 cycles so that I can get a better response. Repeat the laparoscopy, and if still no peritoneal mets have come, then go ahead and do a gastrectomy.
But would you do a lavage cytology the second time?
No, by second time, if the cytology was positive, I would expect that peritoneal mets should have appeared. And if they have not appeared, I would be optimistic and go ahead with a resection, give the patient the benefit of the doubt.
Opinion, what would you do?
I would do exactly the same thing, except that I would repeat the cytology in the second one. I'm not going to change or alter manual. I will still go ahead with the gastrectomy, providing there is no gross peritoneal disease. But I can at least tell the patient, look, your second cytology was also positive. However, we've done the gastrectomy. So, the chances of recurrence, at least it can be a prognostic factor.
Yeah. Yeah,
but
in fact,
if we find progression, then probably we would stop and not operate.
Yeah. So there is evidence to say that a non-responder in the peritoneal cytology does extremely poorly, meaning in upfront peritoneal lavage cytology positive, you've given neo-adjuvant chemotherapy, you repeated the lavage cytology, it is still positive, these patients tend to do pretty
Too
bad.
badly.
But on the other hand, if they convert from a positive cytology to a negative cytology, the results are almost as good as if they were negative cytology upfront. So, but still, I think this is an evolving field. We still don't know where we stand with respect to peritoneal Lavard cytology positivity and chemotherapy and surgery. So, I think we'll just skip this part. So, what we decided to take this patient for surgery. The reasons being it was a signet ring cell cancer, and our anesthetists were quite comfortable, and the surgeons were quite comfortable in operating this patient upfront, and he did have outlet obstruction. So in laparoscopy, we did not find the peritoneal disease, so we went ahead and did a distal subtotal gastrectomy with a D2 dissection. Now, suppose the same. Before I proceed, Dr. Kanagavel, is it time to wind up, or can I continue for some more?
How many more slides do you have, sir?
Okay, okay. Just maybe 3-4 slides I can.
I think we will run through and finish. Every slide answers very clear, pertinent questions. You run through the remaining 3 slides.
Sure, yeah. So I think this is just a quick answer. Suppose this patient had peritoneal nodules on laparoscopy. Would you he has outlet obstruction, mind you. So would you just do a feeding jejunostomy or a bypass or a resection, or would you do nothing and then just put a stent if possible? The surgeons.
So depending upon the number of peritoneal nodules, we will probably resect and do a HIPEC also. Otherwise, we will put in a chemo port and do a bypass and come out. If the disease is too extensive, as you say, then feeding jejunostomy is the last option.
Okay, Indian?
Yeah, exactly same thing. We would try to resect if it is small volume peritoneal disease. But if it is too extensive feeding jejunostomy, in between would be a gastric jejunostomy. But if it is locally resectable, we will try to resect it.
In spite of
I would hesitate to resect in a patient who has got multiple peritoneal nodules. If the stomach has adequate place, then I would do a laparoscopic gastrojejunostomy, because that would be much less morbid for the patient. And I don't like to do a feeding jejunostomy if the primary is not curable. I have that philosophy. If the primary is not curable, I don't do a feeding jejunostomy.
Okay, and the final histopathology report was an adenocarcinoma extending to the serosa with a focal breach of the serosa. So it's a T4A. None of the nodes that was dissected turned out to be positive.
Are we to understand that this is not a signet cell carcinoma now?
Yeah.
From the final report?
Yeah, so that is the confusion. Initial report was signet ring cell, but the final report, they've just said adenocarcinoma grade 2 to 3. This is not an uncommon experience. Sometimes the pathology report does change from the initial to the final histopathology. So the final report was not a signet ring cell. So in this situation, this patient is chemotherapy naive patient. He's had only surgery. It is a T4A N0 disease. Dr. Rajiv, what would be your plan of further management?
Yeah, so he will require adjuvant chemotherapy capox into 6 cycles. Yes.
Dr. Manikandan, would you agree with that, or would you want to give radiation as well?
So I would agree with Dr. Rajiv, because the ARTIST trial, that patients who underwent D2 resection did not benefit with the chemoradiation. So I would prefer only adjuvant capox 6. So only for patients with less than D2 dissection or very high nodal positivity, that may be a case of chemoradiation, the McDonald's regimen.
Would the surgeons agree with that, or would any of you prefer to add radiation as well?
I would perfectly agree. Chemotherapy, capox post as adjuvant, I would agree.
Surgeons are good friends of medical oncologists.
Same here, yeah.
Better be. So suppose you had given neo-adjuvant chemotherapy for this patient as part of a perioperative program. How important do you think is to complete the adjuvant part of this program? Can you just stop with the neo-adjuvant part and say, okay, I've given in 3 cycles, let's be done with that?
No, I think you have to complete it. That if the patient is fit, you have to complete the full course.
Dr. Rajiv?
Yes.
You would agree with that?
Yeah, so if we had given a flawed regime and he has not gone into PCR, yes, we should complete. And although we have data from the MAGIC trial where patients who had just completed the perioperative arm had the same benefit as patients who had completed all the cycle, but from the patient's perspective, if the performance status is good and is good to go, we should complete 4 cycles of flawed. But what happens practically is, again, as I told, a post-operative may not be a good candidate for flawed. In that case, at least FOLFOX into 4 should be finished. So we will ideally complete the same cycles, but if not possible, at least 2 drug regimen to complete all the cycles, yes.
So last 2 questions quickly. Suppose this patient had a complete pathological response to neo-adjuvant chemotherapy. Dr. Rajiv, you had mentioned that they have a very good long-term outcome. So in that situation, can you avoid post-operative chemotherapy?
If I have a PCR, usually surgeons are happy, patient is happy, I am happy, but again, I will continue and complete the 4 cycles.
And what about if there is a poor response? Would you want to change your chemotherapy or would you still continue the same chemotherapy? Dr. Manikantan?
Yeah, I mean, with the current available evidence, we don't have evidence to support risk-adapted therapy based on PCR. I mean, we continue
That is
the
a
same,
problem. That is the problem with every medical oncologist I'm facing.
but
The response is so poor.
Yeah, right. So by
But they
logic,
don't
we
want
need
to
to
change.
change. Yeah. So I mean, recently we had breast cancers completely change in triple negative and HER2 positive. There we have risk adapted therapy. I'm sure in a short time we'll have more trials to address this poor responses, and there may be a case for switching systemic therapy based on the response.
So just hold on, Vikas sir. So we just had a concluded ESMO where a patient who did not have PCR went on to receive immunotherapy, nivolumab. And, although 3 trials were negative, one of the trial is shown positive. So as of now, it is not changing practice, but we are looking into it and hopefully we'll have positive data of changing to immunotherapy, another regimen, and then we will have a positive benefit. And next meeting we'll come back with that, sir.
So as of now, there is no role for changing the chemotherapy regardless of the response. You would continue chemotherapy as you had planned at the beginning of treatment.
That's true.
So thank you, everybody. This has been a very wonderful discussion with very good inputs from the surgeons as well as medical oncologists. And we've been able to see eye to eye both surgeons and medical oncologists, which itself is a very good thing. So thank you once again. And thank you,
I think we see eye to eye because the medical oncologists have now produced the evidence that the results are improving with this treatment. So I think that all of us go for our patients' benefit. At least in the beginning, about 20 years ago, when we started talking of neo-adjuvant, in every meeting at the lunch break and at the dinner break, the surgeons were upset that no, we don't want to send our patients for pre-op because they will never come back for surgery. I think that has gone away. I think that fear has vanished, and
that's why I showed the National Cancer Registry report.
Patients do come back and they do complete their treatment. So I think they have produced good evidence, and I think it is only correct that we should, for benefit of patients, follow it. And I think, fortunately, the new generation of surgeons are better read, and they see the evidence and they follow the evidence.
So to conclude,
it is also a progress. It is also a progress on the part of the medical oncologist to also look at the nutrition part of the patient, which is much better now post chemotherapy, as well as their exercise status. All these things, if they are being followed properly in all preoperative or neoadjuvant status chemotherapy for GI cancers, the outcomes have become much better.
Can I ask the medical oncologist one question? There was a lot of talk about 10, 12 years ago about HER2 receptors in gastric cancer and esophageal cancer. Do you still use these if the receptors are positive in the biopsy? What is the current status of that?
So in metastatic breast cancer, like if HER2 is positive, we can use trastuzumab in combination with a non-anthracycline-based chemotherapy. But again, the benefit is not as significant as seen in a breast cancer. The benefit is actually around 3 months. So this is the only HER2-based therapy that has been approved and used in HER2-positive breast cancer. All the
Stomach
other
cancer.
Stomach cancer. All the other HER2 inhibitors like lapatinib, the TDM1, trastuzumab, emtansine has been a complete negative study. And in even early stage stomach cancer, especially the HER2 positive, they have tried adjuvant lapatinib. So at the moment, the study was a negative study. So the indication is advanced.
So what I can assume is from your talk is that it is not going to be of great benefit in stomach cancer.
It is a 3-month benefit, 3-month improvement in the overall survival.
In metastatic,
metastatic.
In locally advanced,
Which is,
there is no role for. In locally advanced, as
early
an
stage,
adjuvant,
no. Non-metastatic, there is no role of anti-HER2 therapy.
Yeah. Just one more question to Dr. Manikandan or Dr. Rajiv. MSI positivity or MSI high, what is the current thought and current situation?
So Ram cleverly did not discuss stage 4 cancer because we will hold the limelight. So, so if it is MSI, so if you have a stage 4 or advanced gastric cancer, we should be doing 3 markers. That should be HER2, that's MSI testing, and also PDL1 status. Now, if you have MSI high, that was a tissue agnostic approval where irrespective of the tumor that we are dealing with, if it is MSI high or dMMR status, then immunotherapy in the form of pembrolizumab will work, and there is significant improvement in overall survival. So if you have a MSI high gastric tumor, then it is a second-line approval as a single agent after chemotherapy to use immunotherapy. And if it is PDL1 positive, that is called the combined positive score, CPS score is more than 5, then again it is an approval to use immunotherapy in second line or third line. To add to what Dr.
The cost of the immunotherapy, approximate cost of the
immunotherapy. We will leave aside the cost.
For my own interest, I would like to.
So monthly it will cost approximately 2 lakhs of rupees. So you
Dr.
should be giving it at least for 6 months.
Would not be able to afford it. That's the problem.
Just to add, sir, about the HER2 positive also, today we have got the approval from Japan for an antibody drug conjugate called trastuzumab deruxtecan. So that is a 4th line approval. So we are looking in a stomach cancer where we used to tell this dismal prognosis. Now we are looking at a 4th line approval in HER2 positive, where it is a antibody drug conjugate, trastuzumab combined with a chemotherapeutic agent, which has worked very well in 4th line. So we have options in advanced cancers, which is really exciting and hopefully will improve survival of our patients.
Just to add one more point to what Dr. Rajiv had told, apart from the 3 markers, the current NCCN 2020 has added one more marker also to be done in advanced stomach cancers. That is actually NTRK mutations. So these are all uncommon mutations that can occur in gastric cancer. But the main difference is, like, if you take all systemic therapy, chemotherapy, or trastuzumab-based chemotherapy or immunotherapy, the responses may be around 20 to 30%. But if the patient has got this NTRK mutation, we have a specific tumor agnostic approval, 2 drugs, larotrectinib and entrectinib. The responses can be as high as 70 to 80%. And the other advantage is, for patients who achieve a response, the response is very durable, close to around 3 years. So, I mean, we keep evolving by taking small subsets in this advanced stomach cancers, and they may have some targeted therapies, and they may come out as a good subset among the advanced stomach cancers.
And to add to Dr. Inian's question, the MAGIC trial group, they retrospectively looked at the outcomes of patients with respect to MSI status. And they found that dMMR or deficient MMR or MSI high actually did poorly when they were given neo-adjuvant treatment. So I think that is something that is going to come up in the near future, choosing neo-adjuvant treatment based on MSI status. Yeah. So I think thank you all once again very much for this lively and interesting discussion. I hope the students and the younger surgeons have realized that the era where surgery alone used to be the treatment for gastric cancer is long gone. And now we need to add some form of adjuvant or perioperative treatment for most of these patients with locally advanced gastric cancers. Thank you.
Thank you. Thank you, Dr.
Thank you.
Dr. Ramesh Adnari and the other panelists for excellent and vivid discussion about the management of advanced gastric cancer. Dr. Ramakrishnan, shall we go through some questions from the chat box?
Sure.
This is to Dr. Raju. What is your opinion on total neo-adjuvant therapy for gastric cancer?
Yeah, so as I think Dr. Manikandan had already answered, so as of now, the approval is for perioperative, that is 4 cycles before and 4 cycles after. But as in many other solid tumors, people are switching over to total neoadjuvant therapy. That means you finish all your planned 6 cycles of or 8 cycles and then operate. As of now, it is not the standard because we don't have enough evidence for approval, but that is one thing that trials are looking into.
Just to add one more point, like after 3 or 4 cycles, if the surgeon feels that like if they go, it may be probably inoperable, then that may be a case that we can actually complete 3 more cycles and then reassess for surgery.
Okay, and Dr. Ravi Shankar is asking, is proximal tumors responding better than distal tumors to neoadjuvant chemotherapy?
I don't think we have enough data for that. See, most of the adjuvant or neoadjuvant trials have a mix of both proximal as well as distal. Some of them, I think, have a higher proportion of proximal tumors. Some of them have a higher proportion of distal tumors. So I don't think there is a clear-cut answer to that question. Even though the preference, like Dr. Inian and others mentioned, the preference is towards neoadjuvant chemotherapy in proximal tumors.
And this is question to Ramakrishnan, to you. Is the difference in tolerability due to difference in the regimen used? The periop regimens used in trials are not they more toxic than their counterparts in the adjuvant trials? What is your opinion?
I think more than my opinion, it's the medical oncologists who are more qualified to answer that. I can only say that our experience with FLOT has not been so good. Manikandan would also support that. We have had quite a lot of side effects with patients on the FLOT regimen. But I would leave the floor to the medical oncologist to respond.
Coming from Dr. Raju or Dr. Manikandan?
I want to just have make a comment.
Yes, sir.
I think the reason why more neoadjuvant is given for esophagogastric and junctional tumors compared to distal tumors is that most surgeons are happy to operate on distal tumors. There are very few surgeons who like to operate on esophagogastric tumors. Most general surgeons, even senior surgeons, would be hesitant because to do a good surgery, you may need to open the chest and you may need to do a wide resection of the diaphragmatic hiatus along with the tumor, which they are not comfortable in doing, and then to do an anastomosis between the esophagus and the jejunum inside the chest below the arch of aorta. There's a reluctance for most surgeons to operate. So they would rather hand it over for a neoadjuvant and then wait and see what happens. So I think that this is one reason, at least in India, that I see this difference that distal tumors are more readily operated upon because they feel if nothing else will do at least GJ or a feeding agenosmia and come out.
And Dr. Ravi Shankar is asking, do the neoadjuvant chemotherapy have the role in pancreatic involvement where the shrinkage for conversion to operability is a goal?
You see, if I can answer that, one of the golden principles in oncology, in cancer surgery, is the extent of your resection is not going to be changed by the neoadjuvant treatment. If the tumor were infiltrating the pancreas upfront, by giving neoadjuvant treatment, you cannot get away with anything less than a pancreatectomy if you actually want to achieve an R0 resection. There are instances where after opening, you may find that the tumor is away from the pancreas. But in these sort of situations, it is not the neoadjuvant chemotherapy that has caused that. Probably it is the CT, you are unable to identify actual pancreatic infiltration or not. So this is the golden rule in cancer surgery.
But Rama, don't you think that in the last 10 years, this opinion has changed? That we used to say that the resection margins should be the same as the pre-neoadjuvant. But rectal cancer at least is one place where we see that there is something called downstaging and people who are candidates for borderline APRs become candidates for low or ultra low anti-resection. So there is
true, sir. But what I'm trying to say is, in rectal cancer, the type of surgery APR versus LAR, that is a different issue. I'm not talking about the shrinkage of the distal margin. I'm talking about a T4V tumor where there is adjacent organ involvement. You need to remove that adjacent organ regardless of the response.
I agree with you.
Yeah.
But what I think
Having
is that
said that,
the idea
having said that, what we have commonly seen after such multivisceral resections is pathologically the adjacent organ that you have involved, that you have removed, is rarely involved. So it is still a T3 or a T4A. It does not become a T4B. But there is no way of knowing that at the time of surgery. If you find that the organ, the tumor is adherent to an adjacent organ, I wouldn't want to dissect between the two and create a plane where none exists. So I would be more comfortable in removing the adjacent organ if I feel it is a safe thing to do. I don't practice doing a pancreaticoduodenectomy for a distal tumor of the pancreas, of the stomach. And even if I have given neoadjuvant chemotherapy, I would not change the plan of surgery.
I agree with that. I totally agree with that point. I don't do it for stomach CA. Yeah.
And one more question from Dr. Maurai. Do we change chemotherapy regimen if after neoadjuvant chemotherapy, the pathological staging is same as clinical?
I think this point has already been discussed. There is no role at the moment for changing the chemotherapy from what was initially planned.
Okay. Once again, I thank the panelists and as the moderator for excellent discussion and as well as vivid discussion about the advanced gastric cancer. Thank you once again. And since we are running short of time, I request the Secretary of Indian Association of Surgical Oncology, Dr. Sharath Desai, to give his closing comments.
Thank you, guys. Thank you, Chennai ASI chapter, city chapter. I think Dr. Ramakrishnan did a great job, and he called the shots. The final bottom line is that today onco surgery is not a lone wolf treatment. It is a teamwork. It is a total teamwork, and we cannot afford to practice alone. And that is the basic thing in oncology which is coming now, whether it's in a small place or in a big place. The whole of the session was very well managed. We started with the very big basic fundamentals. The fundamentals we began with the genetics, which was very well talked by Dr. Piraman. He emphasized the basic etiology of gastric cancer, which is now being understood better. We also had excellent talk on the endoscopy part, which is again an evolving technology. We can start managing early cancers as they will be detected more and more often in the future. And on the other side, endoscopy is going to be rivaled by laparoscopy because there are further technology advances in laparoscopy also. It is very nice that Chennai has taken such a lead in discussing this whole topic of gastric cancer. Though we all say it's the incidence is decreasing, that may not be really so. We do not know the statistics of our country very well, because it may be also because many surgeons are coming and all that, and our statistics is not really well maintained. But soon, with the introduction of many schemes and all that all over the country, I think we'll be getting better statistics soon and understanding our cancer therapeutics better. As it has been emphasized, I think radicality of remains the basic thing in stomach cancer. Surgery still remains, we have to be radical there compared to all other organs, wherein surgery has becoming less and less radical. And chemoradiation therapy has taken a bigger role. But then chemotherapies are also coming up with a good score, good backup. I especially thank Dr. Kanagavel, Dr. Kannan, and all the office bearers of the Chennai city chapter who have associated with the ISO. I think we will be glad to associate with further webinars in the future. And it was very enthusiastic and interesting participation from all of you. And I appreciate the whole thing a lot. It is in the interest of both the societies that we go on keeping updated with cancers. And we really had a great session. In fact, it was very lively and very enthusiastic, and we enjoyed it a lot. And it was very, very up to date. Thank you all for the great meeting.
Thank you, sir. Thank you for your kind words. Now I finally request Dr. Kanagavel, Chairman, Chennai City ASI, to give the vote of thanks.
Thank you, Kannan and Pandey Raja. In fact, you made our day today. I thank the President, Dr. Sir Arnab Gupta of IASO, Dr. Sharad Desai, Secretary IASO, and the entire EC members who were there most of the time with us of IASO. And I thank my colleagues, Professor Uttakumar Sir, Professor Dr. Kannan Sir, Treasurer, and all the faculty, especially Sudipta and Pandey Raja, who have contributed directly to this program. And I thank all the participants in the Zoom and in the YouTube for staying and keeping our energy levels up and keeping the discussions going on for on and on. I think probably this content is worth a couple of days conference. We try to condense it. Maybe there's a lesson we learned. Maybe we should take it little lighter rather than touching upon everything else. Because I at the end, I felt only the panel discussion could have been the content for the whole program. But then no, like many areas we were able to touch today. And to put on record, I thank Professor Piramanayagam to talk about etiology, Zahir to talk about endotherapy, Dr. P.K. Reddy on GIST, Professor Arnab on open gastrectomy D2, Sudipta on tailoring radicality, and Dr. Tabesh Chala on complications of gastric surgery. And of course, a very, very brilliant panel done by Dr. A.S. Ramakrishnan sir from the Cancer Institute. And the panelists, Dr. Ramesh Adnari, Dr. Vikas, Dr. Inian, Dr. Rajiv, and Dr. Manikandan. And at least I've taken the liberty on most of you by just leaving a message for acceptance as a faculty. And all of you have been very kind to immediately accept in spite of our difficulties and shortcomings in doing it in an online platform. I think I should thank my broadband and the service providers for a flawless connectivity, because I do it from my home and I have the YouTube up and Zoom up and running for the past 6.5 7 hours. And I think I thank the service providers for giving a flawless opportunity to run these type of long programs. And for your information, these things are going to be permanently available in the archives of the YouTube channel of the Chennai City ASI branch. Whoever as a student wants to revise before the exam are welcome to just quickly run through these lectures. I'm sure the panel will definitely open up a lot of your thoughts and clarity on your focus of treating the patients with gastric cancer. So with that few words, I thank once again ISO for shortly accepting our request to collaborate programs. And I also should put on record, we have other forthcoming exciting programs coming up. We have an exclusive full day program on management of venous thromboembolisms. Of course, it should cover the entire spectrum of thromboembolism. It is done in association with the Vascular Society of India and the Indian Association of Endovascular Radiology. So we are going to have it on 10th. And then subsequently at the end of the month, we are going to have the combined meeting of the ASI Chennai City branch with the Breast Surgery Society of India. Again, Dr. Somashekar and Dr. Jitendra Sarkar has agreed to do that. Apart from that, we'll have standalone orations coming up. Together, we can do a lot of exciting academics, and we look forward to seeing you more often. Thank you so much. It's my pleasure to host you. Thank you especially to Kannan and Dr. Pandey Raja for convening this program. And also put on record, thanks to Dr. Ebenesh Bensam for inaugurating the program, our TNASA chairman. And of course, we are ever indebted to ISO, and we look forward for more academic collaborations. Thank you so much. So with the permission of the faculty and the students, I'm stopping the